प्रमदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीप नमोऽस्तु ते
I would like to take this opportunity to welcome all the distinguished guests we have here today at the Perinatology Conference 2025. Please give a loud round of applause for this conference to start. Before we get started with the inauguration of this wonderful conference, we will get started with a panel first. Let's fill our minds before we fill our souls. Now, to truly start,
Good morning, esteemed delegates, respected faculty, and honored guests. I'm Lakshmi, and it's truly a privilege to stand before so many pioneers and future leaders in perinatology. Today marks a unique occasion where minds unite to uplift maternal and neonatal care, bridge specialties, and spark new ideas in our field.
and I'm Navya. A heartfelt welcome from my side as well. Whether you're joining us as a seasoned educator, a burgeoning resident, or an inquisitive researcher, this conference is about shared knowledge, collaboration, and collective growth. Over the next 2 days, we have an inspiring lineup of case based discussions, panel debates, and networking opportunities, all aimed at advancing perinatal health for our communities.
Each session has been crafted to prompt reflection, challenge assumptions, and encourage open dialogue.
With that, I invite upon Dr. Shubhashekar Reddy, our lead moderator for the day, to introduce the first panel.
We have our obstetricians, Dr. Vijay Kumar, Professor and HOD, B.R. Ambedkar Medical College, Bangalore, Dr. Lipakshi, BG, Professor and HOD, SIMS, Shimoga, Dr. Sudha P. Vati, Professor and HOD, Akash Medical College, Bangalore. We have our neonatologists, Dr. Abhishek S., Consultant Neonatologist, Ovum Hospital, Hoskote, Dr. Ankur Rajvanshi, Consultant Neonatologist, Cloud9 Hospital, Whitefield, Dr. Ravi Kiran S., Consultant Neonatologist, Sakra World Hospital, Bangalore, Dr. Sriram Bonu, Assistant Professor and Neonatology at our very own Vaidehi Institute of Medical Sciences and Research Center, Bangalore.
Guests, this is our first panel for the day. I expect some energy from you. Can we have a loud round of applause for all these experienced guests we have here on stage? For our imaging and monitoring perspectives, we have Dr. Dibakar, Professor of Radiology at our very own Vaidehi Institute of Medical Sciences, to shed light on the role of ultrasound here, and Dr. Mahendra G., Professor and Head of Department at Adi Chunchandgiri Medical College, Mandya, to elaborate on cardiotocography in this clinical scenario. For this session's super moderation, we have Dr. Arvind Shenoy, Consultant Neonatologist at Rainbow Hospital, and Dr. Praveena Shenoy, Consultant Obstetrician at Rainbow Hospital, as well as our obstetrician. We'll open the floor for audience questions and reflections after the panel. Over to you, sir.
not getting display. Okay. Welcome one and all, madam. What a platform, madam. This is the platform where the obstetricians, radiologists, and the pediatrists, NICUs, neonatologists, and the PGs are there sitting in one platform to discuss about certain issues is something a very great platform to consider. Because this is how the platform should arise, and this is where the consensus will be formed. And welcome all the delegates. And you are all one of the super specialists, and you are being very well trained, and you are been training the PGs. So we can get lot and lot information with these dias, and then we can get some consensus statements here. Let us discuss about the first clinical scenario. The clinical scenario like this. Overall, the sessions has been divided in such a way that the first clinical discussion will be on the gestational diabetes, second will be on the sepsis, third will be on the acute hypoxia, and fourth will be on chronic hypoxia, and last will be the dilemmas in the perinatal medicine. And the first clinical scenario that we are going to discuss will be the GDM related issues, and what are the case scenarios, GDM, and what happens multiple ways in utero, how to identify the baby in utero and ex utero, what is going to happen. And these all things will be considered now, and the radiologically SARS are there, and he will give us in the input. And first clinical case scenario is this, that a 36-week pregnant woman with gestational diabetes, previously requiring very high dose of insulin therapy, has shown a sudden normalization of the blood sugar levels over the past 2 days, and that is without insulin. And she believes her diet modifications are responsible and is pleased with her progress. However, her obstetrician and the perinatologists are concerned and refers her for the prenatal counseling and fetal assessment. And this is the scenario that has happening. So as an introduction, first the first few slides we will take up as introduction, followed by that you need to give your inputs. And we have divided panelist, obstetrician, and the pediatrics and the radiologist. As this is the first few introduction slides only. The rules of the life, as what we discuss about because every case scenario, we will be discussing the same thing. How the baby in utero is getting adapted, what is the competition, what is the chaos that has happened. Any organism or any person on the survival of this earth should have these things, because they should adapt. The first rule of the life is an adaptation. There should be high sugars, low sugars, there will be infection, there will be low blood flow, high blood flow, whatever the changes are happening, how the baby is getting adapted. That adaptation process we will be understanding through different ways, clinically and radiologically. What is the adaptation that is happening for this baby who is getting high dose of insulin, glucose, and these things that will be discussed. So this baby has to adapt. In order to survive, the rule of the life is adaptation. And followed by that, obviously there will be competition between the organisms, and humans to humans, organisms to organisms, humans to organisms, all these things will be happening, because anyone has to overcome this competition, and then only they can survive. And chaos, certain times there will be chaos. Suppose here there is some chaos, suddenly there is a decrease. And certain times like even the dinosaurs, suddenly they have evaporated. All that within 40 minutes the dinosaurs on the earth has been eradicated. There is some chaos happened. So after the chaos, some other organism entered into this world. So in order to survive on this earth, the first rule of the life is an adaptation, followed by there is to be some competition that's happening, overcome the competition, and the chaos. You should sustain that chaos. And how we have been considering, because so that the few slides we will be considering is this mother, and with these explanations that we can come to little closer to the explanations. We consider placenta as an end organ, absolutely the end organ. What are the end organs? Like adrenals, heart, brain, and the kidneys, and the placenta. Placenta is considered as an end organ. When we speak about the mother, we will be speaking about the placental changes. Followed by that, there will be other system is going on. But because the one end organ change will be reflected some other end organs. When there is certain wrong going on or certain damage is happening to the placenta, equally the other end organs will be suffering. The other end organs are the kidneys, brain, and these things will be under the suffering. How we can assess through that thing, where the end organs are under the suffering, where the end organs are under the compromise. how we can analyze, because one end we are seeing from the mother side the placenta, and others are supporting us, like kidneys are there, adrenals are there, brain is there. In preeclampsia, what is happening to the other end organ? Because of the end organs only, there is some suffering happening, and they are throwing the fits or anything. So how? Then we discussed from the mother, there is a placenta as an end organ, and followed by that the fetus thing is. And further all the discussions, we will be showing these slides. That is the first introduction slides we are showing, because these slides will be repeated again and again. What adaptation is happening in us. This is what the systolic pressure and the diastolic pressure. The most important thing is the mean arterial blood pressure. To have end organ perfusion, that the most important thing is the mean arterial pressure. What is mean arterial pressure is the thing. This is obviously the flow of oxygen to the tissues. Fetal circulation. What is the modification in the fetal circulation in the fetal stage? How the fetus, because this is one we are going to discuss again and again, how these 2,3-DPG values are differing in the insulin-mediated diabetes and also in the baby. What is the alteration that is happening for the oxygen delivery? So obviously, when the end organ has to be perfused, the mean arterial blood pressure is something like, it is 1/3 of the systolic plus 2/3 of the diastolic. Why we are saying is why the diastolic blood pressure is so important in maintaining the mean arterial blood pressure is because of this. Mean arterial blood pressure, there is 1/3 of the systolic plus 2/3 is the diastolic blood pressure. When we say absent diastolic blood flow, reversal diastolic blood flow, we will be discussing about the end organ perfusion through this mechanism. What happened with the absence of the end diastolic blood flow? How the end organs are suffering? What happened to the reversal of the diastolic blood flow? What is that suffering? How the mean arterial blood pressure has decreased? And so we'll be discussing. And this is the introduction slide. And obviously, again, everywhere we'll be discussing these rules. How the baby got adapted, what is the competition that the baby overcame, what has chaos, and how the baby came out that chaos. With these things, we will be going into the discussions. Sir, here is the first discussion, sir. Dr. Vijay Kumar. Slide. When should we deliver this baby? When there is if there is an association of falling insulin requirements, when should we deliver? How we can come to a conclusion? This is what we can explain.
Good morning to all the panelists. I thank the organizing team for giving this opportunity. So the question is, the pregnant woman, at what gestational age she is?
36 weeks. Sir.
36 weeks. She has come with the falling insulin requirement. So is it a good sign or bad sign? So that we need to know. So with the adequate knowledge, we can understand that if the pregnant woman is having a regular dose and these dose requirement suddenly falls, it's an alarming sign. So the reason being that the studies have shown that if the requirement falls more than 15%, then definitely the placental abnormality will be there, and definitely there will be associated problems like the FGR, and even in some cases the sudden fetal death can happen. So in this scenario, since she has already at 36 weeks of gestation, with the vast improvement in the field of neonatology, I think this will be an ideal time for to intervene. Before we intervene, we can go through some of the investigations, especially the Doppler study of the fetal vessels, especially the umbilical artery and the ductus venosus, to understand how urgent is the intervention required.
Yes, sir. Borderline hypertension is there, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. And sir, if not delivered, what could happen?
Yeah. So these studies have shown that there will be increased chances of the preeclampsia, or there can be aggravation of the preeclampsia if there is already pre-existing preeclampsia. That is one. And second thing is the FGR and the sudden fetal death. So these are some of the concerned things for the obstetricians to intervene.
Yes, sir. As we explained again in the first slide, when the one end organ is under suffering, that like placenta is under suffering, the other end organs will be under the suffering. The other end organs are the kidneys, adrenals, and the brain are under the same position. So whenever this has been nearly, we have collected 23 such scenarios, ma'am. And even when we have last time conducted in the Shimoga also, few have given an input. When that has been not delivered, they have thrown fits. After Srusti, I think so. They have given information saying that there is if there is not delivered at that particular point of, they have landed in eclampsia state. This is where, but what has happened here in that thing, they have modestly elevated creatinine, they have mentioned. Modestly elevated creatinine in most of them. Because what amount of the creatinine rise is considered as a renal failure or renal compromise in the pregnancy? It's somewhere, if someone can give an input, we can take it up now. Because in the studies, most of that they are showing at a 0.15 rise in the creatinine is under the compromise, kidneys are under compromise. If one lab gives 0.5 and other lab gives as 0.7 or 0.8, there is under the compromise only. That's where we are getting the trouble. Other end organ renal is under actually suffering. If there is any input from others, we can collect it now. Because in this pregnant lady, not madam. Yes. The other way we are asking is, in what amount of the rise of creatinine, why the creatinine is not rising in the renal failure in the pregnant women when the renals are under the compromise?
If you are monitoring her blood pressure
Yes, ma'am.
and you are monitoring the fetus intensively, I don't think so it's going to be a very alarming situation. We have to keep a watch on the baby and the mother. A small thing that when there is a falling inch, as a practicing obstetrician,
Yes, ma'am.
we see GDM in about 25% of our pregnant women, and we face this very important. Small things, but history is so very important. Falling insulin levels, is she monitoring with the proper glucometer? We had one. The battery was going down and the levels were coming down, and we just changed it. So always confirm with the lab findings.
Yes,
It's a very, very important thing. Second, is she intake has come down, because lot of women at this stage develop gastritis or they have had gastroenteritis. The intake has come down. So it could be a temporary thing. So it's very, very important that we sort of look at other things also before we sort of deliver this baby. And with the, like ma'am said, creatinine levels would definitely go up if she has gone into like severe pre-eclampsia. That is definitely a reason to this. Otherwise, we could just monitor her and see how things are.
Yeah, I just want to tell one thing. As Dr. Rajini madam said, there are two clinical, the biochemical markers what we check, usually the obstetricians. One is the creatinine, as you mentioned. The another one is the serum uric acid.
Uric acid.
We generally believe that the creatinine is the long-term pathology, whereas the uric acid is the acute insult which will lead to the renal damage, leading to the rise in uric acid, will be well correlated with the FGR and the sudden fetal death. So whenever the patient is come with the preeclampsia or even for evaluation for the gestational diabetes mellitus, we concentrate on the uric acid as well as the creatinine. But creatinine is the chronic biochemical marker. Uric acid will be the acute.
Thank you, sir. Madam Dr. Lepakshi. Dr. Lepakshi, sir. What are the clinical implications of the insulin therapy in pregnancy, sir? I will be showing your slides, sir.
Good morning to one and all who are present here. I thank the organizers for giving me an opportunity to participate in this Perinatology conference. Basically, when patient, usually it's, we call them GDM ones as they are followed up during antenatal period, and after 20 weeks, we initially start them on this meal plan that is medical nutrition therapy. And later on, when we keep doing blood sugars once in 2 weeks, once we have this target glucose levels, wherein if it is
Check.
more than when it is
Help. Check. Rest.
we put them on insulin. Before that, the concern here was that there's a falling insulin requirement. We think about fetal placental vascular dysfunction. We try to search for the various obstetric complications where PIH is the commonest, where almost 12%, and we have small for growth, small for gestational age, stillbirths, and preterm deliveries, and placental abruption. We do come across in this falling insulin requirements. So we investigate. We try to find out whether the baby is compromised or there is any impending IOD or an IOD. Because this falling, it really, clinician has to become alert. So we search for it, and then we get an ultrasound done. We have a radiologist who does even the Dopplers. In case if it is a compromised baby, then we have to plan for the removal, because the placenta is the, removal of the placenta is the main treatment for preeclampsia. So we plan for a section or a vaginal delivery. So we're coming to the insulin part. We have this, the day when we plan for inductions, we keep the morning dose of insulin skipped, and we start the normal saline, and we have the blood glucose levels done by the glucometers to adjust the insulin and dextrose. Every hour it is done. So we start a continuous insulin IV infusion drip, and this is how we go about. So one unit per hour or 1.5, depending on the blood sugars. Whether it's less than 100, no insulin is required. But when it is 100 to 140, we put at 1 unit per hour, wherein we have 4 units of insulin in the 5% dextrose. So likewise, 140 to 180, we have 1.5 units per hour, and 180. The protocol is as here. And of course, we also look for whether patient is going for ketoacidosis. So accordingly, we have to plan up the treatment. And we have even the this thing, weight dosage. Next slide. Yeah. Actually, human insulin is very ideal because it's the first line of treatment, insulin. Having a standard care and good glycemic, we can achieve good glycemic control. Whenever we have good glycemic control, we plan for deliveries between 38 and 39 weeks. So the long actings are not preferred in pregnancy. We go in for a rapid acting and intermediate acting. So we start around 2 to 4 units, 30 minutes prior to breakfast. And then 2 hours, if it's good control, we do repeat a PPBG, that is postprandial blood sugars. Target control should be less than 120. So then we can continue the same dose or increase by 2 to 4 units. If it crosses around 16 units, we divide the dose 2/3 in the morning and 1/3 in the night, and try to achieve the postprandials less than 120. And we have even the weight-based dosing also. This is how it goes, trimester-wise, 0.7 in the initial trimester days, and then later on it goes up to 0.9 to 1 unit per kg. So this is how it is.
Yes, sir. Any inputs, sir? From some babies will be bigger. Some placentas will be bigger. Some other babies will be normal. Some other babies will be with that thing. What happens if there is an increased insulin given or decreased insulin given for that mother?
So neither hypoglycemia or hyperglycemia or hypoglycemia is good for the baby. And whenever insulin is given, what happens is it causes hyperinsulinemia in the baby and hyperglycemia in the baby. And also there's another one effect where the insulin causes less of dissociation of the oxygen from the red cell. So there are chances of going in for hypoxia, and sometimes baby can die in utero. And also because of the hyperinsulinemia and hyperglycemia, the baby, there's the deposition of adipose tissue in the in the shoulders, and except the brain, elsewhere also they can be deposition of the adipose tissue.
Yes, sir. As you said, when there is an increased insulin given also, that is the chance that there is a
Hello.
there is a chance of the 2,3 DPG or oxygen dissociation curve of the mother is shifted towards the left
Towards
side.
the left, yes, sir.
And that's where again the trouble happens.
Yes, sir. What happens is the two DPGs it's affected, and there's no release of the oxygen from the red cells.
Yes, sir. That itself causing again hypoxia. for the baby.
Hypoxia, and sometimes even leading on to
IUFD.
IUFD.
This is how a proposed thing. Sir, can you briefly explain how the IUFD happens also? This is the fetal circulation or anything. When there is an oxygen dissociation curve will be slightly shifted towards the left side, even in the mother. Under the insulin
Yes.
and the high glucose,
Yes.
this 2,3 DPG curve will be shifted towards the left side, though the mother cannot give the oxygen to the placenta
To
first.
placenta.
Okay.
Yes.
Again, the baby is landing in hypoxia.
Yes, sir.
And followed by that, if these slides you can see, this is how the babies are born. And obviously, and there will be a sudden death. Lack of the substrate is also causing death, and excess of the substrate also causing the death. How this is happening, and why there is a sudden intrauterine fetal death, as you have explained, this is just again I am mentioning in another way, sir.
Yes, sir.
Because there is a fixed oxygen levels for the baby. In the descending aorta, obviously 55.
Yes.
Ascending aorta, ductus venosus 85. And beyond that, the baby can't, they can't support. Suppose there is a substrate of insulin. The baby is getting sugars, baby started producing insulin. Insulin is an anabolic hormone starting building the body. It's just like a building of the body where the substrate, one substrate is high, other substrate is low. Fixed substrate is oxygen. Other substrate glucose is going high. It's like a cement is high, but there are no rods. To certain extent of the building that can support. After that, it will be building up. It can't support. It will collapse. And
Yes.
that's where the intrauterine fetal death or sudden death happens.
That happens.
Thank you, sir. Thank you very much for that. Coming to the next obstetrician, madam. Sir, from your side, supermarket, sir, you can add some.
That was a very good discussion. 36 weeks, baby will survive, we know that with our good NICU team being there. But like all of you discussed, we have to monitor this baby, see that there are no mishaps. At the same time, if you can buy some time, and of course the role of antenatal steroids also we'll have to discuss. Do you have time to give that so that the neonatal morbidity and mortality will come down?
Surely, ma'am. Thank you, ma'am. And regarding Sudavi part. Madam, role of the placental hormones in insulin resistance during pregnancy and sleep and sugars in pregnancy. How these are affecting these sugars? Kindly explain about the Patterson hypothesis and the extended Patterson hypothesis, madam.
Okay, a very good morning to all of you. Thank you so much for the invite. I go with the first question there. Can I have the first question, please, again? So, role of placental hormones in insulin resistance during pregnancy. That's the first thing. So, I think as physiology has it, there's an innate mechanism which is existing where glucose has to be continuously provided to the growing fetus. And there's a physiological change, the placenta, the end organ, where which is the cause for circulation for the fetus. What we see is, can we have the slide, please? So here the placenta has a big role because it produces certain hormones, which I would be elaborating, and they are sort of a physiological adaptation to ensure adequate nutrient supply to the growing fetus. And they are human placental lactogen. The first, I just try to get a few briefings about each of the hormones because we are always talking HPL and human growth, placental growth hormone and all that. Whatever little literature I could collect here is that the first human placental lactogen is also called as human chorionic somatomammotrophine, and this hormone, very structurally similar to growth hormone, is a major contributor to insulin resistance. What happens is, in the initial periods of gestation, the lipids are going to be accumulated in the pregnant female. And the somatomammotropins, as the the trimester grows off, the placenta ensures more of this HCS or placental lactogen to be increased, and that is going to cause lipolysis. And once these lipolysis happens, this lipid fatty acids, they are going to be the main source of fuel for the mothers. In the process, the glucose which is there is going to be easily available for the growing fetus. So that is a sort of a insulin resistance where the lipid is going to be used because of the HCS, and the free flow of sugars are maintained for the growing fetus. However, if the, okay, we go to the other hormones and finally we'll just conclude how exactly things happen. So so the next one is also the human placental growth hormone, which is also coming in a cyclical episode tonically by the placenta, and it is also having a similar hyperinsulinemia and decreased insulin stimulated glucose uptake by the maternal tissues. The next hormone, we have the progesterone, and these are also going to potentially suppress the insulin signaling pathways. Normally what happens, once the glucose in the circulation, the skeletal muscles, that goes in the it will just get into it because of the existing insulin. However, the estrogens, the high levels of estrogens, the progestrogens, they are suppressing that, the signaling pathways, they make it less sensitive to enhance the accumulation, because all organs will try to catch the glucose, but the situation is such that the glucose remains sort of for the fetus. The next one, cortisols also do the similar story. And can I have the next slide? So in conclusion, when we have, so the increase in these placental leads to the next slide, state of maternal insulin resistance. Finally, we want to conclude, primarily affecting the peripheral tissues like skeletal muscles and adipose tissue, and enhancing the glucose to the fetus. So that is the first part of the question. The next one, the Pedersen's hypothesis, which we always have been talking about. So now we have so much of glucose coming to the baby. If the maternal mother is non-diabetic or a non-GDM, or if she has got good reserves of the pancreas, definitely that will be coped up by excessive insulin, the beta cell function coming on to the, and then it will keep the sugars in a euglycemic state in the mother because of so much of opposing placenta hormones. But as per, if she doesn't have this mechanics, so she goes into a state of a GDM kind of a state, where the Pedersen's hypothesis will come into picture. That was another question, and it is, this hypothesis is from 1954. I was just wondering, it's been 75 years that this hypothesis we've been talking about. So the glucose, excessive glucose, we all know, it easily gets into the placenta, easily gets into the gradient and gets into the fetus, and the fetal pancreas cells, time and again we've been talking about, fetal pancreas gets stimulated, the beta cells increase, the insulin increases. So we have the growth, it's like a growth hormone, and you have a bigger baby with good adiposity, and especially on the shoulders and all. And invariably, what happens to these babies is, when they are in utero, definitely a bigger problem, because they become big, and as we discussed about the shift and hypoxemia. And next thing is, delivery is the issue for us. Normal deliveries, shoulder dystocias, cesarean sections, high rate, increased baby weight. And if you look at the babies come out, the insulin is still higher, and once the baby, the neonate is going to definitely have the hypoglycemic episodes, because it is the, there's no more entry of the nutrition. And later, and when the kids, the neonate grows up, they definitely have a adult onset of diabetes. These are the issues what we are going to have. There is another thing about the extended Pedersen's theory. Only when doctor asked, and he sent us this question, I explored, and this was a new thing to us, that there's something called as glucose steal phenomena. We have seen situations where mother is totally euglycemic, and we see babies are big, there's polyhydramnios, we don't really know what's the reason. Then we, the glucose steal phenomena is a picture here. What happens is, it's not only about the push theory, it is the pull. Whenever there's small amount of hyperglycemia in the mother, and when it is going, initially only the pancreatic hyperplasia happens in the neonate, and thereby this, because of hyperinsulinemia, there's more of a drag from the fetus towards itself, and therefore the mother is appearing euglycemic, however, she may not be. It's a very
Yes,
So
ma'am.
it is an extended pedicine theory. I think he
I
would,
will- I will
yeah,
add
he
one
would
more.
be able to explain. I think I truly try to get it out to you all. Okay, sorry.
It's how sometimes we will be seeing, absolutely we will be finding that the GTT repeatedly twice and thrice we will be doing. We are looking exactly, there is a polyhydramnios, baby looks big, but still we are getting the GTT normal. And we will have a suspicion, sixth sense saying that this is GDM, but we are unable to prove. What is happening, the mechanism is this. This is called as a glucose steal phenomenon. Actually, some amount of the sugar is the baby is getting. The baby should get satisfied there. Unfortunately, they bribe both placenta and the baby is trying to suck the mother's glucose. This is exactly like when there is a tap, the tap water should flow freely from the tank. If you connect one more motor here, absolutely they will suck it up. This baby pancreas is sucking the glucose from the mother, and the mother glucose are showing normal. Every time you do GGT, it is looking normal, but the baby is growing baby. Large placenta, large baby, polyhydramnios, exactly this is a GDM baby. We will be knowing but unable to prove. This is where the glucose steal phenomenon happens.
And in this, I just tried to read a little, and they say you go more stringent, get the glucose. What we want is FBS around 95 or less than 95 and 120. They want us to go to a glucose of 80s and all. I mean, it's a food for thought. I think we need to explore more on this.
Madam, kindly sleep GDM. I will add it.
And another question of sleep duration and
Yes.
blood glucose control. Nowadays, the sleep has become a bigger discussion for all of us. From the younger generation to the oldest, all of us are having a situation where people are sleep deprived, maybe because of their profession or whatever. So what it is seen is that each hour deficient, they've seen 8 hours of sleep. They've done studies and they've seen 8 hours of sleep and 5 hours of sleep in 63 women, and they've found out that each hour deficient of sleep. They have found that there have been a take that the glucose levels can be affected. Basically, when so we can have that slide, sir.
Yes.
So we have the sleep-wake cycle and the insulin. When do they work? When the melatonins work. So if you're going by that, you have a melatonin come into the picture with the sunset and get out of the system with the sunrise. But the insulin start into the system with the sunrise. That means when we start having, this is a variation, this is a slide which is showing. So if you look at this, you can see the black one which is showing that the evenings to the morning you have the melatonin rise and the insulins from morning to the evening side. So it is understood that normally when we are awake and we are going for food, and that's how the insulin keeps coming up and going. But whenever there is a difference or when this is shaken, the whole picture is going to be shaken, because people, they start going where insulins are low, they start eating food, and therefore they can become more hyperglycemic. With all this theory, I mean with all this knowledge into picture, there have been studies where they show that each hour deficient of sleep can make a difference of 6 to 15 milligrams of glucose levels. So when they have studied a set of women sleeping for 8 hours and set of women, this is the study where they have done. So they have studied, compared individuals 7 to 8 hours of sleep at night and who report sleeping of less than 5 hours or less than 6 hours have got a respective 2.51 and 1.66 extra excess of having a chance of abnormal sugar levels. So this is another food for thought, and we need to understand that if we are getting on to our women having a better sleep, maybe it will bring a difference of 15, almost 6 to 20% of sugar levels, which is equivalent to a small dose of glyburide or small dose of metformin being given, and that is another thing.
That's a beautifully explained, ma'am. That because 1 hour of the sleep is equal to 5 mg of the glyburide they have mentioned. See, that's a very important thing. That particularly in Bangalore, where we are damaging the circadian rhythm by ourselves, and we are damaging ourselves, and we are taking the metformin. We are happy to take the metformin rather than to sleep 2 hours extra. That's where the discussion is coming now. You have to sleep for at least, in the prescription also, mandatory thing is the sleep. If the mother is unable to sleep with this particular Bangalore IT culture, if they are working for the foreigners throughout the night and they are taking the metformin, their sugars will not get under the control unless until they sleep. The medicine is the sleep there. What we need to go back again. This is the circadian rhythm that is happening. When the melatonin is there, absolutely these two hormones behave independently, oppositely. When the night happens, the melatonin should come. By that time, you are stimulating the insulin again by eating. This is how the circadian rhythm. But the late night, there will be deep insulin levels completely falls off by 12 to 2. But there we are stimulating again the insulin, and then we are the exactly opposite mechanism works with the melatonin. So we are disturbing the melatonin mechanism there. And melatonin, see how the melatonin is produced. The insulin should fall off. Insulin should fall off, and the melatonin should rise. We are disturbing that. And then we take the medicine. Somehow, if we can go back again, if you stop this thing at night, again go back this, and then there will be a pleasant thing that can happen. And where the madam is pressing is, kindly, if at all you want to maintain the sugars, you have to sleep. That's the problem with each and every one of us. We speak, but we are not healthy. We speak about the health and we are unhealthy. No, that's the truth. No. This has to come into the picture for all the GDM mothers. If the mother comes, if you can sleep only, I can help you. If you can't sleep, how can we help? We can just increase the metformin from 500 to 1 gram, 1 gram to 2 grams. That's it. Now the 2 grams is going. That's how it is happening. Mothers, that too in particular Bangalore. Every alternate is a GDM. Reason is this thing actually. Act of the circadian rhythm is damaging ourselves and then making this. Somehow the prescription should come first sleep. If you can sleep, we can help. Thank you, ma'am. That was such a beautiful video.
Thank you so much. Thank you for the
So next comes the discussion. Sir, Dr. Abhishek sir. He is one person, I know him very well from the long time, and he is the solid pillar of the womb. Sir, kindly explain about the placental hormones, how they will be helpful.
I think the previous speakers have already thrown light about the importance of insulin as an anabolic hormone. Insulin actually is an anabolic hormone on both the placenta and the fetus. Next slide, please. So this slide actually depicts insulin in early pregnancy. The insulin receptors in syncytial trophoblasts are stimulated, so there is more glucose transfer. This more glucose transfer actually positively affects both placental weight and the fetal weight. And what we know is insulin sensitivity normally decreases with gestation. So this is the normal physiology on the left side. On the right side is the disease state. That is, in the disease state, like gestational diabetes mellitus, you have insulin resistance. This more insulin actually will now cause more harm both to the placenta and to the fetus. That is, it will cause both macrosomia and it will end up having a large placenta. Next slide. So this slide will depict at the microscopic level, that is, you have more maternal glucose. There is more glucose transport. This glucose from the placenta is transferred to the fetus. This higher glucose actually will now stimulate your beta cells and will cause higher insulin production. And we all know this stimulation of beta cells, higher insulin, will affect not just glucose metabolism but also the fat metabolism, which can in turn lead to cardiovascular diseases, obesity, and also it will affect your hypothalamic development, causing effects on feeding behavior. This insulin will again cause fetal growth and macrosomia. This insulin will again come back to the placenta and causes increased placental growth and placental angiogenesis. The maternal insulin will again affect the placental growth by increasing the lipid droplets. So maternal insulin will cause increased lipid droplets, while the fetal insulin will cause placental angiogenesis and placental growth. This altogether actually can affect hypothalamic insulin resistance in the fetus, will cause decreased or delayed neuronal proliferation. In the first trimester, it can affect mTOR signaling and can cause lot of cardiovascular defects, while in the late trimester will affect the brain as well. Next slide. So coming to the question or the case scenario, so the falling insulin requirements remember 30 to 25% of pregnancies, that is with GDM, can have falling insulin requirements, especially beyond 34 weeks. So what we have known till now is the placental hormones are decreased. What Sudha madam described, human placental lactogen, which is the predominant one, followed by progesterone, cortisol, leptin, and tumor necrosis factor alpha. These hormones will decrease insulin resistance. Whatever insulin resistance decrease, whatever insulin requirement is decreased is an effect, not the cause here. There is some argument that insulin resistance is decreased probably by decreasing clearance of exogenous insulin or increase endogenous production of insulin in late trimester, but there are conflicting results for it. So the predominant mechanism is decrease in placental hormones, which signals there is placental dysfunction, which again makes us more cautious to evaluate the pregnancy. Probably when to terminate, we need to ask more frequently, and probably we need to monitor more frequently from here. Probably there comes the role of antenatal steroids early here. Next. So there are some studies which is looked into it. This is an Australian cohort published almost a decade back, which has seen that whenever you have falling insulin requirement, there is increased risk of PIH in the mother, increased risk of SGA in the newborn, increased NICU admission, and probably earlier delivery. Next slide. This is another study which also saw that in 157 cohort, so there was falling insulin requirement, there was increased risk of polyhydramnios by almost, I can say, 4 times, NICU admission twice, probably secondary to respiratory distress with no difference in preterm delivery or hypoglycemia. So falling insulin requirement is a concern for neonatologists, probably more NICU admission secondary to respiratory distress.
Excellent, sir. That has been a very good extension of this exhibition, because most of the babies are landing in the NICU. If you can rightly help, because that is what we explained. The adaptation happened. Adaptation is happening from the baby's side, and there is some chaos is happening. At that time, we need to address that issue. Otherwise, this baby is going into IUFT. Thank you, sir. Next speaker, Dr. Ankur, sir. What can be the anticipated neonatal complications, and what can you plan for the neonatal care?
So good morning all. I'm Dr. Ankur. Thank you for giving this opportunity, organizers, and good morning to all the people who are here again. So as we have discussed very nicely, the maternal part of the diabetes, which makes the baby as infant of diabetic mother. The first of all and the foremost thing as a neonatologist, what we are always concerned is infant of diabetic mother always comes with some problems, and it is very difficult to make the parents understand that they can have more complications. So the sensitization is very important in this aspect, that if you are having the diabetes and the more the diabetes is not controlled on metformin or non-insulin, definitely the things are going to be a little bit more chaotic. And we also need to address the baby in a similar way. And this extended Penderson hypothesis explains us in many situations when we have a clear-cut macrosomic baby as per the gestational age of the baby. Many times that baby is preterm, and you have to understand that even though everything was normal, mother is not labeled as infant of diabetic mother, you have more little bit complications wandering around. So the first slide, sir. The first slides here very beautifully depicts whatever has been discussed till now. In that the maternal diabetes still with all the process of maternal fetal hyperglycemia or fetal hyperinsulinemia because of the fetal hyperglycemia and all the complications arising because of this will be maternal diabetes at such alone increasing the risk of abortion or stillbirth. Fetal anomalies will be common in these babies. They will have more of renovascular disease in terms of renal agenesis also, and impaired fetal growth can also be one of the complications. The maternal diabetes leading to fetal hyperinsulinemia will have the complications by the beta cell hyperplasia, very nicely discussed already, leading to a macrosomic baby, which will have more adipose tissue, more of adiposity, more of birth trauma, fractures, and cardiac hypertrophy. Again, the cardiac hypertrophy will be a bit discussed later. It can be ventricular hypertrophy, it can be transient subaortic stenosis. Those things resolve over a period of time, but give us some problem in the acute neonatal period when the baby is born. Neonatal hyperinsulinemia leading to neonatal hypoglycemia once the baby is there with us, leading to jitteriness. Again, fetal hyperinsulinemia leading to increased fetal metabolism. There will be relative hypoxemia or the placenta not providing the things adequately, leading to polycythemia leading to the management of hyperbilirubinemia later, and managing the polycythemia as such. Again, polycythemia can be more associated with breathing difficulties, feeding intolerance, and other things. Lung maturation will be decreased because of the fetal hyperinsulinemia, because it plays a direct role for decreasing the down regulation of the cortisol action, which helps us for the lung maturity. So the lung will behave like as an RDS baby. There can be an associated TTNB also for these babies because of polycythemia and various other factors. And then there will be the parathyroid maturation decreasing, leading to hypocalcemia. Meanwhile, addressing hypomagnesemia also, because if you are not addressing this, your hypocalcemia is not going to get corrected.
Out of these things, very interesting, this relative hypoxia we are saying, because there is a substrate increasing. Glucose is coming, insulin is building the body, but there is a fixed oxygen. That is called as a relative hypoxia.
So again, we have discussed this into metabolic cardiovascular complications. So hypoglycemia, we know that hypoglycemia will be the effect of fetal hyperinsulinemia and abrupt cessation of the glucose which the baby was getting in utero, and we have to manage it accordingly. The onset starts after 1 to 2 hours of birth. There are various regimens suggested for this monitoring, suggesting as 1, 2, 3, 6, and further 6-hourly monitoring of the glucose parameters. And depending on the situation can be more often. Presents with jitteriness, lethargy, poor feeding, apnea, seizures, and we have to do the feeding of these babies adequately, making sure it is properly addressed, because after the delivery sometimes the feeding can be an issue if moreover it is a cesarean section, and monitoring the glucose hourly and IV dextrose if required, or admission to the NICU. Again, hypocalcemia also has to be kept in the mind for these babies. Low parathyroid hormones and high calcitonin is one of the response, and high calcitonin is one of the factors. Hypoparathyroidism is also one of the factor. Usually it starts presenting at 24 to 72 hours after birth is what we know. So that's why your sugar, your calcium check should be done at around, in case of any symptoms arising, not as a regular thing, as symptoms arising at around 48 to 36 to 72 hours as per the needs. Anything less than 1 millimole of ionized calcium will be considered as significant, and you have to address it adequately. The baby can present with irritability, jitteriness, seizures. You have to monitor calcium, treat if total calcium is less than 7 milligram per deciliter, or any symptomatic IV oral calcium needs to be given. Very nicely discussed. Metabolic acidosis is one of the very important factor, as we were discussing the relative hypoxemia, because substrate is more. We have more of polycythemia because of the hypoxemia. Polycythemia causing the sluggish blood flow, decreased oxygen delivery to the end organs, leading to the metabolic acidosis. So you should need to have a high eye on this, and there will be build up accordingly. You will have to address if there is an associated problems like respiratory distress, any other things, poor perfusion. The things have to be done accordingly and managed accordingly as per the symptoms. We don't go with the bicarbonate and all corrections most of the times for these babies, but again it depends on the severity of the problem. In cardiovascular and respiratory, we have complications pertaining to the cardiac, like hypertrophic cardiomyopathy. Again, the mechanism is same, fetal hyperinsulinemia and other things. Congenital heart defects. Moreover, the congenital problems pertaining to the renal, to the brain, to the things will be more happening because of the maternal high glucose levels initially, and more of hypertrophic cardiomyopathy and the other things will be there as a presentation in the later part of the trimester. So more better control will lead to have more better outcome in these things. So again, managing these complications. And again will be the hematological and neurological complications, as we already discussed, like polycythemia, high jaundice levels. In a rare circumstances of seizures due to hypoglycemia and hypocalcemia as the main factor rather than any brain problem as such. And again, you have to address it accordingly, and you need to understand that if the baby is infant of diabetic mother, you can get seizures if these problems are not addressed well in time. But trauma will be there with the brachial plexus injury and other things. So these are some of the things we have discussed here for the baby in case as per the needs of the baby.
Thank you very much. Dr. Ravi Kiran.
Good morning, all the senior neonatologists and obstetricians here. Thanks to Dr. Dinakar for giving the opportunity. For the right or wrong, my slides have not got uploaded, so I'll try to keep it simple.
Sir, immediate and the long-term complications of
My topic was immediate and long-term complications of hypoglycemia. Much of the immediate complications can be summed up as the clinical features which Dr. Ankur just now mentioned. There will be like non-specific features related to immediate neuronal dysfunction, like it's like seizures, lethargy, feeding difficulties, respiratory distress, and other organ systems getting affected in the form of respiratory system, cardiomyopathy, and hepatic dysfunction. And overall, so neonatal hypoglycemia is only one pin in the entire cogwheel of the neonatal care, and a very important pin though. So in itself, it is affected by multiple other things. For example, hypoxia leads to suppression of the insulin-mediated potassium receptor. So the uptake of the potassium itself is reduced, and hence the insulin release is increased. So hypoglycemia is aggravated by hypoxemia. So overall, neonatal care as a whole equally matters, along with the numbers of blood sugar management. And this is very important for short-term management. And when it comes to complications, if the long-term complications are mainly related to severe, depends on whether it's a severe hypoglycemia or recurrent hypoglycemia, or it's a persistent hypoglycemia. If it is severe and recurrent, the main issues that we see will be visuomotor impairment, motor impairment, and learning disabilities even at the age of 10 years. So there are only 2 long-term studies which has documented the proper effects of hypoglycemia for neurodevelopment, and there is a definite evidence of delayed number development and both language development in those who have undergone initial hypoglycemia. So the number of studies are very lacking, but definitely there is evidence of long-term injury because of this. And secondly, persistent hypoglycemia increases the risk of CP, and also the cognitive scores and academic literacy is reduced. When it comes to the complications at the cellular level, this is mainly because of the oxidation damage of the neurons because of lack of insulin, leading to oxidative injury. That is, it leads to oxaloacetate, this leads to increased glutamate mediated neuronal injury and oxidation injury. So at cellular level, we can say it's mainly the oxidative damage that happens, and mainly the one more point that comes to picture is whether it's hypoglycemia is isolated or it's anything associated with underlying syndromes. So that has to be taken into account, because many associated syndromes could be masking underneath, and that could on the long run manifest as neuronal disabilities. And one more point here is the importance of sequential assessment of the high-risk babies over the long run.
Sir, Dr. Sriram, sir, you can add on for that. Thank you, sir. Thank you very much, sir. You have explained beautifully about the hypokalemia, how it is causing the changes.
Yeah, good morning, esteemed faculty, senior members and colleagues. A warm welcome to this conference on behalf of Pediatrics Department. Thank you so much for coming. So what are the immediate complications, immediate outcomes, and long term? So immediate, it may be because of neurogenic features will be there, or neuroglycopenic features. Neurogenic is due to over sympathetic activity. So these features will be irritability, tachycardia, vomiting, sweating. These features will be there. And neuroglycopenic, that means because of less glucose to the neuron cells. It may lead to lethargy, poor feeding, and seizures. In severe cases, severe and prolonged hypoglycemia may lead to cerebral palsy as well. And one more thing I want to add, why the posterior part of the brain, occipital lobe, is involved in neonatal hypoglycemia. Could be first is high metabolic demand, because this posterior part of the brain has visual receptors. These are highly active, metabolically active. They require more glucose. In case of hypoglycemia, there will be depletion of glucose. These cells will get damaged. The second thing is excitotoxic damage, cytotoxic injury. So hypoglycemia may lead to cytotoxic damage, influx of more calcium into the cells, and release of glutamate. This glutamate is excitotoxic injury to the cells, leading to the premature cell death and long-term neurological complications will be there. And third thing will be vulnerability of the posterior part of the brain because of the posterior cerebral circulation is the auto-regulatory mechanism is immature first few months of life. Because of that, anyway glucose is less and auto-regulation also hampered. The third thing is glucose transport and glucose receptors are also affected. That also leads to neuroglycopenic features. And one point I need to add, MRI findings. The typical MRI findings are seen in the posterior part of the brain. Bilateral occipital lobe signal abnormalities will be there. T2 hyperintensities and DW images shows restriction images. That means bright spots we can see on the DW images. And in case of severe and prolonged hypoglycemia, even parietal lobe is also involved. And they will be sparing of deep gray nuclei. If we compare hypoxic injury with hypoglycemic injury, hypoxic ischemic encephalopathy leads to this brain basal ganglia, red nucleus, thalamus will be involved in these conditions. Whereas in case of hypoglycemia, these nuclei will be spared.
Okay. Thank you, sir. Thank you. But hypoglycemia followed by hyperglycemia is the one that is much more dangerous, and this is happening. How can you explain that, sir?
Hyperglycemia causes
followed by hypoglycemia. Suppose there is hypoglycemia, suddenly we try to give the glucose, and then there is sudden rise of the sugar, which is not required at that point of the time to very high sugar. That hypoglycemia followed by hyperglycemia is causing much more damage than the hypoglycemia.
Intraventricular hemorrhages and cerebral bleedings will be there.
Yes, sir. How low is too low is being our favorite. Sir, you can explain how low is too low, that New Zealand thing that study. Sir, you can kindly explain that hypoglycemia followed by hyperglycemia is too dangerous, and then there is a how can we explain that medico-legal issues that is being associated with that, sir?
See, one of the things the child study showed, it taught us three important lessons. The first thing it told us was earlier we used to have different cutoffs for different ages for defining hypoglycemia in babies. So they, as clearly made out in Dr. Sriram's slide, they now said 47 is the cutoff. You have to maintain the blood sugar above 47. Second thing what the child study showed was what you have mentioned, that among the cohort of babies who had hypoglycemia, those babies who had hyperglycemia following the hypoglycemia, their outcomes were worse. So like you said, it seems as though hypoglycemia followed by hyperglycemia is more damaging than hypoglycemia alone. And the third, this study what it showed was, they did what was called as interstitial glucose monitoring, which as many of the adults know, these days adults have implantable electrodes which continuously monitor glucose. So for the first time that was used in neonates. And in that study what they showed was that the interstitial glucose levels in some ways parallel intermittent this thing, but they are not perfectly in cognizance. Meaning, if the baby's blood sugar is low, the interstitial glucose may be low or normal, or even when you correct the low glucose, the interstitial glucose may continue to remain low. So we still don't understand where continuous glucose monitoring for neonates has a role or not. We are still learning that. But what it showed was maintain blood sugar levels above 47, and also that when you have a low sugar level, don't overdo the correction. Bring it to normoglycemia. Don't take it above 180. Don't make it hyperglycemia. The last part is the dangerous part, the medico-legal part. The problem is the medico-legal part of neonatal hypoglycemia has been studied in retrospect, meaning those babies who had severe problems and definitive MRI changes, they were retrospectively found to have very low blood sugar levels. Prospective cohorts like the child's never showed that severe kind of injury. So I think that severe hypoglycemic brain damage is probably a small subset of babies who are prone for it for reasons more than diabetes, meaning maternal diabetes is just one of the risk factors, but probably there are other risk factors where you have severe brain injuries, or the other way to say it is, most babies where the mother has diabetes generally do well if the maternal blood sugars are well controlled and the babies are monitored for hypoglycemia. So actually it's a positive thing. One doesn't have to always worry about medico-legal problems. However, I would like to add one more point with your permission, sir.
Sir, you
that what most we would like all perinatologists to ponder about is, more often than not, infants of diabetic mothers, even if term, are more likely to come to NICU for respiratory distress. In fact, the dictum we teach our juniors is that if a full-term baby is having respiratory distress, make sure you will most probably find that the mother has had diabetes, either overt or undiagnosed. So they come with respiratory distress, and a bad respiratory distress in a full-term baby more often than not is in an IDM than in any other baby. Thank you, sir. Back to you.
Thank you, sir. Thank you very much, sir.
Excellent question, sir. I don't have the answer. The problem with corticosteroids is there is good amount of evidence that you should use it before 34 weeks. 34 to 36 weeks, nobody is sure. If there is a very high risk for RDS, maybe you can use it, maybe you can't. But all of this has to be added with the Swedish cohort. The Swedish cohort clearly showed that antenatal steroid usage is associated with higher incidence of cerebral palsy. So dexamethasone or betamethasone isn't really all that safe as we believed. So one has to use it with a lot of discretion. So I don't have the answer, sir. And as you're very much aware that people few years back even went on to say give near-term babies also. But now those recommendations have been diluted. Elective sections and other things, those have been diluted. Perhaps a little bit of respiratory distress may be better for the brain rather than have steroid-induced brain damage. So I don't think we have the question. Maybe the next conference we'll have more.
GDM, because lung match. If you see the guidelines, no.
That's why I said I don't have the answer, sir. I clearly said I don't have the answer, but the guidelines have been diluted following this Swedish study. The problem is someone later on turns around and said my child got CP because you gave steroid, will put all of us in a dangerous situation. So one has to be very careful and probably weigh the case, as you have rightly said, and based on case-to-case basis maybe use it.
Sir, I can help you in another way.
Pregnancies may not require, but GDM, I think so we should give them.
Yes.
GDM, even though blood sugar rises also, still we give the steroids.
In
But normal baby is better to avoid.
Yes. In another way, we can see at 36 weeks, the placental maturity, sir. Good cotyledon size, good cotyledon size, calcifications are there. We can, or if the placenta is showing 1 to 2 grade and then this is granular, and no calcifications are there, cardinal is not mature, then we can go ahead and
We are not following the placental grading that so Granum score has gone down. We are not seeing the placental grading nowadays. No, madam. Placental grading we are not looking down. We are all seeing the biochemical tests. So as for 34 weeks, less than 34 weeks for any babies, you can still give. Beyond 34 weeks, do not give. But gestational, irrespective of gestation, where gestational diabetes, if you are not given at 34 weeks and she is on treatment, you can still give at 36 weeks. I don't know how many will agree or not.
Madam, just to add, antenatal steroids in late preterm actually is a matter of controversy. As sir rightly said, what we are worried is 34 to 37 weeks, brain maturity is faster. The brain size is only 50% by 34 weeks. By 38 weeks, it's 80%. So what we have seen is whenever you use antenatal steroids in late preterms, the risk of hypoglycemia is more. When hypoglycemia is more, risk of CP is more. Whatever guidelines is there, if you see the latest WHO guidelines, it says you can use only in late preterm, only if you have GDM. Otherwise not.
Yes.
So I'll agree with obstetricians that If you have a GDM above 34 weeks, then only you use it, not otherwise for elective sections, but we don't have any national guidelines for it. So above 34 weeks, probably use in GDM, but monitor for sugars.
Less than 32 weeks. Less than 32 weeks.
Yes, ma'am, definitely above, definitely, madam, below 30 weeks or 32 weeks, it will definitely help. Definitely it will help, madam, below 30 or 32 weeks.
I just
we
had
have
one
that
query.
discussion, ma'am.
We have, we give,
discussion is there.
can I have a
Ah, you can have it.
No, we give steroids, say less than 34 GDM, and we normally tend to increase our insulin dosage. So, because we always see some amount of hypoglycemia with those patients. So, how ideally all of us are doing? I just wanted to have an opinion.
Just GDM is not an indication for steroids unless she is going to deliver in the next 1 week. Now, regarding this case, 36 weeks, if you look at the consensus, current consensus, still 34 weeks universal if you are very sure they are going to deliver in 1 week. Just like that for twins and diabetes is not an indication to give antenatal steroids because it's not going to do any benefit to the mother or baby. It may sort of cause issues later on. But in this case, 36 weeks, the consensus is that you take case to case. All the guidelines, whether it is your FIGO, ACOG, RCOG, everybody says that till 36 weeks you can give depending case to case. They're very clear on that. Before 34, everybody, if they are delivering in the next 1 week, after that, case to case. So this is what is the current consensus.
They label us. They label us.
Sir,
No,
you
no,
are the
what
expert,
ma'am
sir,
is
you
saying
should
is
answer.
true. What happens? It's practically we see.
Sir, can we proceed to next?
So, ma'am, we will like to say, as it is clearly discussed, we do go on the basis of case-to-case basis. Surfactant is a magical drug without no harm. As we work in Cloud9, we don't have any problem of the giving surfactant. But as per the financial part of it is concerned. But as I completely, if there is anything which is going to the respiratory distress and qualifying into the criteria of giving surfactant, the surfactant needs to be given as early as possible. But the mother is not steroided, the baby is getting delivered at 36 to 37 weeks. I will take the baby to the NICU because the baby can have transient tachypnea of newborn, baby can have respiratory distress because of polycythemia. I will not give the surfactant alone. I will have to weigh my things. I have to do the things accordingly, depending on my X-ray, depending on my requirements. I may be wrong, but I can still give surfactant. But it will not be that you will go ahead and give the surfactant.
Sir, can we start? Sir, Dr. Divakar, sir.
Yeah.
Sir, Dr. Divakar, sir.
Yeah.
How can we monitor throughout the pregnancy, throughout the ultrasound, and what way it helps us in analyzing that the baby may be in the relative hypoxia? Because this is the state where the IUF, we are all worried about IUFD or some the damage of the placental dysfunction. Here there is sudden fall. And where there is a relative hypoxia, how can we identify through the ultrasound, or what all the criteria that can be used to see this baby, monitor this baby?
Good morning, everyone. See, ultrasound is inseparable part of management of the any pregnancy. So whether it is monitoring the growth, whether monitoring the amniotic fluid or the lung maturity in terms of with the placental maturation, whether it is correlating or not. Coming to the growth parameters, definitely the diabetic mothers, the baby will be having macrosomia or the effective fetal weight may be around more than 4 kg, or the abdominal circumference is more than 95th percentile, or the even they reduced it to up to 75th percentile in early pregnancy case. So once the baby, we know that it's a large, it is definitely going to have a hemodynamic changes in the fetus, depending upon the whether the baby is in the hypoxic state or not. We take a help of umbilical artery Dopplers, uterine artery Dopplers, and the MCA and the CPR ratios. Later the ductus venous flow and the IVC flows. So coming to the uterine artery Dopplers, definitely they help in the deciding whether the mother is going to have pregnancy-induced hypertension or coexisting with the diabetic and the PIH. So definitely the PI values will be more than 95th percentile mean. PI will be the definite criteria is there. The PI values of more than 95th percentile for any gestational age. So coming to the umbilical artery flow, definitely initially there will be systolic flow as well as the forward diastolic flow will be there. So as the hypoxic sets in, the diastolic flow in the umbilical artery start decreasing because of the placental factors, and the PI values also comes to lesser. So once there is a decrease in the PI values or the decrease in the diastolic flow in the umbilical artery, there is a changes in the cerebral flow. The MCA starts showing there is an increase in the diastolic flow and the PI values start dropping. So there comes the role of cerebral placental ratios in the borderline cases of that one. When we take a cerebral placental ratio, then that more than it is less than 5th centile. So then we say that there is a mild to moderate, there is a hypoxia is already set in. So whether to terminate, based on that one, again we have classified according to IUGRs. There are stage 1, 2, 3, 4 are there according to Barcelona classification of these IUGRs. So in the first stage, there will be definitely there is a increase in the PI values of the uterine arteries, and there may be normal flow in the umbilical arteries. In stage 2, there is definitely there is a decrease in the diastolic flow or the absence of diastolic flow in the umbilical artery and normal flow in the MCA. So in the stage 3, there is a reversal of the diastolic flow in the umbilical artery, and there will be brain sparing effect already set in. So in the stage 4, there is a decrease in the A wave in the ductus venosus or the reversal of A wave in the ductus venosus. So definitely ultrasound Doppler has a crucial role in managing in taking decisions whether to terminate or not. So definitely the Doppler parameters definitely give an insight to go for the delivery or not.
Here,
sir.
The glucose is coming from the mother or placenta, and the glucose has to go under the glucogenesis or anything. And then there is a glucose that is being formed, and that is being deposited, fat is being deposited under the transcutaneous fat tissue. So what we want is here, how we are monitoring this HbA1c from the mother, and what are the changes that is happening in the baby's flow, because the flow is coming from the umbilical vein into the liver, liver is going to the vein, and liver is metabolizing something and then going and depositing in the umbilical. So we can get a clue from here. So subcutaneous fat tissue, what amount of the subcutaneous fat thickness is something alarming, or when there is a flow happening here to the liver, and the liver has certain blood flow which the liver will be mostly utilizing from the ductus venosus or 70 to 80, and 20 will be bypassing. Suppose when there is a relative hypoxia state, this win-win situation happens in the liver, saying that there will be initially or 70 to 30% will be there in the liver blood flow. Mostly liver will be utilizing the umbilical blood flow, or 70%, and 30% will be bypassing. But in case if there is any relative hypoxia, this liver, the bottom line of the fetal liver receives less, and the distribution from the ductus venosus shifts. A 75%, 25% will be shifting to 50-50. This is where we can identify, and there is a subcutaneous fat thickness. If the baby is abdominal circumference, so if there is subcutaneous fat thickness more than 6.5 mm, something alarming. Where the and we can in portal vein, they have noticed portal vein blood flow and correlation with the pH and the HbA1c, sir. That they have correlated. How they will help us, and what will be?
Sir, whenever the ambiguity of whether to early detection of GDM, apart from the biochemical abnormalities, does the ultrasound help in diagnosing these patients? Yeah, definitely. From 24 weeks onwards, we can put these mothers on surveillance based on the early detection of the fetal macrosomia or abdominal wall subcutaneous fat thickness. So some of the criteria are from 2 millimeter thickness to 4, and 8 is the cutoff for between 20 weeks and 30 weeks and more than 30 third trimester. So definitely we do measure these thickness depending upon the case-to-case basis. So regarding the Doppler changes, so as of ISWA guidelines, still maintains these parameters only, the umbilical artery flow, the
portal venous blood flow, and then followed by that the liver blood flow, and changes, sir. What is the change that is happening? How that is being transforming from 75 of the blood flow that is being decreased, and there is a diversion of the blood flow that is happening in the liver, and there is a subcutaneous fat thickness happening.
So the deposition of the subcutaneous fat is a continuous process, sir. So there are definitely cutoff points are there to say that deposition of the subcutaneous fat is just helps us to say that the baby is macrosomic or GDM induced large for the gestational age. So regarding the Doppler changes in the ductus venosus, so once there is a reversal of the flow in the umbilical artery is set in, so we definitely monitor the A wave in the ductus venosus. Either it is absent or it becomes a reversal.
That is under the cardiac compromise, sir. That is
Correct,
the baby
sir.
already established fetal acidosis, and there will be decrease in the A wave, and there will be
So
absence of the wave. By the time
that
the baby demise
itself
happens.
says that there is a impending fetal demise, sir.
Yes, sir.
The moment A wave reversal occurs in the ductus venosus, that says that there is a impending fetal demise and the baby has to be delivered. That's what.
Okay. Thank you, sir. Thank you, Amos.
Thanks.
Dr. Mahendra, sir.
Good morning, sir.
Sir, nice to meet you, sir. Welcome, sir, and kindly add some information about how we can monitor with the CTG, how it helps. CTG.
Sir, actually CTG, it is mainly it's regarding acute hypoxia, sir. We divide it into hypoxemia, hypoxia, anoxia and asphyxia. Actually, so it mainly, it is a determinant of CTG is mainly determinant of acute hypoxia, rather than, as sir said, it is a Doppler and all, they indicate it's a chronic hypoxia. So it indicates the acute hypoxia. So in low risk it has no role, but definitely in a case of in diabetes and preeclampsia, this patient definitely it has a role. In 36 weeks means it has inter-observer variation, and inter-observer variation will be there in CTG reading. So just by looking at single traces, so we cannot take a decision of delivering or we take or means either by normal or by cesarean section. So only it is pathological or there is a variable deceleration, continuous variable deceleration is there, then we can take a decision depending upon the gestational age. As I said, you have to correlate with the Doppler findings with the CTG. CTG mainly depends on acute hypoxia, whether it is impending, it is we need to deliver or we need to wait for some time. We have to concurrently coordinate with the Doppler findings.
Yes, sir. The
Yes, ma'am.
It's only NST is interpretation only for the acute condition. So whenever the beat to beat variability is absent, less than 25 and normally what it should be up to 25. So we suspect either hypoxia, hypoglycemia, abruption, Meconium stain liquor. So these are the things need to be thought whenever beat to beat variability is absent. And late deceleration definitely reflects a hypoxia. Hypoxia with the metabolic changes and needs to be delivered immediately. And early decelerations depends upon the findings. If the findings are just obstetric findings are where the head is at the outlet, it depends upon the vaginal delivery, or if it is high above it's unlikely with the early dips. Early dips always is the below only, +2, +3. So vacuum or forceps is needed. And variable dips, it's a cord compression. What we suspect is a cord compression which is causing the variable dips, either because of the oligohydramnias. So that also need to be delivered by cesarean section. Thank you.
In variable, as you said, ma'am, variable deceleration, we have to correct the underlying pathology. First, you see whether it can be corrected.
Yes, yes,
You can take it. But definitely, as you said, late deceleration is an indication for acute delivery. But in variable deceleration, we need to wait. We can wait
see
and
the cause,
and correct the underlying pathology.
Yes, yes. Thank you.
Sir, anything to be added from your side, sir?
Sir, regarding lung maturity, ma'am, and the placental maturity, there are various studies are there which correlate the grading of the lung maturity
To
with.
ask you one thing,
Yes,
do you do the placental maturity routinely? You tell.
Yes, ma'am. We do
Because
in the
Granum
institution,
score, we used to teach initially the Granum score, stage 4, Garlanding sign, all that we used to teach. But now,
Yeah,
even the reports also are not
ma'am.
interpreting the placental grading.
Yeah, ma'am.
So do you do routinely?
Routinely we do in our hospital, ma'am. Regarding like from 0 to 3 are there, which definitely correlates with the studies correlates with the lung maturity. That LS ratio, it is correlating with that one. Grade 0 is smooth maternal, the fetal part of the placenta is smooth and homogeneously uniform. Basically ultrasound grading, that one. And grade 2 is the smooth indentation in the grade 2, grade 1. Grade 2, there is a definite cartilagen formations, and the maternal side also there will be echogenic lines will be there, and grade 3 is about the calcification.
No, you are giving us the information that it's
but,
correlating with the LS ratio.
Yes, ma'am.
I think so. We will take some interest and do some studies. No, madam.
There are.
No, earlier are there, but we'll continue to do. We'll continue to do.
Even after the delivery, we are observing the placentas, madam. That we are
No,
correlating.
we'll continue to do this. We'll give
Because
to the
observing
PGs.
the placenta gives you much more information.
That will give some idea about the
LS
lung
ratio.
maturity.
No, LS ratio we had to do.
Ma'am,
What maturity?
That's what, ma'am.
What test you want us to do?
Ma'am,
With the
that's
placental
what
grading.
grading of the, it is an indirect sign to say that the lung has matured or not. That's what, ma'am.
Sir, with your permission, may I add some words? Earlier, I fully agree with our madam. Earlier in 90s, late 90s probably, we were very happy and enthusiastic to grade the placenta and correlate with the fetal outcome. However, many studies came into existence telling that the placental grading, though majority of cases it may correlate with the fetal outcome, however, many studies show the fetal hypoxia with absolutely normal placenta grading are 1 or 2. So we have deviated from the placenta grading. We no more recommend from the obstetrician point of view for placenta grading as such. You can say all those things. Grade 3 and all, it shows the placenta is getting aged. It may not be correlating with the fetal outcome. That is number 1, sir. Number 2, madam has aptly addressed the CTG. CTG is a parameter which should be done only in labor, when lady in labor, where there is added stress of the uterine contraction. Now, when patient is not in labor, we use the word NST, non-stress test. Even all these, even auscultation, anything, they have got all the parameters to be discussed, observed of the antenatal field surveillance, starting from the auscultation with a very good, say, a stethoscope. An intelligent person, skilled person can pick up these babies who are at risk. Keeping apart, we go for the biophysical profile, where we use the word loss of fetal tone. Tone is the indicator, red light on there. Number 3, in the heart rate monitoring, as madam rightly told, if there is a loss of feet to feet, beat to beat variability, so earlier it was 5 to 15, now madam extended to 25, agreed. If the loss of beat to beat variability, this shows these are the babies not going to do well and all. Well in advance, before the ultrasound manifestation of all those things. Next core to address is the fetal. Say if at all we have done, say Meconium, there is a already leak. If there is a Meconium stain, that is the third point to be observed. Absence of acceleration may not be significant, whereas presence of acceleration will do add confidence for the fetal well-being. These are apart from the fetal heart rate. A fetal heart rate could be 130 fixed and all, but loss of beat to beat variability. When there is a loss of beat to beat variability, it goes something like a teeter like fetal heart rate pattern. Last one is if possible, if feasible, when ladies in labor, best Supreme Court is go to fetal scalp blood sampling. Even stimulation is low, it may not possible. Fetal scalp stimulation and see the heart rate pattern. That is what is being done many hospitals feasible. But fetal scalp blood pH and lactic acid as a estimation 7.2 below shows acute, and immediately the baby has to be taken out depending upon the situation. This is what I wanted. Thank you for allowing me.
Thank you, sir. Ma'am, we have an extensive discussion on the CTG completely for 1 hour. We have an extensive CTG discussion.
So many neonatologists are there.
we are going to have extensive discussion.
No, I'm not talking about CTG.
Ah.
No, extensive discussion will be there on CTG.
Still, madam has to complete her sentence. It is inevitable abortion, like, has to do it. She has to do.
No,
She
sir.
has to do.
No, sir. Whenever hypoxia
She has to
is
tell,
there,
sir. We have to
really
allow her
no,
to.
hypoxia, whenever we are delivering, we should not keep the pediatrician inside our labor room, sir. Really, as an obstetrician, I really feel, no, because we do so many attempts, sir. We put the vacuum, they will see all that number of attempts. No, but I have experienced.
Madam, that is protocol. They have to do it. But
No,
many
no.
times it is a mother-in-law and daughter-in-law. Always the labor room situation.
baby came
It
out
is
crying
inevitable.
also.
Thank you.
Sir, to compromise only we have made it this, sir. We
No,
have
no,
made
no,
it this
baby
thing
came
compromise.
Here also we don't leave, sir. We are there.
Sir, we have an extensive discussion
Thank
on
you,
CTG,
thank
madam.
you.
1.5 hour.
Thank you.
I have fellowship over the CTG.
I think here we have I think here we have to restrict to the panelists. I think if they have any questions, we can interfere. I think let the panelists answer.
Okay, now the time is come. Thank you very much, sir. Okay, and introduction of all the people, everybody, because today exactly 11:30, some trains are 10:30 train is coming, 10 o'clock train is coming, so they're all coming here. That is the reason I am giving the breakfast little late. Please, everybody, pardon me. Now we will disperse for the breakfast. Okay, 20 minutes time I am requesting, giving you. Please finish the breakfast, come back fast, and we are going to how many you people know Kushi Infertility Center? Dr. Rashmi Yogesh, madam is going to deliver about our infertility things. Then inauguration is there by great our my guru and my mentor, everything, and sir Arvind Shadai sir and Pravina Shanai madam, and with and all the people, everybody together they are going to do the lamp lighting and inauguration of the infertility things, sir. Okay, after the breakfast, then our sessions will go on. And one more thing I am requesting, see, when we did the same program in Andhra Pradesh,
normal, healthy, then we are going
look after,
to
we will look
definitely,
now.
yes.
There is a hypoxia class is there, and there is a sepsis class is there. In that, once again corona will come, once again natural body will also, natural killer cells will come, and at the same time how that corona is affecting the kids, either ADHD or OCD or what is autistic, why it is, that all class will come. We are going to discuss. Can we go for breakfast? Please.
Loud round of applause, please.
Thank you, Dr. Dinakar, for the opportunity. Padava Toro Shri Rama, Padava Toro Shri Rama, Ninna Padava Toro Shri Rama, Ninna Mohana Gunadama, Ninna Mohana Mohana Gunadama, Ninna Mohana Padava Toro Shri Rama, Varaguna Jala Suraguna Lola, Varaguna Jala Suraguna Lola, Karunala Vala Kadali Pala, Karunala Vala Kadali Pala, Padava Toro Shri Rama, Avabhava Pujita Gajavara Palita, Avabhava Pujita Gajavara Palita, Surajana Sevita Trijaga Vandita, Angaja Janaka Vihanga Turanga, Tunga Vihara Shri Ranga Vitala, Padava Toro Shri Rama, Ninna Mohana Gunadama, Ninna Mohana Padava Toro Shri Rama, Shri Rama. Thank you.
That was such a heart-touching performance. Thank you so much, Dr. Chandrakala.
Continuing with our schedule, Dr. Sridhar Venkatesh, Principal and Professor Obstetrics, WIMS and RC, will introduce the conference and unveil the IVF stimulator. An exciting stride forward in medical education and training.
Prestige is yours, sir. Let's have some enthusiasm. Come on.
Good morning and a very warm welcome to all the dignitaries, esteemed faculty, delegates, and all the postgraduates. At the outset, I wish to convey the best wishes of our Honorable Chairperson, Dr. D.A. Kalpaja, and our advisor, Dr. Mahesh Kotapalli, for this rich, informative rendezvous of obstetricians and pediatricians in this conference. Most unique features of this conference being that it is well attended by a number of luminaries in the specialty of obstetrics and pediatrics. Most of them are the senior heads of departments of medical colleges and faculty of other teaching hospitals. The program will have 5 panel discussions which will be chaired by experienced senior faculty from across the state and the esteemed panel sharing knowledge on most important queries related to the topics discussed. The program has drawn vast interest from all across the country with around 150 plus registrations to attend in person. Perinatology conference takes into account the safe medico-legal practices in perinatology and keep practicing obstetricians and pediatricians abreast with all medico-legal issues. The conference also sheds light on controversies in the management of perinatal high-risk factors and complications and lays a foundation for guiding and guidelines to manage such cases. The conference also displays the state-of-the-art IVF simulator, which is an addition to this year's conference on neonatology. Right here in front of you, the entire simulation set has been assembled. IVF simulator devices which are going to be a breakthrough in IVF simulation teaching. There is no way any peer postgraduate student or trainee can have hands-on experience on a live patient. It has to be once and for all. So this is one in such situation where simulation is the best place to learn, make your mistakes, recognize the pitfalls, and to improvise on your techniques. To take you through this IVF simulation lab, we are privileged to have with us today Dr. Rashmi Yogesh, a renowned IVF specialist. She has kindly consented to bring the IVF procedure, highlighting the pitfalls to be avoided during the live procedure. With these few words, I once again welcome every participant to an enriched learning experience over the next 2 days. Thank you. No, sir.
Thank you, Dr. Sridhar. Thank you, Dr. Sridhar. That was truly inspiring.
Now, moving on with our schedule, we are privileged to welcome Dr. Javed Syed, the National Head of Simulation and Training here at VASA, who will share introduction to VASA and its core mission of advancing neonatal simulators and training. Over to you, sir.
Good afternoon all. A warm welcome to VASA, Vaidehi Advanced Simulation Academy. So myself, I am Dr. Javed Syed, National Head at VASA. So I take care into the training and the simulation component of the Vaidehi Medical College. So we are privileged to have all the dignitaries here and the delegates. We warm welcome you to the Vaidehi Advanced Simulation Academy, which is the Southeast Asia's largest simulation center and India's most utilized simulation center. When I say we are India's most utilized simulation center, we have certified more than 28,000 participants as of now, and 24 days of a month is completely blocked, is what we run as of now. So a warm welcome to Vaidehi Advanced Simulation Academy. I have the honor of presenting VASA to you today in a small slide presentation. And it is world's first integrated training academy where we have got a medical museum associated. So I welcome you all to visit our VIDA also, which is an anatomy museum which is situated next to VASA building. When you enter, it is VIDA first and then the VASA. So all the delegates who have not visited VIDA, so I take this opportunity for you to welcome to VIDA also, anatomy museum of one of a kind, and then to VASA. So the people, my staff is available over here with a tag of VASA in their necks. So once in your free time, in the break time, you can just go around, have one of them and tell you to give a tour of VASA, and all are ready to help you out in showcasing what exactly the simulators we have got, how we impact the medical education through the training and the simulation. So this is what we have got. We have got 10 advanced simulation zones. When I meant 10 advanced simulation zones, ICU we have got partitions where my pediatric residents can participate, my OBGY residents can participate, my first year MBBS can participate, my nursing students can participate. It is called the integrated systems which is partitioned. So without a disturbance, without any kind of minor disturbance, you have got simulated atmosphere where everyone can come and participate and enhance their skills. That is how it is been designed. So it can occupy, I mean, any given day, they have got more than 4 debriefing rooms and 1 big lecture hall where more than 300 students can happily accommodate on any given day. And we have conducted multiple national and international conferences here in Vasa. So these are some of the stats what we have got. We have got more than 500 workshops conducted, more than 25,000 students who have been certified in Vasa as of now. So this is how it is, and Vida is a museum what I was showcasing. You can just go and visit Vida. That's how it looks. It is integrated with the advanced technology. And these are the different zones we have got. We have got task training zone, we have got ICUs. So we have got OBGY ward where it is exclusively for maternal and neonatal suits. We have got new IVF simulators which has been in display. So this one of a kind in India what we have got. First in India, first medical college in India to have got a IVF simulators. We have got 4 different models in the IVF simulators. We will give a demo shortly after the inauguration. So it is Hysteroscopy, it is then with the ovum pickup and then the and then the ultrasound. So we got 4 different simulators for this, and where we can train the people of into the IVF education. So we got changing stations for all the students. It is mandatory. So our management was visionary to have this simulation lab where they found that the students should not differentiate saying that this is a simulation lab. So we'll follow all the measures. So for example, you are wearing scrubs, we are wearing Crocs. So Crocs is mandatory, scrubs are mandatory for the students. So students should not differentiate saying that this is just a simulation lab. Just a simulation lab is a word which we don't like. We follow all the norms as if we take it in the hospital so that the seriousness is maintained. So they go in, they change into the scrubs of Vasa, all the valuables of the mobiles are collected over there and they enter the Vasa simulation, where if they are doing the case scenarios as if they are performing in the real in the hospital setups. So we got one apartment simulation. This simulation center is not only for the medical students, it is for the paramedical students, for the nursing graduates also. For example, you have got a paramedical student coming in. So we showcase that there is a pregnant woman or a geriatric case who has collapsed there in the wash area, and how do the paramedics enter it and stabilize the case and load them in the auto loader, and then this case is transferred to the ambulance. We have got a simulated ambulance also down there. So we showcase how do the emergency medicine technician take care in the ambulance part. So stabilization in the ambulance part is taught. So paramedics come there, stabilize the case and load them into the ambulance is what we train. So this is how the the ambulance simulation looks like. So we had the privilege of having a real ambulance, but we being a simulationist, we wanted to design our own ambulance. So we have taken the parameters, measurements, and we have designed ambulance on our own. So when you open the ambulance and see, it looks as if it is a real ambulance. All the monitors are there, portable ventilator, portable defibrillator, all the drugs, right, are there, and we follow the norms of discarding the drugs. Even if it is a simulation, we don't use the drugs which are expired. We make sure that the policy is followed as if it is the real hospital. That is what we train our students on. And you have seen this, and this is the ICU zone. We have got 6 beds of ICU, which will resemble the real ICU setup or the emergency casualty setup. So we can make it the emergency into the ICU, ICU into emergency. We can just replace any modality. So from lowest of the fidelity to the highest of the fidelity, we have got all the mannequins arranged there for our students to perform cases. And every bed has got a partition where there is, without any disturbance, all other students can participate. So we got a maternal and neonatal suit, a very advanced one again. So we can perform from the first stage of the labor to the fetus out. We can simulate a normal labor. We can show our students how to cut, clamp. We can make the delivery a complicated delivery by making it shoulder dystocia and 8 different difficult modalities of normal labor. We can simulate that. In case if the mother is in cardiac arrest and 4 minutes are lapsed and the baby is not coming out, we can show them how to perform a perimortem cesarean and take the baby out. So we are a center where we can run a course called also ALSO, Advanced Life Support in Obstetrics. We run that course. So any of our participants today can circulate this word of mouth that Vasa is open. So we are mainly for Vaidehi students, but we are open for common public and for the people of other medical colleges also. So we are here to run the show for the participants who are coming in. We have got a website, vasa.ac.in. So once you log in that, we have got more than 60 courses where you can enroll and register. So our team will call you out and give the slot, and you can come and enroll for one of our program and get the simulation done. vasa.ac.in is the website where you can go and do. So we got a neonatal suit also. Then the baby who has got problem can be kept here and the neonatal procedures can be run. We run our NRP courses, PALS programs, so all this can be taught here. And we are a center. We applied for AHA ITC also, and the inspection part is done. So very shortly we will be receiving the ITC status, so where we can run our BLS, ACLS and PALS programs regularly. So we got anesthesia wing also, that is a HPS mannequin, which is a very advanced one what we got. So it just barcode, there all the drugs, more than 80 drugs are barcoded. You take the barcoded drug near to it, it behaves as if the real drug has been given. So my postgraduate has the flexibility of seeing what happens if you give 1 mg epinephrine, what happens if you give 2 mg, 3 mg. They can experiment here and see the vitals and the parameters, what happened. They can't experiment on the real case, that is where the simulation comes in place. So all the drugs are barcoded, and I just give the drug, it is physiologically tuned and it performs automatically. So the visionary management has got only one idea with the simulation basically. I just want to summarize in one line saying that you perform n number of mistakes onto the mannequin and do the best possible thing to the patient. So that is how the simulation comes in place. So I can create n number of mistakes here. So I perform here, I damage the parts here, doesn't matter, but you go and don't harm the patient. In the real life scenarios is what Vasa and Vaidehi is committed to. So we got surgical suit where we can perform open laparotomy. So the suit is something what can be worn onto the patient's skin and they can perform live surgeries on it. So that kind of surgical suit, again one of a kind in India, is available in Vasa. So ASCII rooms are all the exams, for example the DNB practical exams, the FRCS exams, all the abroad exams whatever you take in, it is all the ASCII models we are going into. So we have got ASCII space, we have got 4 different rooms where a student can enter, we have got a timer, so he performs case scenarios in 4 different rooms and exit. Examiner can sit at one corner and monitor all the 4 students, everything is videographed. They can come and practice their practical examination ASCII model in our ASCII suits. We have built only for the examination purpose, and the mock exams we have conducted ASCII rooms just for that. So we got ultrasound where we conduct one program called point of care ultrasound, POCUS. So 1-day course where you can enroll from morning to evening, you know the basics of ultrasound. This model is a very advanced one when I say that when you keep a probe, for example, I am a just MBBS graduate or a postgraduate who is first year, I don't know anything about ultrasound. We see only this model wherever you go. But what we have integrated is the textbook model also here. For example, this is how it looks in textbook and that is how it looks on contrast, is what they can compare and study. So this is how my heart looks here and that is how the heart looks there. So that is how it is inbuilt. I mean the software is inbuilt that way that you keep the probe there, you get this anatomical model and the contrast model. So for our students it becomes very easy to compare and learn. So 1-day program is what we run, and that is there on the website. People who are interested can come and log in. It is very good for the postgraduates to learn basics of ultrasound is what we teach here. So we got advanced part of augmented reality also. The medical education is going way beyond. I mean most of the people will watch for it, that when we were in the medical college it is all about the blackboard learning where the teacher is to come and teach us and we used to write in the books and go. And it has gone to the simulation, and the simulation has gone more advanced of the augmented reality and the virtual reality. We have got something called VR gates and the AR setups. So VR gear, you just give one of the VR gear to the student and he see the human body live in front of his eye. I mean he just wear the gear, he can see human body live here, he can go touch, palpate, he can take the heart out, he can see the layers of the heart dissecting. So it is that advanced that they can go and just wear the VR gear. The medical education is transforming to the other level, and Vasa is one of the steps in becoming the pioneers of the medical education. So we got surgical suits again, we got laparoscopy surgical simulators where more than 80 surgeries can be performed. You can just select the surgery and you can get the haptics there which will give the real feel. You can ligate, you can cut, you can give the real feedback in time. How much amount is the blood loss, how much amount of the accuracy of your surgery. So my postgraduates can come in, day out and practice and get the precision done. For example, today I have got 92% of success rate in performing a lap surgery. He can improvise tomorrow, coming that, saying that mine is 94 now, 96 now. Blood loss was 20 ml, 30 ml. Now I can improvise over that, is what they can come and see here. Live feedback is what it has got. So we have got a system where we can manage. One of our instructor will be sitting here and the students will be performing case over there. Students doesn't know that we are sitting and controlling the atmosphere. So once they think that the patient is stabilized, we can drop the vitals, we can make it complicated, and students will perform in that tense situations. So that is how we are designed. We have got debriefing zones. We believe in simulation that the actual learning will happen in the debriefing. So once we perform the case, the students come in, the other students, half of the students have watched them performing live. So we sit together and we discuss what went well, how can we improve. So we got separate stations for that where debriefing can happen in a very systematic way. And we have got inbuilt LMS such strong that, for example, once you enter VASA as a student, we give you a login ID and login password. So with that login ID, login password, you can see our LMS. For example, I got a phone call and I missed 20 minutes of the session. So everything is there in your mobile. You can go back home, go back to the session and see the 20 minutes what you have missed. So everything what we speak, more than 120 cameras in VASA. So everything is recorded, everything, audio visual thing is recorded. So once you missed out anything, you can go back, rewind and see. That kind of atmosphere is what we have simulated, and debriefing rooms are one of the things which will help us out. So these are number of workshops what we have done. So more than 500 workshops and more than 25 students trained in BLS, ACLS, PALS, trauma, life supports, laparoscopy, POCUS, you name it, we have it, all the programs. IVF is one of the newest thing. Last month is what we have got. Slowly we had, management is thinking about starting a course on fellowship or a course, diploma course on IVF. We have to sit and check out how it works, and within 2-3 months we will plan a full-fledged program on IVF. That is what we are planning in. That is a small thing about VASA. Thank you so much for being VASA. I hope that 2 days will be fun loving, and we welcome you all again. Thank you so much.
Thank you, Dr. Javed, for enlightening us about VASA's incredibly impactful work.
All right, now moving on. Now we come to the beautiful tradition, the lamp lighting ceremony. May we request our most distinguished, kind and learned HOD, Dr. Prithviraj Nakar sir, to come up on stage and invite our speakers for the lamp lighting ceremony. All the speakers can join us on stage, please. We invite your presence, to start and inaugurate the conference. Can we have a loud round of applause for these learned, experienced, and educated minds that are coming up on stage?
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
The obstetricians and the pediatricians, I was sitting in the behind and looking at the keen interest of the debate in the morning panel discussion. All the panels are wisely chosen, and I'm sure every session had medico-legal issues. Dinkar was very particular, so please await till the last, towards the last panel discussion to have more on the medico-legal issues. Thank you.
This is a long-awaited conference, and I think it is all the effort of the man behind the conference. Thank you very much, everybody, for coming here. We have a very good neonatal neonatal setup and obstetric setup. Thank you for coming.
One word by Dr. Guru Prasad sir is a stalwart in neonatology in Karnataka state, and my colleague proudly is now in JJMC Davangere as a director of Bapuji CHI. He is there nearly for 30 to 40 years. He has saved many of our lives because he has saved our kids. Okay, sir, few words, please.
Thank you for your kind words, sir.
He is a Guru Prasad also. Guru Brahma, Guru Vishnu, Guru Devo, Maheshwara,
Guru Sakshat, Parabrahma, Tasmai Shri,
Guru Prasade Namaha.
Respected dignitaries on the dais, dear friends, esteemed delegates who are attending this conference. I really feel honored to be here amongst you to inaugurate today's Perinatology conference. Whenever any event is organized by Dr. Dinakar and his team from Vasa, you can't say no. The love and affection with which he invites you. I had so much of pressing commitments today. I told him I am coming. So I drove all the way from Davangere, getting up at 6 o'clock 5 o'clock in the morning. And association with him is always cherishable for lifetime. Recently we had a new hemodynamic conference. We were here for 3 days. Probably the best academic sessions are organized by this institute. I heartily congratulate the entire Vaidehi team and the Vasa for doing that. Especially the Vasa team and Javid, they presented brilliantly just now. On behalf of our institute and all our friends, I wish this conference a great success. Thank you. Dr. Arvind Shena is my senior friend. I'm my guru also, and we studied together a couple of years apart. He's a great personality in the field of neonatology.
Whatever you say, Guru is my Guru. So thank you, Dr. Dinkar, and congratulations. As Dr. Guru Prasad already said, it's a wonderful conference, and I think simulation is the way forward, along with the augmented reality, not only in terms of patient safety, but makes learning much more fun than drab and dreary lectures. The only thing lectures do is add on to your sleep. But here, as you can see, though it may bring down your blood glucose levels, it definitely, the way forward is to learn from simulation.
Hello everybody. Thank you Dinakar sir for this opportunity. It was an eye-opener to me today. I mean, we have been trained on real patients, and the amount of guilt we had when you cut a ureter or there was bleeding, and this is real the way forward through. I think the current generation of students are very, very lucky, and you should really make use of it. And I think that your running courses is fantastic. I'm sure the word will spread and you will have plenty more to go. Thank you.
Among all the speakers, may I request one senior person? I think so. I don't know who is senior. I'm sorry. May I request, madam, can you talk?
Yes.
Why not?
From morning.
Why not?
From morning I'm giving my voice.
Allah, I don't know who is senior, madam. No.
Oh, thank
Not
you.
age. It is experience, not age. Experience.
I'm younger to you, sir. Thank you. Good morning, good afternoon. And I should thank Dinakar for inviting me. As sir said, the invitation was really pleasing. We can't say no. And especially when I entered this Vasa Center, I think so everybody should step in. Especially your students should utilize the services. So I am heading the department in Saptagiri. I'll be inquiring my students who are from Saptagiri. So I brought one of the students also along with me. You are coming to lead me in your hospital, in your center. And as sir said, Shanai sir said, simulation is very, very important. And nowadays, the youngsters' brain is not very good enough, madam. Their breeding is not good. So they are really, how they are means, whatever we teach from our side, they are not assimilating, they are not digesting it. They think, let the teacher talk to herself. Like that it is. And when we ask them, when we take classes, extra classes, when we are teaching, when we are screaming, they come with the iPad or some download, and it's very hard to say. See, anybody of your, I am saying the youngsters in this crowd, buy some textbooks, at least to keep in your almara. Whoever enters your room, they should think that you are a doctor. That's how they recognize you, you are a doctor. Some doctor is there in this house. And you people carry the downloads and pen drive and other things. Please stop that. I made it a point. No, I will not allow any student without a textbook in my classroom. So that is one thing, textbook, the touch feeling of the textbook should be there. And apart from that, that simulation center, what we are having, we should utilize it. I have worked in Ramaya also, we do have that simulation center, laparoscopy, and I am a laparoscopic surgeon also. I have done so many laparoscopies, but I have not undergone training in my period, because during my career, I was doing the camps, where tubectomy camps, like that. We learn from seniors, no sir? We learn from seniors like that. We never had any courses or anything, but still now, I am very strong enough, very sound enough to do any laparoscopy, TLH or any surgeries, because that foundation was very strong. But now you people require this simulation center where you need to augment your body, mind, coordination. So all that is required. And one more thing I wanted to say is that you people need to do the courses. Whenever you are doing the PG course, we do send the PGs to attend the like these courses. See, among them only 2 I mobilized. Sorry to say, from my college only 2 I mobilized. That's what they should utilize.
I am very happy, madam. I am very happy. I am very happy. I am very happy. Okay, yeah, it's not like I called everybody might have thought why I called all the HODs. See, the reason why I called all the HODs is we have this simulation material. If I will call the HODs, they are the one are having PGs. They can tell the PGs. Otherwise, when I started, this one was there since 2 years I want to do in Bangalore. I could not do it. So when I thought, okay, Bangalore ella kardu bidu. You call all the Bangalore doctors. I know that everybody is busy practitioners. And they have DNB students, they have to work in their hospital. So HODs are more better. If I will call them, they can, tell all their PGs. That is the only reason I called the HODs. Please, we have this facility. Please utilize. And for OBG people, I am telling you, see, I am zero knowledge because I am a perinatologist. I don't know like what you people will do. And I have sent my own person. Something is there, madam, take care. This is the one. Please, madam. Okay, and madam, you are all my gods. Okay, and gods, you just thanks for coming. Okay, now we will go for academics. Whenever you feel like boring, okay, just get up, wash your face, come back, and you know that, no, how Neo Gurukul will run. See, Neo Gurukul is the institution created by Dr. Dinakar and Dr. Prashant. Prashant will come now. Okay, that institution only for academics, not any monetary. How much you paid everybody here? 1,500. That will be help for your own food. But we are not making the money out of it. We are for the teaching, Neo Gurukul. And Vaidehi people, they blessed me and they're always blessing hand is there on my head. So that is the reason I'm able to do. Principal sir, vice principal sir, and everybody, please learn. And I'll be sitting there only like a watchman. Okay, if any PGs will go, मैडम जी, नफीसा मैडम, आपका PGs को देखने का, क्योंकि क्या होता है मैं बोल रहा हूँ, कल XYZ something is happened in some conference, somebody, nobody, it should not be. I have got more than 50, 70 people from outside, our own PGs. Okay, see the pediatric, all 23 PGs, final year and second year PGs are here, they're all, you know, same, I mean, feathers, no? Birds will sit like that. But I want your PGs because I have, okay, I am requesting everybody to learn. Thank you very much. Okay? Madam, thank you, Sal. Oh, Sal. Ammo, madam. Ammo, madam. Yaar? Himashri. Very happy. Madam, Himashri is our student, no? Banbidti. Madam, you want mic collar or something like that? Whatever you want to place.
Collar is better, I can show.
Please put the collar for the madam. Okay, everybody will go for academic.
I request everybody to settle down as we have Dr. Rashmi Yogesh elaborating about the IVF simulator we have inaugurated today. Please give her a loud round of applause.
With the kind permission of the organizers of this CME, we take this opportunity to invite all the obstetricians to the Karnataka State OBG conference, which is being held in Tumkur on 31st October, 1st and 2nd November. So we will be sending across the brochures. Please register, please come and participate as faculty, and also bring your PGs for this academic fees. Thank you so much.
Thank you for this opportunity. Thank you. 1 minute.
Laptop, put it in full screen F5, slideshow.
Fertility consultant. I'm the lead fertility consultant at the Krushi Fertility and IVF Center at Bannerghatta Road, opposite Vega City Mall in Bangalore. IVF has been my passion, and I'm so glad that I am able to demonstrate simulators of IVF, embryo transfer and hysteroscopy, which form the crux of fertility treatment today to all of you. It's been only in a few places that people hire IVF simulators for a day or two and have workshops, but having something like this so handy is a great bliss, and I'm so glad that Vaidehi Medical College has taken this beautiful initiative. IVF is something that has been advancing in leaps and bounds over the last few years, and a lot of people who graduate from masters in obs gynae are now trying to do fertility, and they want to take up this branch because we see a lot of late marriages, a lot of people trying to conceive after setting up their careers right, and so this has been something which is booming as of today. And we have heard of so many people that yes, nobody would really want to get married at the age of 20 and have children at the age of 25. People want to make their careers strong, and they want to be really sure that they are with the right partner before they actually plan pregnancy. And that's why oocyte vitrification is something that has become a very well-known practice, and we have a lot of women coming in for oocyte vitrification now. At the same time, we also have women who are aging, and they have aging ovaries, they hardly have any reserve in their ovaries, and then they would want to really rejuvenate their ovaries. Be it for oocyte vitrification or for ovarian rejuvenation, apart from the routine IVF, ovum pickup procedure is the most important one. Ovum pickup for doing ICSI and creating embryos, or doing ovum pickup for oocyte vitrification, the ovum pickup technique is something at which every fertility specialist should master on. It's a very simple technique, but at the same time a very skilled one. We see a lot of people doing ovum pickup, but doing it in the right way is very important. So the more you do, you get more and more perfect at it. And having a simulator is surely a boon in disguise. So we have 3 simulators here. One is the embryo transfer simulator. IVF success rate depends not just on the eggs, sperms and the embryos, it depends on the technique of embryo transfer, which is a rate limiting step in IVF. If the fertility specialist who is doing the embryo transfer does it precisely, the best embryos are placed in the right point, which we call as the maximum implantation point in the uterus. It's only then that the pregnancy rates are good. We see a lot of failures happening in IVF just because of difficult embryo transfers and faulty techniques, and mastering this is the least possible thing we fertility specialists can do to master ourselves and add to the success rate. And a simulator makes things really easy. And the next one is the ovum pickup simulator. As I told you, be it for ovum pickup, for oocyte vitrification, or to create embryos, even for ovarian rejuvenation, the technique of ovum pickup is important, wherein we inject stem cells, platelet-rich plasma, exosomes, and primordial germ cells inside the ovaries to rejuvenate the ovaries. This technique is very important. Ovarian rejuvenation has been my passion, and I really want every doctor should know about this ovarian rejuvenation and advocate more and more of these to women, especially when they have no hopes of getting pregnant with your own oocytes. And then is the hysteroscopy. Ovum pickup, embryo transfer, all of these can be done seamlessly well, and pregnancy can happen only if the uterus, the womb is all in its perfect shape. We see that when we give hormones like estrogen, a lot of people develop endometrial polyps, which is a very common thing. Apart from that, we see that women have submucous fibroids and things inside the uterus which make pregnancy difficult. A simple diagnostic hysteroscopy can also bring up things like endometritis and small adhesions inside the uterus which could have happened because of previous DNCs or endometrial biopsies. And we see that the endometrial gland distribution in the endometrial layer is also very important for pregnancy. So when we do a simple diagnostic hysteroscopy, all these things would be opened up and the success rate for IVF can be increased. There are a lot of fertility specialists who don't do an embryo transfer without having done a hysteroscopy. So hysteroscopy, ovum pickup and embryo transfer these are the 3 most important things a fertility specialist does day in and day out. I mean, our entire day goes with follicular scans, ovum pickup, embryo transfers, hysteroscopies and then counseling. So these are the things that we do the entire day, and the fertility center that I have, we specialize in all of these and we really want more and more people to do this. We have a fellowship program under the Rajiv Gandhi University, and I always feel that I give only the ovum pickup of donors to my fellowship students, and looking at this I felt really happy that I can do more justice to them by using the simulators with which they become much more confident. And the kind of guilt that we have when we let our fellowship students do ovum pickup for the donors is something that we will not have to carry anymore. We'll first start with the hysteroscopy. Actually, in the actual hysteroscope, we have something called as telescope, which is an integral part of the hysteroscope. This telescope enters into a sheath. The sheath can be of two types. It can be a single channel sheath or a double channel sheath. Single channel sheath will help in irrigating, and we will be able to visualize the uterus. A double channel sheath has got the advantage of an outlet, so that if there is some bleeding inside the cavity, all that can seep out, and then the vision can be much more clear. Standard hysteroscope or the telescope comes at a diameter of 4 millimeters. When you put the single channel sheath, it becomes 5 millimeters, and we put a double channel sheath, it becomes 6 millimeters. Of course, when you have polyps and all that, you will have to use a scissor that will enter through an operating channel. So you have something called as operative sheath, which will have 4 channels, one for the telescope, one for the instrument, something like a Caesar or a grasper, and it will have inlet for the irrigation of normal saline, and it will have an outlet for the fluid that is there inside the uterine cavity to flow out. So this operative channel, with all of this, it becomes 8 millimeters. In our center, we use the 1.9 mm fiber optic hysteroscope, which is called as the office hysteroscope. The advantage of this is that even with the operating sheath, it comes to only 2.9 mm, and we are able to do things like polypectomy, we do endometrial plowing, subendometrial, PRP for increasing blood supply to the uterus, and even things like small myomas can be resected using that, and that's why now, without having to dilate the internal os and without damaging the circular fibers of the internal os, which can result in cervical incompetence later, we can do diagnostic hysteroscopies. However, the routine hysteroscope comes as 4 millimeters, and then we have something called as a resectoscope. So if we have submucous myomas that are huge, vascular, or polyps that are huge and vascular, then we have to take the help of resectoscope. Resectoscope will come with a loop, and what actually happens in resectoscope is we don't use this diagnostic 2-channel or a 4-channel sheath. There is a working element which is available. So this model, I saw that is something which simulates the resectoscope working element. So what happens in an operative hysteroscope is we take the working element, and in the working element we first put the electrode. So this system is ready. Then we have an inner sheath and outer sheath. So this thing enters into the inner sheath. The inner sheath will have a ceramic end, and that will make us recognize that this is the inner sheath. The inner sheath is then inside the inner sheath we put the resectoscope working element, and then we with the electrode, and this system is kept ready. What we put inside the uterus through the cervix is the outer sheath, which has an obturator. The outer sheath will have some perforations at the proximal end of it. So what we do is that with the outer sheath with the obturator is something which will prevent an injury. It will make the barrel actually filled up with it, so that nothing comes out when we are secretions don't come out, and we put the outer sheath inside the uterus first. After putting the outer sheath, what we do is that we take out the outer the obturator, and this thing what we have assembled, the inner sheath with the working element and electrode, is then introduced inside, and then we perform the procedures. And the most important thing is the kind of energy we use. We usually use a bipolar so that we can use normal saline as a distension medium. If we use monopolar, what happens is we have to use glycine for resectoscope, and glycine toxicity is a dread, and that's why we usually use normal saline as distension media nowadays. So right now this is a model which simulates a resectoscope, so that you can do all the diagnostic hysteroscope, operative hysteroscopes, and the resectoscope, everything in one go with this. And the advantage of using resectoscope is also because when you have Asherman syndrome, when you have septum in the uterus, this is something that we do on a routine basis, septal resections and ediciolysis. We see a lot of women coming to us with persistent thin endometrium, which is hypovascular. And this is not just because of tuberculosis, which used to be in the ester years. It is unfortunately because of inadvertent curettage of the uterine cavity post miscarriages. We see that there are a lot of adhesions inside the uterus, and that is something that is preventing them from pregnancy. Most of the times we see cornual adhesions, and because of cornual adhesions, the fallopian tubes are kind of blocked. The moment we do hysteroscopy with hydrodissection itself, all those flimsy adhesions open up, and then we see that the fallopian tubes also get patent, and a lot of women conceive just after a hysteroscopy. And then nowadays we see that as a fertility specialist, what I really observe right now is that a lot of women are actually not getting pregnant, not just because of reduced ovarian reserve, not because of blocked fallopian tubes, but because of reducing sperm counts And the second thing is that women have their endometrial layer which is not up to the mark. And can you just imagine what is the main reason for endometrial layer not being good and the endometrial blood supply not being good? It's because of lack of pelvic floor exercises. One thing that is lacking in today's generation is pelvic floor training. We have a lot of women who are coming to us and they ask for pelvic floor therapists. We have physiotherapists who are doing specialization in pelvic floor therapy now, and until and unless the blood supply to the endometrium improves, we can't do an embryo transfer, and it's only because of that that women don't conceive. And our women, our ancestors would sit on the floor and mop, would sit on the floor and cook, and they would sit on the floor and do everything, and now squatting has become an exercise rather than a routine, and asking women to squat every day has become our practice now. And we tell women, please do pelvic floor exercises. People go for acupuncture, yoga, they go for MCLA chair to do Kegels automatically so that the blood supply increases. And what we do with a hysteroscope is that we do something called a subendometrial PRP, where we take the platelet-rich plasma, and with the help of operative sheath, with the ovum pickup needle, we inject platelet-rich plasma into the subendometrial layer and increase the blood supply to the uterus in women who are having sedentary lifestyle, to increase the blood supply, after which we've seen fantastic results and women getting pregnant. So I feel hysteroscopy is a boon. Our ovum pickup and embryo transfer is incomplete without this. I'll just show you how this simulator works. Yeah, he's just doing one. You giving me a polyp? Usually in the hysteroscope we have an inlet and outlet. The one which is closer to the user or the telescope, the camera, is the inlet, and the one which is away from us is the outlet. And it will have a knob. If you make the knob parallel to the outlet or the inlet, then it is like being on. When you make it perpendicular to it, it is off. Can I start? So he is switching it on so that the normal saline starts flowing in. Usually we keep it at a suction of about irrigation system of 80 to 90. It has to start now. It's coming there. Oh. So it's asking me to insert the hysteroscope. When we insert, we see a black hole, and that's the internal os. And what we do is that when we enter inside the cervical canal, if we see the internal os at the top, we have to move our hand down. If it is low, then we have to move the hand up. Actually, I'm inside the uterine cavity already. It's very different from how it is in the normal routine. The normal. This is the left ostium, and this is the right ostium. Always in hysteroscope, whatever is our right is the patient's left, because we are in between the two. Here is a endometrial polyp which is there right at the fundus. So what we do in hysteroscopy is we take the scope very close to the fundus. After going close to the fundus, we move the cable on one side, and then we try to move the hand. Whenever the cable is moved to the right, our right, you see the patient's left ostium. When you move your cable towards your left, you will see the patient's the left ostium. So it's like this, that you go to this side and then you see that. It's always opposite. So here what I'm focusing right now is the right ostium of the patient, and what I'm focusing right now is the left ostium of the patient. We usually go very close to the ostium. We try to look for periosteal vascularity. If there is a lot of periosteal vascularity, periosteal congestion, it's usually suggestive of endometritis. And then what we have with us is something called as contact hysteroscope. We go very close, touch the the endometrium with our scope, and then we have a knob to adjust. We will be able to see the vascularity as well as the endometrial gland distribution. We will be able to make out things like hypoplasia based on the vascularity, the mosaic pattern and all that. So here, when we keep the scope very close to the ostium, we'll start seeing that there will be some bubbles that circulate around the ostium. If the fallopian tubes are blocked, we see a lot of air bubbles that usually circulate around the ostium, and that gets an understanding that the tube is probably blocked. And if you don't see air bubbles there, then you know that the tube is probably patent. And then when we look at the fundus, we see that usually the air bubbles are light, so they go and deposit in the anterior wall. So usually when you do a real hysteroscope, we see air bubbles settling in the anterior wall of the uterus. So what we actually do is we first go towards the fundus, and as I told you, we see both the ostia. We try to look for patency of the fallopian tubes. We look for the vascularity, the glandular distribution. Then we come very close to the internal os. When we come close to the internal os, we have a panoramic view of the uterine cavity like this. When we have a panoramic view of the uterine cavity, we get to understand if it is adequate for a single or a double embryo transfer. We try to look for the contour of the fundus and see if it is deep arcuate, arcuate or subseptate. And then what we do is that we turn the cable in such a way that we see the right lateral wall, then go this way, see the left lateral wall, move the cable up and see the posterior wall of the uterus, uterine cavity, and then the anterior wall of the uterine cavity. And then when we come closer, till we come out, we have to keep seeing everything. Then we look at the internal os. When we look at the internal os, we actually look for the circular fibers and see if the circular fibers you have this bottleneck kind of a stricture that indicates that circular fibers are intact and the risk of incompetence is lesser. And then we try to move out and note the direction of the internal os, because that would be of importance to us when we do the embryo transfer. So I think we'll try to perform resection of this endometrial polyp now. For this, he has to give me a loop. So when we see a loop, what we try to do is, the first thing is we have to look at the base. So we try to go beyond this, try to manipulate till we see the base. Sometimes we'll have to move this to see the base. Whenever we see the base, the best thing is to go beyond the polyp and resect. So we go beyond the polyp, the base, then he has to give me a cautery. Okay. So we go beyond this. So we go beyond this. And resect. Actually doing it in real is much more easy. So we go beyond the polyp, we see the base, and then we cut and we try to come down. And this is the right way to do it, that is go beyond it and come down. Never go from below up. This is the wrong way of doing it. Always go from up and come below, because if you try to do from below and go up, you might accidentally perforate the fundus. So as much as possible, go beyond it, touch the base, and as you touch the base, you have to do it like this. So that's the right way of doing it. This is the focus. No, I removed the scope. This is right. So I think now the polyp is out. This is the internal os, and then the polyp is coming out. Yeah. Okay. The next step is our ovum pickup. Shall I start? As I told you, it is not just about ovum pickup for creating babies. We do ovum pickup for oocyte vitrification, and the same kind of technique is used to inject PRP and exosomes inside the ovarian cortex, and that's why this technique is a very important one. The operator sits in between the two abducted supported legs of the lady, and then we have to use an ultrasound system to be able to see the follicles and the ovaries precisely. And then the transducer would be a transvaginal transducer, which will have a needle guide, and this needle guide is the one through which the ovum pickup needle, which is a 21 gauge ovum pickup needle, enters inside. The ovum pickup needle can be a single lumen or a double lumen. Single lumen is only to aspirate the follicles, whereas a double lumen is to flush the follicle, especially in low reserve, to be sure that you are extracting the entire cumulus oocyte complex. I feel the entire process of IVF is all about detachment and attachment. When we do ovum pickup, we want to detach the cumulus oocyte complex from the follicular wall, and we want to take it out completely. And when we put the embryo inside in an embryo transfer, we want the embryo to go and get attached to the uterine lining. So this detachment and attachment is all very important in an IVF process. While doing this, we also have to ensure that we have a suction system. because this ovum pickup, which is the free end which is shown here, and this is attached to a suction system, and the suction is the one which will create the suction to pull out the cumulus oocyte complex. And what happens is the other end of this would be connected to a test tube, and this test tube will be kept in a test tube warmer, and all the follicular fluid is collected in the test tube, which is placed in a test tube warmer. And the moment all the follicular fluid is collected there, it's all passed down through the pass box to the embryologist, who will examine the follicular fluid and try to look for cumulus oocyte complex. They separate the cumulus from the oocytes, and they keep the oocytes in an incubator for about 2 hours, so that the oocytes also gain the second level of maturation. Because what happens is, it's not necessary that all metaphors 2 oocytes come out during an ovum pickup. There could be some metaphase 1 oocytes also. When we keep it for incubation for a couple of hours, from M1 they get converted into M2. And what we do is, after 2 hours, is take all those oocytes out, and then we perform ICSI under the micromanipulator. And after the ICSI is done, ICSI is nothing but injecting one normal looking sperm into each oocyte. And then after this is done, we put these fertilized oocytes back into the incubator, culture them for about 5 days. And then on day 1 of the day the ICSI is done is called day 0. Day 1 is a fertilization check. Day 2 we see 4-cell, and day 3 we see 8-cell embryos. Day 4 we see a ball of cells which we call as a borula, and by day 5 we see something called as blastocyst, which will have about 100 cells in it, and this blastocyst will have an inner cell mass and a trophectoderm. So we keep seeing them conventionally on a daily basis. On 5th day or 3rd day we usually do the embryo transfer. So we'll start doing one ovum pickup procedure here. Transfer 2 minutes. Pick up and transfer. I'll just do and show. Transfer is very simple. Just put the embryo inside the uterus. I'll take 30 seconds for embryo transfer, and ovum pickup I'll just show you a minute. Okay. We need a suction pedal. Nowadays we have digital suctions. Okay, it's getting ready. So you see here, this is a needle. Now I want the cursor on the other side. The cursor on my left or the screen's right. Cursor on this side. The other way, mirror image. Yeah, that's fine, but that cursor should be this side. However it was now, it has to be. Okay. Can I start now? Yeah. I don't see the movie. So what we do is we inject every follicle with the ovum pickup needle. The pickup needle should be in the center of the follicle, and we aspirate it all. And then once the test tube is full, we have to change the test tube. I'll show the embryo transfer in the meanwhile. Yeah. We usually use cusco speculum for this. Cervix should be seen. Cervix is seen. A little more it has to go in. Yeah. So once the cervix is seen, we put the outer catheter. Can you show this?
That is ready. That's ready.
Okay.
Because that is projected there.
Okay. Yeah, it's fine. Then we enter. It's overshooting. See, the follicle gets emptied. Then the next. Yeah.
Automatically after the test tube.
Then we stay in the center of the follicle. It gets we usually don't take the needle out and avoid multiple punctures of the vagina wall. We just go into every follicle. The moment the needle enters, we press the pedal, aspirate the follicle. This is how the Om pickup is done. Yeah. Leave this and I'll show the embryo transfer. Yeah. The embryo transfer will have an outer catheter and inner catheter. We'll probably display it. First we put the outer catheter and then ask the embryologist to get the embryos in the inner catheter. That's called as afterload. Sometimes outer catheter, inner catheter, everything is brought to us in one go, and that is something which we call as preload technique. Yeah. This is going inside. You have to see the cervix first. Now I can see the cervix, wait. Yeah. The outer catheter has to enter inside. Yeah. And what we do is there's a knob there. It has to stop at the level of the external os. Okay, give me the inner catheter. Let's see if that goes in. The inner catheter with the embryo is loaded. Like how she's doing, the embryologist gives me the embryos and then you can see it entering inside. It is not gone in. Yeah. Okay. You will have to give a different model, otherwise the uterus model. Give me the catheter once again. It's actually very simple to do an embryo transfer. The catheter has to go in, no? Yeah. Only then. Does it also depend on the kind of model you're showing me there? Sometimes when we have difficulty in putting the outer catheter inside, we use something called as obturator. So we take the obturator and with the aid of that, we put the outer catheter inside. Outer catheter will be kept at the level of internal os, and then we put the inner catheter with embryos inside. And then we try to transfer the embryos exactly at the point where you have an intersection of two cornual ends. From the cornu, from one ostia to the internal os, another ostia to internal os. At the intersection of that in the upper uterine cavity, half of the upper uterine cavity is a maximum implantation point, and we try to transfer the embryos there. Yeah. So our outer catheter would be stopping here at this point, and then the inner catheter goes inside with the embryos. We go here. Usually we reach up to this point, and then we go a little above the mid cavity and then transfer the embryos. So once we do the embryo transfer, we wait there for about 30 seconds and then take the catheter out. So this is a successful embryo transfer. Success is only after the beta HCG comes positive. Thank you. Thanks for this opportunity. Thank you. Thank you, sir.
Hello. Check. Check. We would like to call upon Dr. Sridhar Venkatesh to felicitate Dr. Rashmi for this wonderful demonstration that she's performed for us. Thank you so much, Dr. Rashmi. We had such an insightful understanding of the entire simulator. For our second session, we have Dr. Subhashekar Reddy introducing the clinical scenario. But wait for all the panelists that will join us.
I'd like to introduce our panelists. We have our obstetricians, Dr. Dharma Vijaya, Professor and Head of Department, MVJ Medical College. Dr. Rajini, Professor and HOD, Saptagiri Medical College. Dr. Nafisa, Associate Professor, Vaidehi Institute of Medical College. And we have our neonatologists, Dr. Shashidhar A, Associate Professor of Neonatology, St. John's Medical College. Dr. Manjunath Shetty, Consultant Neonatologist, Rainbow Hospital. Dr. Akhila Akula, Consultant Neonatologist, Cloud Physician. Dr. Sriram Bonu, Assistant Professor, Neonatology, Vaidehi Institute.
Along with that, we also have some doctors enlightening us about the imaging aspect. We have Dr. Suresh A, Professor and Head of Department at Radiology at our own very own Vaidehi Institute of Medical Sciences. We welcome you, sir. To repeat our wonderful panelists that we have for our second session, we have our obstetricians. We have Dr. Dharma Vijaya, Professor and Head of Department at MVJ Medical College. We have Dr. Rajini, Professor and Head of Department at Saptagiri Medical College, and Dr. Nafisa, Associate Professor at WIMS NRC. Again, repeating our neonatologist names. So Dr. Dharma Vijaya, Dr. Rajini, and Dr. Rajini. Ma'am is here. And Dr. Nafisa, ma'am is here. Yes. Neonatologists, we have Dr. Shashidhar A. Sir, Dr. Manjunath Shetty, Dr. Akhila, and Dr. Sriram. And for the imaging, we do have Dr. Suresh A, Professor and Head of Department of Radiology at our wonderful institute. Our super moderators for this session will be Dr. Nandish Manoli, Professor of Oxford Medical College, and we also have Dr. Sahana D, Professor and Head of Department of Neurology at Bangalore Medical College, guiding the conclusion and the participant question and answer session. We welcome all the panelists on stage. Please join your hands together for all the wonderful experienced doctors we have on stage.
Shekhar, just a minute. I am Dr. Nandish Manoli, Professor, Oxford Medical College, Professor of OBG. I was really very pleasantly surprised when Dinakar rang me up and asked to be super moderator. I was just wondering what is this super moderator, or then he asked super computer. Then I asked, okay, you mean I should become the third umpire? So it's a great pleasure to be in this Perinatology conference and workshop 2025 being held at such a prestigious college, and being invited to be one among the senior participants of this conference. I think I will do justice and add to whatever additional information I can give when the speakers conclude. Thank you.
Before I start this session is on the sepsis. Sepsis, initially we have divided in the same way, like first session will be on the GDM, that gone excellently well. Are you able to hear me? Yes. Oh, yeah. That gone in an excellent way. And we will be going towards now with the sepsis, which is a burning problem in India. Okay. And before starting of this sepsis discussion, Dr. Manduna sir, because of his passionate over the sepsis work, because we have been discussing over the days and days about this sepsis over the phone and these things, he was obsessed in this sepsis and he made a poem on that. And now we will start this session with sir only. Sir, kindly.
Thank you very much. My background is I've spent a lot of my time so far in UK, and after coming here, I joined the Rainbow Children Hospital as a neonatologist. And when I was offered to talk about sepsis, this is the one which hit hard most of the neonatologists and the obstetricians, particularly having a normal grown baby so far and then suddenly losing. And this, I've got many examples from all the neonatologist and obstetrician point of view. When I heard this, yesterday night, this was again bothering me. So I put some lines of a baby whom I came across. And this is written in Kannada, my mother tongue. I hope most of you understand. Those who don't, not to worry, but I can translate at the end. So I put the title as Nanna Horata to Namma Horata. Means from myself to all of us. Nanage aga haga, my pronunciation is also not so great, so please bear with me. Nanage aga hagittu 29 ವಾರಗಳು. ನನಗೆ ಆಗ ಆಗಿತ್ತು 29 ವಾರಗಳು. ಏನೋ ಆಗ ನನ್ನಲ್ಲಿ ಕಳವಳ ಮೂಡಿತು. This is a fetus saying. ನಿನಗೂ ಆಗ ತಲೆ ಸುತ್ತುತ್ತಿತ್ತು, ನಿನಗೆ ಆಗ ರಕ್ತದ ಒತ್ತಡ ಹೆಚ್ಚಾಗಿತ್ತು. So this is going with PET. ವೈದ್ಯರು ನಮ್ಮೆಲ್ಲರಿಗೂ ಧೈರ್ಯ ತುಂಬಿದರು, ನಾನು ಹೊರ ಬಂದಾಗ ನನಗೆ ಆಗಿತ್ತು 31 ವಾರ. ಸೊ ಐ ವಾಸ್ ಬಾರ್ನ್ ಅಟ್ 31 ವೀಕ್ಸ್. ನಮ್ಮೆಲ್ಲರಿಗೂ ತುಸು ಆರೋಗ್ಯ ಸುಧಾರಿಸಿತು. ಮೀನ್ಸ್ ದ ಬೇಬಿ ಆ್ಯಂಡ್ ಮದರ್ ವರ್ ಗೆಟಿಂಗ್ ಬೆಟರ್. ನಿಮ್ಮೆಲ್ಲರ ಹೊಗಳಿಕೆ ಮಾತು ಕೇಳಿ ಕೇಳಿ ನನಗೆ ಸ್ವಲ್ಪ ಖುಷಿಯಾಗುತ್ತಿತ್ತು. ಐ ವಾಸ್ ಫೀಲಿಂಗ್ ವೆರಿ ಪ್ರೌಡ್ ಟು ಹಿಯರ್ ಆಲ್ ದ ಡಾಕ್ಟರ್ಸ್ ಆ್ಯಂಡ್ ದ ಪೇರೆಂಟ್ಸ್ ಪ್ರೈಸಸ್ ಫಾರ್ ಮೀ. ಎರಡನೇ ದಿನ ನನ್ನ ಶಕ್ತಿ ಕುಂದಿಸುತ್ತಿತ್ತು. ಮೀನ್ಸ್ ಐ ವಾಸ್ ಫೀಲಿಂಗ್ ವೀಕ್ ಆನ್ ಡೇ 2. ಎಲ್ಲಿ ಇತ್ತೋ ಆ MDR ಕ್ಲಿಪ್ಸಿಯಲ್ಲಾಗಳು, ದಿಸ್ ಆಲ್ ಗೋಯಿಂಗ್ ವಿತ್ MDR, ನನ್ನ ಹಾಗೂ ನನಗೆ ಕೊಡುತ್ತಿದ್ದ ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಗಳನ್ನು ಮೀರುತ್ತಿತ್ತು. ದೇ ಆರ್ ಮಚ್ ಹೈಯರ್ ದೆನ್ ಮೈ ಪವರ್. ವಾಟ್ ಎವರ್ ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಯು ಆರ್ ಗಿವಿಂಗ್, ಸ್ಟಿಲ್ ದಿಸ್ MDR ವಾಸ್ ವೆರಿ ಮಚ್ ಹೈಯರ್ ದೆನ್ ಆಲ್ ಆಫ್ ದೋಸ್. ನನ್ನ ಸಮಯ ಮಿತಿಯಾಗುತ್ತಿತ್ತು. ಐ ಆಮ್ ಫೀಲಿಂಗ್ ಮೈ ಟೈಮ್ ಈಸ್ ಲಿಮಿಟೆಡ್ ನೌ. ಆದರೆ ನನ್ನ ಹೋರಾಟ ಮುಂದುವರೆದಿತ್ತು. ಸ್ಟಿಲ್ ಐ ಆಮ್ ಫೈಟಿಂಗ್ ಫಾರ್ ಆಲ್ ಆಫ್ ದಿಸ್. ನನಗೆ PVL ಲಕ್ಷಣಗಳು ಕಾಣುತ್ತಿತ್ತು. ಫಾರ್ ದೋಸ್ who have not much heard about PVL, this periventricular leukomalacia, which is very dreadful for our babies because it's almost eat like the brain around the periventricular area, and almost certain cerebral palsy is written up for that baby. So this was what the signs were showing. ಈಗಲೂ ನಮ್ಮವರೊಂದಿಗೆ, ಮೀನ್ಸ್ ಈಗಲೂ ವಿತ್ ಅಮಾಂಗ್ ಮೈ ಪೀಪಲ್ಸ್, ನನಗೆ ಉಳಿದಿರುವ ಬುದ್ಧಿಯೊಂದಿಗೆ, ವಾಟ್ ಎವರ್ ಸ್ಟಿಲ್ ಮೈ ಬ್ರೈನ್ ಇಸ್ ಸಮ್ ಲೆಫ್ಟ್, ಯೋಚಿಸುತ್ತಿರುವೆ ಎಲ್ಲಿಂದ ನನಗೆ ಬಂತು ಈ MDR ಕ್ಲಿಪ್ಸಿಯಲ್ಲಾಗಳು. ವೇರ್ ಡಿಡ್ ದಿಸ್ MDR ಕ್ಲಿಪ್ಸಿಯಲ್ಲ ಕೇಮ್ ಟು ಮೀ? ಅಮ್ಮನಿಂದಲೋ, ನಮ್ಮ ಆರೋಗ್ಯವನ್ನು ವಿಚಾರಿಸಲು ಬಂದ ಆ ಕೈಗಳಿಂದಲೋ, ನಮ್ಮ ಆರೋಗ್ಯ ಸುಧಾರಿಸಲು ತಂದ ಆ ಯಂತ್ರದಿಂದಲೋ. I don't know where this MDR came from. Is it from the medical people who came to help me, or was it already in my mother's birth passage, or was it the instrument which was used? That's what the baby is thinking. Moving further, ನನ್ನ ತಮ್ಮ ಅಥವಾ ತಂಗಿ ಬರುವುದು ಉಂಟು. Means I am expecting my brothers or sisters are on the way. They will be born. ಈಗಿಂದಲೇ ಹೋರಾಡೋಣ ಈ MDRಗಳೊಂದಿಗೆ. We have to fight against this MDR from now only. ಎಲ್ಲಿಂದ ಆರಂಭಿಸೋಣ? ವೇರ್ ಶಲ್ ವಿ ಸ್ಟಾರ್ಟ್? ನಮಗೆ ಬಂದ ಕ್ರಿಮಿಗಳು ನಮ್ಮ ಅಮ್ಮನಿಂದಲ್ಲವೇ? ವಾಟ್ ಎವರ್ ಬರ್ಕ್ಸ್ ವಿ ಗಾಟ್ ಇಟ್ ಫ್ರಮ್ ಅವರ್ ಮದರ್ಸ್. ತದನಂತರ ಆಫ್ಟರ್ವರ್ಡ್ಸ್ ಫ್ರಮ್ ಫಾದರ್, ಬಂಧು ಮಿತ್ರರು, ಸಮಾಜದಿಂದಲ್ಲವೇ ಬಂದು. MDR ಅನ್ನು ತಡೆಯೋಣ. ಆ್ಯಂಟಿಬಯೋಟಿಕ್ ಮತ್ತು ಇನ್ಫೆಕ್ಷನ್ ಕಂಟ್ರೋಲ್ ಪಾಲಿಸಿಯನ್ನು ನಮ್ಮದಾಗಿಸಿಕೊಳ್ಳೋಣ, ಪಾಲಿಸೋಣ. MDRಗಳನ್ನು ಮಿತಿಗೊಳಿಸೋಣ. ಥ್ಯಾಂಕ್ ಯು. ದಿಸ್ ವಾಸ್ ದ ಶಾರ್ಟ್.
Sir, thank you, sir. It was a great start. Now we'll be going into the discussion. See, the pain that he pursued has been written in a poem, because this is originally the burning problem in India. And we are going to discuss something, different systems and different hypotheses, because most often our books never write about gram-negative sepsis. If you go through any of the neonatal or perinatal books, it will be 20-25 pages will be on the gram-positive EOS, and then only 2-3 pages will be on gram-negative, because that's the lack of the information that we have. And today we are going to propose some hypotheses. And the question is like this. A 36-week pregnant woman with a previous LSCS admitted with abdominal pain, scar tenderness, and fetal heart rate fluctuations, an emergency LSES is performed, delivered at 3.2 kgs. Every word here carries a meaning. 3.2 kgs. Postnatally, the neonate presents with respiratory distress and is admitted in the level 3 NICU. Sepsis markers were positive within 12 hours of the birth, and intravenous antibiotics were initiated on day 1. Despite intensive care, the baby remains hemodynamically unstable and unfortunately expires on day 5. Final diagnosis. Early onset sepsis. Blood culture reveals Klebsiella pneumonia resistant to multiple antibiotics. Now the discussion starts. Here the both obstetrician and the pediatrician will be combinedly discussing these things and one in one. And initially, Madam, first one, Dr. Dharma Vijaya. Nafisa, Madam. The first question.
She's not there. As an obstetrician, I can
Yes.
talk.
The first question is this thing. What type of the sepsis is this? If this is classified as an early onset sepsis, what could be the potential routes of infection? And you can start up, Madam.
Yeah. So, early onset sepsis. You people classify as early onset sepsis, late onset sepsis. For us, only sepsis is a one term where we use throughout. So, whether the sepsis is acquired through vaginal route or through the systemic route or through other respiratory system, if she has blood-borne infection or side-borne infection, definitely she is infected. But the fetus is protected. We are nature's gift, where the fetus in utero is no time is affected with the sepsis. The previous slide. So as you all know, the amnion, chorion and intermediate layer which are there, they are type 1 and type 3 collagen giving its tensile strength. So these 3 layers fuse at 12 weeks. As you know, basalis and amnion, where they fuse it, and resulting amnochorion, decidua at 25 weeks. So this is the protecting layer. So the infection causes, what infection causes intrauterine? Inflammatory response releasing cytokines like interleukin 6, 8 and tumor necrosing factor. So once the sepsis sets in, definitely it will be there. So what are the risk factors for this sepsis? As you all know that whenever the preterm labor, the demographic profile, whenever a preterm labor has come, we have a Papernick scoring is there, where demographic, all those features, what all, the age, nutrition, socio-economic, all that. Apart from that, the extremes, low BMI, extremes of the age, low socio-economic, polyhydramnios, twins, smoking. So these are all the things. Apart from collagen disorders, what we see, the SLE, Ehlers-Danlos, where they have a higher risk of sepsis, which is there in them, which will be there in them. And other one is iatrogenic is the amniocentesis. If they have undergone some procedures in the first trimester, where the risk of 1% is there, and encerclage also, chorionic venous sampling also. But we do under antibiotic cover, but still there are chances of sepsis. So the concept of inflammaging was introduced in 2000, claiming that during aging, a sterile low-grade inflammation may develop. Pregnancy-associated inflammaging is there for particularly, so wherever the inflammation should be there, both life partners. So vaginal microbiota composition is an established risk factor that no doubt everybody knows. Vaginal infection, first when we think of preterm labor or in any, if the patient has set into labor, first cause of preterm labor will be the genitourinary infection. So vaginal microbiota composition is an established risk factor. Interestingly, studies using the cultivation or molecular techniques have shown that the outcome in the neonates with the PPROM and intra-amniotic inflammation without detectable microorganisms. There is a sterile intra-amniotic inflammation similar to the outcomes in the neonates which were exposed with the microorganisms in the amniotic cavity. So this is a positive maternal culture of potentially pathogenic bacteria were evaluated. The antibiotic treatment given during labor and found that developed in the 53.8% of the cases despite adequate empiric antibiotic treatment during the labor. So these results indicate that development of the infection, fetal infection, probably preceded labor and could not be prevented by antibiotic treatment during labor. In line, 3 out of the 4 cases of the early onset neonatal sepsis occurred despite the antibiotic treatment. So these are all the studies, citations which have shown 6, 7, 8, 9, all of them they suggest that histologic chorioamnitis with a fetal inflammatory response is characterized by presence of the fetal neutrophils in the chorionic vessels and umbilical vessels. Next slide. So clinical chorioamnitis. What do you say? How do you define them? So when we see when the patient has come with the preterm labor, we monitor the preterm labor whether she is going in for the chorioamnitis or not. So when we admit the patient, we ask the history first with the fever, whether she is having any fever with a temperature of 38 degrees or at least 2 of the following symptoms, signs. One is a symptom, the other one is a sign, where we look for the maternal tachycardia. That's a more than 100 beats per minute. It is there. You have to suspect some infection. And also the fetus is being affected 1:2 ratio, where the fetal tachycardia will be there more than 160. So these two are alarming signs to say that there is a sepsis and is an etiological factor. Then biochemical tests, what we do is a leukocytosis, more than 15 per or 10 to the power of 9 per liter. The last sign will be the uterine tenderness or malodorous amniotic fluid and discharge. So don't wait for till the discharge with the earliest symptoms and signs, where we take a call to decide that this patient is having a sepsis. So chronic endometritis, where you see that all that infection will be there, definitely is a cause for early neonatal sepsis. So first, if we say that whenever the patient is having the premature rupture of membranes, we have to tell the neonatologist, pediatrician, how many hours they'll ask first that. Everybody they'll ask first. I think so more than 18 hours is dangerous, I think.
Correct, madam.
More than 18 hours is dangerous. So that you take it into account whenever the PPROM is there, the rupture membranes. Even though the patient is asymptomatic, but still you take account of the rupture of the membranes duration. Even though she is asymptomatic and biochemically also she is not showing any sepsis. But still the duration of the time, I have seen the stressing the importance of the pediatricians asking the time, and for I think so for you people to manage the show. So early neonatal sepsis can lead to complications that we all know, everybody knows. Even the patient also is aware now. They will only tell better you deliver rather than me waiting. I think so they take a call. So like that, the importance has creeped into the minds of the patients, where they are taking early decisions and helping us to decide for the early delivery. So early detection and treatment of both early neonatal sepsis and chorioamnitis are crucial to prevent the severe consequences of to the newborn.
Thank you very much, ma'am. And regarding the tightening of the abdomen, most of the times the pregnant women come saying that tightening of the abdomen is there, tightening the persistence, even if you observe for a day or two after giving
today actually I have to tell you all, when I'm coming for this panel, yesterday one patient got admitted with high risk pregnancy. I would like to share with you all. You can also give the comments. So she's a high risk pregnancy with the 2 preterm labors of 7 months she lost, and she doesn't have any live issue. Then she had an ectopic that we managed medically. Then after 1 year, she conceived ovulation induction, and she conceived and continued till term. Yesterday she came and she said, I'm having some discomfort, but she's not telling me, explaining me at all. But I could feel the tightening. I just admitted her. So tightening is one of the indications that she's having some, but total counts are normal. But she's having that tightening symptom. So I can't take it lightly. I just groomed in for observation. So it is one of the sign.
When mother is saying that she is feeling some pain, and how we say that this is a false pain?
Yeah, see, it is a normal labor pain.
And the mother is perceiving the pain. Is the terminology false pain is acceptable? Because mother is saying the pain, I have pain.
Yeah.
Is it a false pain and we are saying?
See, there is a false labor pain. We teach students for each and every one. True labor pains, false labor pains. True labor pains are progressive in intensity, amplitude, and they come in the regular intervals with the increased amplitude, fundus down to the medial aspect of the thigh. But the false labor pains, they are radiated to the back, and usually they are relieved with the enema. So that we can say, and every postgraduates, I don't know whether they have an habit of sitting. Madam, contractions are there. How long they are lasting? They don't tell. They had to sit with the patient, feel the pain, whether it's lasting 40 seconds or not. And when we ask how long the contraction will be there in the second stage, that also will not be answered by them, because they don't observe. Unless they observe, the second stage labor contractions will last for 60 to 90 seconds. The first stage, 3 to 4 contractions in 10 minutes, lasting for 40 seconds. So definitely pain is there.
Ma'am, is endometrium sterile?
Yes, that's how the baby is continuing. If not, baby would have expelled, it would have landed up in a blighted womb or missed abortion earlier itself.
Then this chronic endometritis,
they won't conceive. They will conceive, but they will end up in early pregnancy failure. Early pregnancy failure. They will end up in a pregnancy failure, they will end up in ectopic, preterm, all consequences will be there.
that's what, because this birth channel completely sterile, or the baby is carrying that, because most of the mothers, they are not on antibiotics, yet the baby developed a multi-drug resistant bacteria from the womb. From where where the baby is getting?
Bloodborne? You have to tell us.
That we'll discuss. Dr. Shashidhar sir.
Sir, now
Dr. Shashidhar sir, here, this is the discussion that is happening right now. Because certain times in spite of the...
we have the vaginal flora is there, acidic environment is there. They suppress the pathogenic bacteria. So where is the chance for the ascending infection to go through vagina?
I agree with you, ma'am.
Apart from that, sir, we have to any systemic illness, for example, the patient suffering with any respiratory illness or any asymptomatic bacteria or any vaginal discharge, those some things, some small infections which might not be corrected during the pregnancy may flare up and may turn up into sepsis when they come at the time of the labor.
Thank you,
especially that's why the term of asymptomatic bacteria came.
Yes, ma'am. We will be discussing that in literature. That we are getting into that thing. That just we are giving the glimpse on it.
Yeah.
Sir, Dr. Shashidhar sir, certain times I am explaining the straight away case. The judge daughter came for the delivery, and that too it is real case scenario, and was continuously monitored. By the time of the delivery, the baby came out in proper first. SARS has developed, scleroderma was their baby, and the baby came out same, early onset sepsis, death has happened. And the baby has been continuously monitored in utero. And then the baby came out with the fetal inflammatory response in a peak state. How we will explaining this fetal inflammatory response, and what is this meta-inflammation that is causing this baby to compromise?
Yeah, so I think you put me in a spot, I think, with madam. Where did this come from is your question. So from recent research, what we have understood is that amniotic fluid is not sterile. And the fetal meconium is also not sterile. It doesn't mean that it is colonized with pathogenic bacteria, but it is not sterile means there are some microorganisms which can be isolated from advanced PCR techniques, from even amniotic fluid and even from first meconium, that the stool the baby passes. So if you go back to see the highest burden of neonatal sepsis, all the literature, as sir was saying, comes from the West, where GBS is the primary cause. But that is not our concern at all. Our concern is always gram negative and always has been.
and we contribute much more to neonatal mortality, unfortunately, than the West. You can.
There is an amniotic sludge.
That will come. Will come.
Yeah, amniotic sludge also by ultrasound. I think sir will speak about it.
How the predictors, everything will be there.
So where did this come from? Is still not completely answered. One, as Madam is all saying, it can be from the mother's genital flora, or it can be from the mother's GI colonization. With her. Second one, where did it come from? It can come from aspirating this, micro-aspirating this amniotic fluid, or it can come from the umbilical translocation. So what it does is, even when the fetus is inside, the LPS, the lipopolysaccharide, will trigger the TLR4 receptors, and it causes inflammation as a fetal state. And then if there is a high inoculum, it surpasses all the placental barriers that Madam had just mentioned, the skin, lung and gut, and the fetus is blessed with high natural or innate immunity. But it can get triggered on itself. That's the concept of meta-inflammation, that whenever this inflammation cascade is triggered just by an exposure even to a minute organism, and it can cause lot of release inflammatory responses, complement release oxygen free radical in the fetal life itself. Next. So whenever this happens, the interleukin 6, interleukin 8, TNF alpha, all these can be even detected in the umbilical blood sample, the first blood sample itself. So even then, as Madam rightly said, currently we are also not in favor of this early onset and late onset sepsis. This came because the early onset was supposed to be from mother, the vertical transmission, and late onset was supposed to be from environment or hospital or community acquired, horizontal transmission. But right now when we see the early onset versus late onset, because of high colonization pressure, are rampant. So it's not only the doctors who are supposed to be blamed for this. And if you culture all our surroundings, even the sinks, taps, all equipments which we use routinely in our labor rooms, we can isolate all these multi-drug resistant organisms. So we should question ourselves, is it early or late? Does it really matter? That 72 hours cutoff came because of that. When the babies got delivered, the first symptom used to come within 72 hours if it was vertical transmission. Right now, it doesn't matter where it came from. It matters what is the organism and what is its resistance pattern. So we should think about, right now we are not having a separate policy for early onset and late onset sepsis, because the antibiotic sensitivity is the same, the GNB is the same, and wherever it comes from, it is just sepsis like Madam mentioned. And if you see, even on day one, we have Acinetobacter, Klebsiella and E. coli. They are the dominant organisms. And they are all ESBL, that is multiple, they are intrinsically resistant to meropenem. We can't do anything about it, and we need to have higher antibiotics. So whatever AMPI Genta that is mentioned is hardly sensitive in most of them. So if you keep on seeing this is a LMIC studies, that low middle income countries. The GBS is very less. If you see even from first day onwards, the highest one are E. coli, Klebsiella and Acinetobacter. Acinetobacter was not quoted in any of our books when we are reading, and not even this Klebsiella. E. coli was supposed to be and GBS was supposed to be the cause. So we should think of it as a sepsis, which is a continuum, and not really differentiate into early or late onset. We just have to titrate our antibiotic based on our flora, which is persistent in our setting. So the concerning part is that if you give AMPI, almost 100% are resistant. Gentamicin, about 60% are resistant. The first graph is for Klebsiella, because sir was asking about MDR Klebsiella. all the cephalosporins 70% are resistant. They don't work. Some of the saving grace is maybe aminoglycoside, 40-50% sensitive. Vancomycin doesn't work for GNB. So what do we do? The Acinetobacter is even more resistant to all the organisms. This comes from antibiotic overuse and abuse, not only in hospitals, in all other settings that I just mentioned. Even our milk contains antibiotics, what we drink. So this fetal inflammatory response syndrome, where the fetus is already exposed to inflammation in utero because of this pre-activated innate immunity. So whatever antibiotics we give to the mother may not really protect the newborn. So that is the problem that we are facing. Because already the inflammation has started, invaded, this FIRS has started, there is a cytokine storm that it is going on, and it has high case fatality. So what should we do? Should we abandon this LOS and EOS in favor of just empiric antibiotics? I definitely think so. Is it possible to do surveillance in formulas that we use? Whatever comes in contact with the mother, the NST machines, the gloves, we should really think when we are focusing on facility delivery, are we really giving the quality of care that the mother deserves? And thirdly, if Ampygenta is not sensitive and colistin is sensitive, should it be our first line drug? I definitely don't think so, but we should find out a combination which really covers what the flora we are having. And can we do decolonization in the mother before the baby is born or when she gets into third trimester to curb this EOS? So what can we predict this early onset sepsis? There are multiple, like and generate some models where if we put in the risk factors and we get a probability of early onset sepsis in this child which is going to be, that might help us. So the summary of my message is we have to recognize this. It is gram negative and most of it is antimicrobial resistant. And that split is not really useful. Your data should drive your antibiotic policy. We should always focus on infection prevention and control. There is no way out of it. And we should still do a lot of data collection in our setting and not rely on whatever is the West is trying to give us.
Thank you, sir. Madam, when Dr. Rajini ma'am, and even Dr. Manish, the same thing, question for both of you. How do we explain this multi-drug resistance Klebsiella in neonate when the mother had no recent antibiotic exposure and the fetal growth was normal? Yes, ma'am.
Yeah, multi-drug resistant Klebsiella, when you say that, it is not responding to more than 2 groups. There's more than 2 to 3 antimicrobial classes. So it includes resistance to the beta-lactams, aminoglycosides, and even fluoroquinolones. So extended spectrum they are also that what we are using, they hydrolyze the cephalosporins. So the meropenem, ertapenem, those are the drugs, they respond to this Klebsiella. So the commonest organisms what we are seeing is the Klebsiella pneumonia, E. coli, Proteus, mirabilis. So these are the organisms what we come across. E. coli is the commonest thing, commonest organism what we are finding when we culture. So whenever the patient comes to us with a problem only, we are searching for a screening. We are not doing a routine screening for the infection for all pregnant mothers. That I had to...
This asymptomatic bacteriuria showing ESBL?
No, that is a separate entity. As they are doing in the Western countries, they are doing the rectovaginal swabs and all that vaginal urine culture routinely screening for the infection in a pregnant mother. But When she comes with the problem, with the preterm labor, there's a protocol where we do the cervical swab and other one is a urine culture apart from the blood test. So that's one of the important, another risk factor in a pregnant woman is always when the patient comes is a asymptomatic bacteria should be kept in a mind. Need not be that she should have a symptoms. So as we all say, more than 1 to the power of 5 organisms are there, and without any symptoms, the asymptomatic bacteria is there, and you do a culture sensitivity. Don't randomly start off with the antibiotic. I think so. Definite culture should be proved to start any antibiotic. And routinely, I think so, all have a protocol to start off with the ampicillin is the commonest drug. But the patient can have diarrhea. Then other one is a culture sensitive drug only to be start, and amoxicillin clavulanate if she is sensitive. But one more thing, newer drug for the asymptomatic bacteria, phosphomycin, single dose therapy will suffice. That will definitely prevent the further infection. And nitrofurantoin, I think hemolysis is the common problem. And trimethoprim sulfamethoxazole, that's the Bactrim DS. What we should, we used to use those days before cephalosporins were there. I think so those are the drugs were commonly used, but now we cannot use as we have a better drugs. So avoid in the first trimester and near term, only if use only if benefits the outweighs the risk, then only use it. In a more resistant and complicated cases, meropenem and ertapenem, and though patient is clear of the asymptomatic infection with the repeat culture which is done after 2 weeks. So guidelines, the special consideration, do not ignore asymptomatic bacteria in pregnancy, and as per the guidelines of ACOG and NICE, recommended treatment even if the women, if she doesn't have symptoms. So the extended spectrum beta-lactamase colonization, if it is detected, inform the labor and delivery staff. Risk of the neonatal colonization and early onset sepsis exists. So screen for the diabetes and other risk factors, as we all know, we definitely screen a patient whenever the patient comes with the routine antenatal checkup. So now WHO has extended antenatal care where the minimum 8 visits. So in that 8 visits, definitely we should screen, prevent and treat infection so that the baby, when we hand over to you, will be sterile.
Yes, ma'am. This is something you are explaining about the colonization and the persistence of the bacteria.
Yeah.
If you want to know this colonization and persistence of this MDR bacteria, if you want to screen, what are the samples that you can collect and screen?
That's what, if you want to screen, we do the vaginal, high vaginal swab or a cervical swab.
What week are you
and
collect it? No?
Yeah.
At what weeks you can collect? No?
If she comes with the symptoms, right, if she has any threatened preterm labor, like that only we are doing it. Routinely we don't do cultures.
That's one, because she is developing
But,
asymptomatically.
yeah.
If you want to keep some screening guidelines,
Yeah.
how we can? Because now the baby is in MDR Klebsiella. If you want to bring some screening guidelines, at what week we can collect for
28
every
weeks,
mother these things?
28 weeks ideal. Because 32 weeks, less than 32 weeks is definitely dangerous for us. 32 to 34 weeks is the grey period. And more than 34 weeks, I think so, salvageability is very good. See, before we used to define 28 weeks as abortion. Now we have come down to 20 weeks. We are able to salvage the baby even with the 600 grams also. They are going home with the weight of the 600 grams.
Yes, when the sterile environment is
Yeah,
being provided.
yeah.
Sir, thank you, ma'am. Thank you very much, ma'am. Sir, regarding Manjuna, sir,
Yes.
the same thing. This baby got this MDR Klebsiella. This baby got this MDR Klebsiella. After this MDR status, this baby acquired for this thing, whether after entering into the blood or before entering the blood itself, the baby has this MDR Klebsiella.
Thank you. It's a very important question. I've also got some slides.
Yes, sir. I will keep.
Yes. You know, in terms of the one which Storia is shared through the poem was a real scenario about 31-weeker, and I was the doctor who went and reasonably reassured the parents because there was no risk factors for infection. And as we all discussed now, we were very positive to give a good outcome for that baby at 31-weeker and around 1.2 kilo baby, but that did not go that way because of due to the MDR sort of thing. Now, just to take a step back, what I thought was to look into a bit more of the vaginal flora. And what we need more of, which I could not find it, what is the vaginal flora in the community even when they are not pregnant. But what I got is something during the pregnancy period. As we all know, and it was emphasized earlier, predominantly once they get into the menarche, it's lactobacillus, and which produces the acidic pH, which means the pathogenic bacteria cannot survive there. However, there is various prevalence of bacterial vaginosis, somewhere between 10 to 30%, and more so in the pregnant ladies. And this was one of the publications which was published not far from here, from Pondicherry, where they looked into all the pregnant mothers coming from 18 to 40 weeks, and if they had some vaginal vaginosis or discharge, they were screened. And they had a good sample, around 500 samples were collected, and out of them 252 was positive. And as already shown with many slides, predominantly it was all gram negative. Whereas in the before coming to, while I was in UK, I was only dealing more and more of gram positive, and GBS was the main killer there. And now as you can see here, almost 60% of the bugs were gram negative associated with either E. coli or Klebsiella. So that gives us enormity of what we are dealing with, which is gram negative bacilli. And if I go a bit more further, what was the multi-drug resistance already? I did not add the use of antibiotic in those mothers, but not all of them would have been given antibiotics before they took the sample. And in that one, you can see nearly around 60 to 80% of them were resistant. So this was the bugs which our babies would be bathed as they come through to us. So we would be dealing with multi-drug resistance. And since then, I found many other studies, which is not there, but this was another big study which was looked into the special care baby units from big 5 district hospitals, where they were like level 1 or level 2, which means no long-term ventilation there. And in those, currently there is no way they can do a blood culture, but however with the associated tertiary center, they did a study. This paper I can share, which is multi-drug resistant sepsis in special newborn baby units in 5 district hospitals. One was from Assam, another one from Jipmer, Pondicherry, and around Delhi. This was a big population where they recruited 6,612 neonatal babies during that period. Out of them, 3,300 were screened for infection. Out of them, 213 had positive blood cultures. There was 3.2% was the positive blood cultures. There, they did not divide into early onset neonatal sepsis and late onset neonatal sepsis. Like as Dr. Shashidhar mentioned, that is not adding much value for us from that point of view. And in those, 84% of the Klebsiella pneumonia they noticed were multi-drug resistance. I'm talking not about tertiary centers, I'm talking about small units. And even the E. coli was around 85% multi-drug resistance. So now what they could summarize was the multi-drug resistant pattern observed in the district hospital thus mimics almost as though it is reported from a tertiary care center rather than what we would have seen in the community bugs sort of thing. All of that made me to think, me coming from working in the Western countries and coming here, where are we with our antibiotic policy made me to think, and which I have not shared, but some of the articles shows here we are using reasonable antibiotics, and one survey where they called the parents, this was collected from 1,700 phone calls to the parents, asking in the last 2 weeks, did your child had history suggestive of upper respiratory tract infection, and how many of them received antibiotics? 20% of the phone calls where they suggested there was upper respiratory tract infection, less than 3 years received antibiotics. Do we really feel that 20% of the upper respiratory tract infections are due to bacterial infections or questionable? And when I was a kid, I was treated with amoxicillin and those sort of things. But now those are out of the box. You know, nobody treats with those. If something augmenting, and on a daily basis, I'm seeing one patient at least where the parents themselves have started the antibiotics before even coming to me. So where are we changing the gut flora, the bacterial flora, what we have got is a much a bigger question from that point of view. And in the UK, there was another study, and they said less than 2 years, 70% of the kids could have had 1 dose of antibiotics. I think that is still sounds for me a big number. Because you know, in UK, for me to get an antibiotics for even my own child would have been much more harder through GP, and I have to go through much more appropriately different route if I need it. So now coming back to the question, how early onset neonatal sepsis with this child got, as Shashidhar and we all mentioned, because was this already colonized, or did that move from instruments to the baby, or due to the examination, or is this a bug what you got in the community already there? And even contact with colonized family members, treating the antibiotics, prior antibiotic exposure, or even surgical procedure in the past. The other question which came up was, did this
is in vitro or in vivo?
In vivo.
Because before coming itself, this is a mother who has never on antibiotics. Now this baby has grown very well inside. 3.2 kgs baby came out with a multi-drug resistance Klebsiella, which you are unable to treat with any of the antibiotics. You have used almost all the antibiotics and you are failed to save this baby. This is something a very alarming symptom.
Yeah.
Why this poor baby has developed in utero and then died. 3.2 kgs just died. We are able to see, Mary saying 600 grams baby is smiling and going, but this 3.2 kgs baby died like.
Yes, yes.
How? Why? And then another thing, if this has acquired from in vitro, means this bug from the before entering into the baby itself is a multi-drug resistant. And why this bug let this baby survive up to 3.2 kgs inside, and then the baby came out and died? Where were we failure, or why this bug is so psychotic that this baby let the baby till the delivery time and that killed immediately?
Thank you again, a very important question. Just it takes me back to my own 31-weeker, and that baby was good up to 24 hours, and we were doing the ward round. By the end of our ward round, this baby needed quite a lot of respiratory support from CPAP, went on to intubation. My echo showed a significant PPHN, and we were on a lot of inotropes and sort of things. So when this, as also Dr. Shashidhar mentioned about meta-inflammatory response, when does that happen, and what is the juncture when the babies move from simple infection to a systemic inflammatory response syndrome is a big question, and I don't have a clear answer for that. But most of the literature says about already existing multi-drug resistance, particularly as we are dealing in the hospital environment or the multi-drug resistance because of due to the other factors which we discussed. Maybe only a small number could have been evolving multi-drug resistance later because of the use of the drugs. Only the resistant strains could have survived, or through the transfers of the genetic materials from one bacteria to the other group of bacteria through the plasmids, or also called which are written over there. So they can jump, these genetic materials can jump from one bacteria to the other bacteria to give that immunity, but that goes as less than 5 to 10%, and most of the times that is when the babies are in the unit for a longer period and we are given the antibiotics for few times by that time. So very hard question, but multi-drug resistance is the one.
This is something we need to understand. That is the reason we kept it up, because this baby, where one other baby is going from 600 grams to home, this mother was unable to carry this baby for 3.2 kgs baby, and in utero completely grown up. What that meta-inflammation that helped for, this is where we need an understanding of the meta-inflammation, why this metabolically completely damaged organs, and then the baby came out and died. That is where we need to be looking inside this thing. This mother got this MDR Klebsiella before entering into the blood. This is not something the baby got after coming outside and then we have given some antibiotics and antibiotics. This mother is never on antibiotic, because this mother is delivered in Cherpalshere, I know that thing. And this is a Kerala remote place where in another 5 kilometers if you go there, they won't even have the huts. They will be living in the jungle mother. And this was never the mother was on antibiotics. See what is happening. What is happening for this mother? And why this psychosis? This is why I just kept this slide. If you have gone through the Arundhatana, this person will be trying to find out what is the origin, why. There was a clue written on that portrait saying that this has been like this is the one that can kill the person, and I say. But exactly when it comes to exact place where it is located, and he will burn it. That is the psychosis that he showed towards them. Then why this bug is showing towards psychosis in this baby? This baby came out happily over 3.2 kgs and died within 2 to 3 days. And we labeled it as an early onset sepsis. And certainly we need to look into this is the highest burden of India. Most of the babies are dying. We speak about the ventilators, HFO, we send these things, but we are unable to save these babies. Where we are lacking? Why we are screening where we are lacking? This is one which we need to think about this thing. This is why we are all here right now. And importantly, now the discussion starts like, why it is gram-negative in India? Why it is gram-positive outside? A mother who has been delivered, this is the original case, a mother who has delivered first pregnancy, first baby with 32-weeker, having the gram-negative sepsis here, went to UK, after 3-4 years or anything, this mother got the early onset sepsis again with the GBS there. How this transferred? And now we will be discussing about that. What is that logic? Because the books never mention these things. This is the, we are afraid to discuss. That is the problem. We are afraid to discuss. Why gram-negative here? This mother, poor Indians, are suffering from the gram-negative sepsis and they are gram-positive. Why we are suffering? No books are mentioning. What is the hypothesis that we can collect over the generations, over the wrapping to multiple persons? We are trying to expose here. And you can come up with your own hypothesis even. Well, this is to the floor even. Madam, this is one of the hypotheses we have discussed and projecting. It's not that you need to take it as a theory. This is the hypothesis we are proposing. And if this turns down to some other time a theory, we are awaited. And the hypothesis which we are proposing is, you can go to, madam, can you explain these things? Because this is something which we have discussed and we are projecting, but the floor is open. If you want to tell some other hypothesis or theory, we are welcome.
Hello, good afternoon, everyone. This is regarding the question why gram-negative infections are more common in Asian population compared to gram-positive infections in Western countries. There is actually the exact answer or exact cause of it is unknown. We have come out with an hypothesis based on the geography, climatic and lifestyle and cell structure of the organism itself. That could be the reason for it to be gram-negative to be more in Asian compared as gram-positive in Western countries.
Just see the location, how this is being there. India, what is the surroundings and the heat building. And this is how it is. You can see Iceman. Okay, that's we want to explain. This heat wave, how is here, and cold wave, how it is here. That the environmental factor.
In Asian countries, as we know, most of the Asian countries lie in the tropic and subtropic areas, where the warm and humid temperature will be there almost most of the year. And the countries like India, Thailand, Indonesia, all of this lie in these Asian countries with a relatively high humidity of around 60 to 90%. Even it is, whereas compared to the Western countries, they lie in the temperate zone, where the humidity will not exceed not more than 40 to 60%. And even though there are some seasonal variations there, but still the winters are dry and with mild humid summers there. They based on that and even some seasonal variations or patterns which are seen are, even the monsoon rains will make the summers extremely humid in Asian countries. And winters relatively they are dry but not so dry, as because Western countries are almost so our winters may not be so dry as compared to the Asian compared to that. And one more is the indoor lifestyle, whereas in Asia where the low socioeconomic people are there, we preferably depend on natural ventilation, ceiling fans or open housing styles, where we are more prone to this ambient humidity. Whereas in Western countries, most of them will have air conditioned closed cabins, air condition or heating devices. So they are more prone to dry. And why this dry humid I am talking about is because this gram-negative bacteria generally prefer a humid or moist environment, whereas a gram-positive bacteria, they prefer to survive in a dry environment. So this question of dry, humid, this we have to talk about. Then what is that which causes the gram-negative to prefer a humid, whereas gram-positive for a dry environment is based on the cell wall. Yeah, they have a thin peptidoglycan layer and an outer lipid layer. This thin peptidoglycan layer is more vulnerable or more sensitive to a humid environment, whereas the thick peptidoglycan layer of the gram-positive bacteria is resistant to it, and they have a better resistance to it. So they grow only in a dry environment, whereas the gram-negative, because of the thin peptidoglycan, they thrive or they prefer to be in a moist, humid environment. So Asia being a moist, humid country, or this one, so we find those bacteria more in the gut, urinary tract, and other hospital humidifiers and any wet surfaces. Whereas gram-positive, they tend to colonize on the skin, dry hospital surface, and that is one of the reason which, it's only a hypothesis. It's left to the anyone who can come out with some better answer and all those.
Thank you, ma'am. Because this was a discussion that has happening since 5-7 days, and why, and I say, and that we have some other hypothesis we have, but we are proposing. If you accept this hypothesis only, you can speak. Now, other things we have discussed. See, the gram-negative is spraying the slime area, and there is a moisture. This requires moisture, humidity. Almost we are having our culture, our dressing, and we are made up in half-baked Britishers. We are making ourselves humid. And then we are keeping ourselves humid and moist. These exactly thrive in the humid moist. See, actually I don't need these things. I made because I am a baked up, half-baked one. Okay. And they have left us in this way. Otherwise, before and when maybe they might be having another structure. Very freely we used to wear it. And that lifestyle that has happened. And the environment is something, and we are living like other thing. And that is the reason this gram-negative bacteria forms a slime layer. And very high antibiotics are required for this to penetrate even. See, all the genital area is wet. Added to that, the cultural practices. We keep most of our genitals as a wet tone. That brings some other opportunity for the organism. This moisture and humidity is letting the organisms to grow, keep a slime layer, happily live there. And the antibiotics which you are giving is not penetrating that. And then this is proliferating. This is community acquired. Happily, this MDR Klebsiella is sitting there and took some root. And this, you can see the layers. This is staph. Because these are forming spores, dry spores. So they can survive these dry areas. This is E. coli. You can see Klebsiella, how this is moist. Wetness. Humidity is a killer here. Klebsiella, E. coli, Acinetobacter, Pseudomonas. You can see, even the Pseudomonas also, same things. Always the competition is happening between the gram-positive and gram-negative. You see one area. Either they will be in the gram-positive Staphylococcus, or if not there, there will be a Pseudomonas. If you are trying to prevent the gram-positive there, Pseudomonas is evolving. You can see there is always the competition that is happening in between these two things. You can see everywhere, even Acinetobacter, moist. Link with geography, and that we linked. We searched it and spoke with multiple people, and we linked. But if there is some other hypothesis or some other theory you want to propose, you are welcome. And sir, if possible, in the NICU, if the baby is acquiring from the NICU, what are the wet surfaces that is transferring the infections? What are the dry surfaces that are transferring infections? Kindly throw some lights. You can. Acinetobacter, dry surface, pens, moist, and these things. And then there is a humidifier we are using. In the humidifier, what is that like?
Sir, one study. Sir. So, hospital-acquired infection, especially from the NICU, Acinetobacter baumannii spreading through wet contaminant, through the wet hands. So, a study has done. So mostly from the wet hands, sir.
Okay.
Histobacter baumannii.
Sir, how
Second thing is
how the baby is acquiring these infections, from which surfaces? Acinetobacter from where? Klebsiella from where? Acquired.
You know, our incubators even are
incubators.
wet and moist, and as long as it's not properly cleaned, thoroughly cleaned, that's a risk. And any table surfaces what we are using next to the babies, sometimes there is a spillage of milk. All of that is a threat to what we are doing around the babies. And even the, you know, when we are doing some procedures or using some of the information to the parents, what come next to the baby, what comes from outside of the unit, what is there already existing, all of that are a risk. How do you find the balance is always a big question. So anything which we are going to touch, and my practice, you know, in most of the Western countries was before touching any baby, it's in the NICU setting up. It's not just the chlor prep or the pink solution, it was always wash hand and then only touch the baby. And after touching the baby, in the ward round I would have washed 10 to 20 times my hands. And when I'm week of service, my hands could have got a bit dry until I was very careful with using the moisturizing cream.
Kindly check those things. And from where we are transferring? What are the wet surfaces transferring these things? What are the dry surfaces? What are the fomites that are transferring? Fomites. What we are bringing, and what are pens, pencils, and then these things that they will be transferring. And how the mothers are carrying. Okay, these things that we will be keeping in mind and then cover it up. And anyone on this floor can come up with any of the hypotheses you think in your own thing, and you can propose. And this is floor will be open for throughout the day. And Dr. Suresh, sir. Sir, how to know through the ultrasound something is going wrong? The baby is completely in the early onset sepsis, or the baby is in sepsis. How exactly this will help us in these identifications?
Yes. Good afternoon, everyone. In this clinical scenario, ultrasound plays a very important role. Looking at the discussion, the fetus could have acquired infection either vertically or horizontally. So, can we, so the role of ultrasound is to find out the telltale signs. Firstly, we need to examine the cervical canal to begin with, the length of the cervix, the vaginal, the endocervical canal, whether there are any thick copious secretions, or is there any chronic cervicitis. These are the things firstly we need to assess. Secondly, coming to the placenta. Placenta will tell us if there was a long-standing intrauterine infection. If there are calcifications, fine or a coarse calcifications, it tells that there was a long-standing silent infection. And if there are any, because this is a case of sepsis, are there any associated placental infarcts? One is, it will tell us about the long-standing scenario and an acute scenario. Coming to the fetus per se, we need to survey the fetus. Right from, since it's a case of sepsis, it can affect any organ systems. The important, the craniospinal axis, leptomeningitis, cerebritis, ventriculitis. Then, since the fetus is having tachycardia, before this, we need to concentrate on the heart. Look at the heart, whether the chambers are symmetrical. Is the squeeze proper? Is there a pericardial effusion? The lungs, is there a pleural effusion? Then, coming to the thymus, assess the thymus, look at the size. Then, the head, the meninges, the cerebritis, ventriculitis. If there is an hydrocephalus, it tells that there was a long-standing infection, and that's a telltale sign of a long-standing infection. Then abdomen, very important is look at the spleen. Once again, the calcifications will tell you that it was a long-standing infection. Then look at the kidneys. Very important, adrenals. It tells you that if there is an adrenal hemorrhage or an enlargement, it tells you that it is an acute condition once again. And ascites. This is about the general survey. Coming to Doppler, Doppler plays a very important role in assessing the clinical scenario and the outcome. we have the MCAs, the uterine arteries, then your ductus venosus. In this scenario, the MCA is by default it's an high resistance circulation, and the umbilical artery is a low resistance circulation. When we assess, the RI and PI in MCA is always high. The RI, PI and the STO ratio is always high, remember this, as compared to the uterine artery. Whenever there's something going wrong, especially like a scenario like this infection, the PI and RI will try to first, because of, it will drop initially, then there will be pseudo normalization, then because of edema, then all these parameters will persistently be high. Then the uteroplacental ratio is normally 1:1. This will drop. It will become less than 1.1. So this tells that there is an altered hemodynamics. And the uterine artery per se, normally it's a seesaw pattern of waveform. Whenever there is it's a low resistant waveform. Whenever there is an infection, the diastolic flow will start reducing. In severe cases, there will be a reversal of diastolic flow. That tells that the condition is very severe. And finally, when we look in this scenario, when you look into the Doppler assessment of the ductus venosus, the A form, the A, if there is a decrease or a reversal of an waveform, in this scenario, it tells that it is going to an impending death. And that's the time when we look at this, especially the obstetricians, we need to, take a call. We should not allow the pregnancy to continue. So these are the parameters. I forgot to tell you another point, that is, we have to look into the amniotic fluid. Normally it is, anechoic. In case of infections, it becomes very turbid. It will become echogenic. There will be a lot of echogenic floaters. This tells that, there is also chorioamniotic.
Chorioamnitis. Sir, regarding thymus and adrenals, can you throw some light, sir? Because the first organs that go under alteration when there is some infection or the immunity change is the thymus and adrenals.
Yeah, whenever there is a crisis like this, sepsis, always there will be some adrenal enlargement and adrenal hemorrhage. We have seen, normally we do document in fetuses. So adrenal hemorrhage is one complication which can set in, and the thymus per se. Thymus.
Because the first organs that are being insulted, following this insult, are the thymus and the adrenal glands in utero.
True, because there is a immunomodulation which is happening, and these are the organs which are involved.
Yes, sir. Thymus involution is happening here. Apoptosis is happening to the lymphoid tissue, and then there will be decrease in size. And both thymus and spleen are the lymphoid tissues. So when there is an ongoing sepsis inside, these two will give some clue where the thymus will be shrinking. The apoptosis leads to shrinking, and the spleen. Followed by that, you can see the thymus and there is this one is a short thymus, enlarged thymus. Amniotic sludge, sir. This was what Madam is explaining. This is called as an amniotic sludge. When you find an amniotic sludge, obviously if you try to drain it, it will be having mostly high drug resistant bacteria will be there. And most of the mothers who are having this amniotic sludge, the babies will be having a severe form of the sepsis, and they will be coming out much premature. Preterm deliveries are very common with these things. If an ultrasound couple finding, if you find there is an amniotic sludge, be aware that this baby is going to be little troublesome, and this delivery also will be troublesome. The baby.
Madam,
we have trained.
I was reading through the papers and journals about EOAs and multi-drug resistant then only. But how far you people are taking search for this amniotic search?
To be very honest, normally we look as do the amniotic fluid assessment. We observe the amniotic fluid. The turbidity can be easily made out. Normally it is anechoic. When you find a lot of echogenic floaters thick, and something in the dependent position, easily it can be made out. It is not something great.
Yes, sir. So this is obviously visible. And if you find something like that, try to drain it, and then you check for the organism.
How it looks like? What is your?
It looks echogenic, bright.
Echogenic.
Bright. It looks bright.
Debris.
Debris. Yes, it looks bright in the dependent with layering.
Do you take the thickness? How do you measure by volume? How do you measure this sludge?
Just observation?
No, see, one is this is madam. One is the sludge per se is by observation, because we have a clinical scenario, we observe and we say that it is exudative. And this, if you want to exactly quantify, only when it is thick, we can quantify. Otherwise, normally we don't quantify the sludge.
Most of the
Sludge is
babies
not
delivered,
quantifiable.
I observed 3 cases, 3 babies were in the FIRS only, fetal inflammatory response syndrome. Thank you.
Your question. One second, madam. Junaid, you want to go to Junaid last. For the question of Dr. Rajni madam, see, she has asked very clearly, you have to be crystal and clear, loud, because it is little
forward.
going, little monotonous. Come, Junaid.
Come forward.
Junaid is
Can
an
you repeat the question
interventional
once again
radiologist.
for me, ma'am, so that I can be a
Come,
little
come dear.
clear?
Come dear, Fred, that doesn't matter. See, it is a discussion things.
Yeah.
Don't worry, we are all in the same boat.
Of course, of course.
He is
Yeah.
Dr. Junaid, interventional radiologist. Okay, and you will come to know who is he when he talks. Okay, madam is asking simple, crisp and clear.
Yes,
Don't
ma'am.
beat
Can
around
you
the bush.
repeat the question once again so that I can be more
No,
specific?
the sludge, no. How do you describe as a sonologist?
So-
and how much importance you give to it? And
Yeah.
sensitizer has to react to that.
Yeah. So a lot of patients, the positive predictive value of this sludge or ecogenicity is very poor. So when most of the times in third trimester we see a lot of ecogenicity within the amniotic fluid. So what happens is we give it as ecogenic fluid, and then that is most likely probably we say that probably meconium stained or what so forth. We will not know the exact etiology as to what is the exact reason why this ecogenicity is present. It may be more of amniotic cells, skin cells, or even hair for that matter. A lot of times we've given that, and we've seen that after delivery it is normal. So the positive predictive value or the specificity of the ecogenicity of the fluid is pretty low. Telling that it could be due to infection is like almost close to impossible. That's what I would say.
We observed
yeah.
3 patients in the same sludge, and we have aspirated, and the babies were literally having the FIRS syndrome. Okay, now the baby came up with a proper sepsis. The baby was completely in a SIRS, and most of them twice the 2 babies expired. Okay. Radiologist will do that, madam. They will do it. We can ask that, madam.
So we want to know whether when you have seen the sludge, was there a culture sensitivity done for that?
Done, madam. Done, madam. From the obstetric side, it was done.
Huh.
And she noticed something like this. It came,
So
sir. And
wha-
we asked
what
for
was the
sludge.
culture report, sir? Any positive cultures?
I didn't remember, madam, but it was positive culture.
Positive culture.
culture.
Okay, sir. So another thing I wanted to ask, we are talking about, sirs, we talk about high leak, sir. Sometimes amnion and chorion, whatever the genital tract or whatever we are talking, usually it is well protected. The fetus is well protected within the sac. But we have one concept which we think could be the cause where this breach of the amnion and chorion, which is protective, there is a breach in that. So that is a high leak where there is a small rent in the membranes which could be responsible. So have you considered that possibility in this fetuses which are born with SIRS?
We haven't, madam. We will go through. But most often we will use to correlate with the funiculitis.
Sir?
When there is this breach and everything, there is a funiculitis, an umbilical cord vessel, where there will be clear-cut redness, and then when we send for those
Need
things,
not be, sir. Need not be. It's not a overt rupture of membranes, but there is a high leak. There is a rent somewhere in the amnion and chorion, where there is a small leak. The amniotic fluid volume is also maintained in these because the production is also correlating with the leak that is there. But these babies don't tend to do well. So we just wanted to discuss if you had any
And we
experience
do
with
continue
that.
the pregnancy. When high
They
leak
continue.
patients are come, no? We continue the pregnancy. We don't want to terminate.
Then
Sometimes high cells will heal on its own. Sometimes high leaks they tend to heal on their own.
As radiologist will be explaining, they will be observing, you will be observing fetal movements, CTG, everything will correlate. Not on single factor, never we can decide. Take consideration everything.
So because
Sir.
many new points you're bringing out,
Yep.
sir. So we also
That's
want to
good.
know how much importance we should give to sludge next time something
Complete
like that is
guarantee it's
reported.
important.
And whether we should go for cultures. These are the two take-home points we want.
Madam, for your question, sorry, you are all great, but the thing is, sludge, preterm delivery. What I mean is, amniotic sludge, preterm delivery, number one. Number second,
sludge with leak, preterm delivery. Sludge, whatever you told, the high leaking, the rent, whatever you told, the flow, flaps, okay, with preterm delivery, culture sensitivity. Then one more thing, term delivery or near term delivery. Like that, there are more than 15 articles are there, 15 articles are there only on the sludge and the thickness and the girth of the sludge, whether it is there. Then whether floating articles and the delivery, why the babies are, one question was there, because I know some people are hungry, but we had around 11 o'clock only breakfast.
No issue, no issue, no issue.
Okay,
This is
please,
more important.
please don't curse me. No,
No.
Your question, madam, your question. See, madam was asking that there is an article, I'll send now only to in the group, all perinatal 1, 2, 3, 4 participant group, I'll send right now. One. Second thing, madam, people were asking, Shashidhar, you were telling something to, he was telling, I don't know. Okay. Why, if the baby is getting infected inside the uterus, how it will survive till term? If it comes out, why the baby will die because of EOS?
No
Means,
answer.
Wait,
Including
madam,
EOS.
madam, income, finish child. Okay, number one, please. Okay, in that, this thing only, please, if anybody is having, you can see something, there is a called a inflammatory reactors. I think so Guru Prasad knows. Okay, whatever it is there, it in that article only, because before this, and I think so whoever in 2007 we are doing every at least 4 months, Guru Prasad sir knows, every 4 months we used to do the conferences. Like that I used to read the lot of articles on that grounds I am telling. Okay, I'll send the article also. See, it is like this, plasmapheresis. You know what is, everybody knows plasmapheresis here. Whatever unwanted things, it will filter it. Whatever the necessary things, it will send back to the baby if you are putting the plasmapheresis. Like that, plasma will act, placenta will act. It will take all the inflammatory things. On that grounds only, you know, when the baby had, our neonatologist, when the baby had, it was very much high in during 2007 to 2008, sir, which is that medicine when baby was having too much sepsis, we used to give for that baby, which is that medicine we used to give for too much sepsis. Early we used to give pentoxifylline. Everybody we know, because now it is not there. No, on that grounds only, you told no madam why, okay, all the inflammatory reaction is coming back, placenta is filtering, taking to the mummy will excrete it is. Like that baby is getting served. After that, that is cut off. Because of that inflammation only, baby is having CNS problem, baby is having cannot tolerate, and baby is having what is it, like a, you know, sudden birth asphyxia. Why within 12 hours all the blood vessels will have diastolic more flow, systolic more flow, and RI will come down. So diastolic flow will come down, death rate is increasing. Like that, it won't happen inside the uterus, but when it cuts, when the baby comes out, that is the reason babies will die, need more inotropes. Whatever you give, it is not even with corticosteroids. So madam, that is article within 10 minutes, I think so it will be there in the groups. Okay, I think so we will go to the next, if it is, okay, sorry.
Sir, my simple question, sludge is equal to vernis caseosa plus skin debris of the baby, are the same or different?
Sir, everything is written in the exact 10 minutes.
When evidence is there, boss is there.
When a judge is there, we can take direct answers, sir. Please, sir.
Sir, these are the normal components of the fluid.
Yes,
These are
sir.
the normal components.
Yes, sir.
But whenever there is an meconium aspiration, it becomes more thick.
Yes, sir.
More thick. That's another thing. Or if there is an hemorrhage, it becomes more thick.
Yes,
these are some
sir.
pathological hemorrhage, and these are pathological conditions. Otherwise, the normal components of the fluid is, as you said, the vernis caseosa, the skin cells, and these are all the normal components where, to certain extent, in the last trimester, it looks, slightly echogenic. Echogenicity is not the only sole criteria. We have to look into the overall clinical areas to other parameters and the clinical status. We should not take this as in isolation.
Yes, sir.
Then we'll be
Thank you.
misled.
Thank you.
Dr. Akhilam, you can.
Last 1 to 2 minutes. So I would like to just add about the data and the practices when compared to the Western and the low and middle income countries. So here we can see in higher in Western countries, though 30% of the newborns has exposed colonization of the maternal bacteria, only 2% developed GBS because of intrapartum antibiotic usage and routine screening of the pregnant women. And next slide, sir. And coming to the Indian data, which is a famous Dennis study, where as already mentioned, madam, and all this discussion and beautifully the journey of microbiota explained by Shashidhar sir and how baby, same thing in this Dennis study also they have explained, where it is the LOS, US, the organisms are same, and it is horizontal transmission from delivery room, NICU, and through personal hygiene or unhygienic OPD or delivery room practices leading to the infection. So we need to more concentrate on the infection control practices straight from the personal hygiene to the OPD to the delivery room to the NICU. With that we can decrease the sepsis rate, and unfortunately we are in a situation where we don't have any reserve antibiotic. So and with the supportive care we cannot save the babies. Thank you, sir.
Thank you, ma'am. Thank you. Thank you, ma'am. Thank you. Here is every one of you can show some interest and then bring out some other hypothesis by next time when we meet up. So that we will meet once again and bring one of the best consensus statements from this. And
anybody wants to tell one question, please? After this, we will close. Any one question?
Routine screening in the mothers.
Madam is having some.
Routine screening in the mothers, can we some.
High risk. So, routine screening is not
Urine is
recommended, but every trimester we can go with urine routine. By that, if any bacteria, anything is found, then we can go for culture to know that.
According to WHO, we do the monthly, every month visit, no? Hemoglobin, urine routine. So that will definitely, in high risk patients, definitely we go for further procedures. And especially not only leukocytosis, CRP. CRP also is indicator for the infection. When we are monitoring
can I also
sepsis,
add,
CRP levels.
asymptomatic bacteriuria is at more higher risk than just a vaginal swab result. So I think
yes. That's one of the first.
More studies
thing we have to evaluate.
More studies on asymptomatic bacteria, vaginal swabs.
Yeah, many more studies are there.
Suddenly
they have done studies.
Coming up with the protocol.
More so, last word, sir, one last word. We are using the antimicrobials within our hospital, but these are overused, abused outside. That is one of the reasons for getting the multi-drug regime, say, these molecules. They are being abused by each and Tom, Dick and Harry is using outside. So we are getting the effect of here. Nowadays, today is the best molecule, get it, but they use outside. Even, I don't want to mention the what pathies, and we get these resistant drug, say, organs inside. That should be kept in always. Thank you.
And one more important thing is pesticides in the food, that has been, very much the reasons for one of the things, because all the tomatoes, whatever we are eating is all pesticides, including your poultry. Yeah.
And one thing with this forum, I advise you all gynecologists and pediatricians, don't say to the patient, urinary tract infection may be one of the cases landed up in hysterectomy, peripheral sepsis and hysterectomy in one of the hospitals recently. And it was told to the patient husband, urinary tract infection was not tackled during antenatal. Really? Or he was he's a police department. It happened, I'm telling you all.
Bakre ko sher ke haath mein diya hai.
Be extra careful.
No, he was told.
Bakre sher ko diya hai.
How to explain him?
Very bad, sir. That has to be having.
Most probably,
100%
have not taken care of urinary tract infection.
Definitely,
my wife landed up in a peripheral.
Definitely, madam. Similarly, sonologists with due respect, why this anomaly was not detected earlier? Go and ask them, because it can happen later in the process of the fetal development.
I'm sorry, with due respect, please do keep us also in mind. Operation is also your kids only. Don't suddenly give us to shares and all to eat us away. Eat us away.
I
So
think
thank you. Thank you.
One more
the
thing I
time
want
for
to say,
super
by usually 20 weeks ultrasound we look for the cervical length, which are having the less than 2 centimeter. Those can be kept for close monitoring so that they don't go for preterm labor or PROM. In that way we can prevent sepsis, I feel like that. So
Also cervical amputation was told.
Urine routines and vaginal swabs should be taken once in 2 months.
Rest of the discussion during lunch. Okay. I think as a super moderator, the third umpire, I think all have played very well. Give them a big hand. And so many have contributed from the audience itself. The contribution was excellent. I just noted down some points. Teenage pregnancy, young primary, maternal infection, fever during delivery, no doubt PROM, prolonged and difficult labor, which are all prevalent in Indian scenario, contribute a lot to neonatal sepsis. Meconium stained lacquer and frequent PV examination. And of course, as our good friend Shivmurthy was telling, overuse, abuse, and unnecessary use of antibiotic has a lot to play a role in this situation. Thank you all. I think that should be the end of the pre-lunch session. Is it true? Oh, okay, fine. Thank you.
Now, sir, may I request Guru sir? Manoli sir. Manoli sir. Manoli sir. It is there, Manoli.
Yeah. Nice meeting you.
Very good. Manju, please.
Could we have loud round of applause for all the esteemed dignitaries that are getting felicitated right now for their contributions?
Sahana madam. Shashi. Madam is super. See that dress, super madam.
I would like to take this opportunity to thank all the doctors for their insights on sepsis, teamwork, and real world problem solving. Now, moving on to next on the agenda. The spotlight now revolves around a 27-year-old primary gravida, and this clinical scenario will be shed light upon by Dr. Subhashekar Reddy. Leading the session and the panelists are, on acute hypoxia, we have Dr. Hema, Professor and Head of Department at Siddhartha Medical College, Dr. Ramakrishnan, Consultant Neonatologist at SKS Hospitals. On subacute hypoxia, we have Dr. Rekha N, Professor and Head of Department of BGS Medical College, Dr. Bhaskar MV, Consultant Neonatologist at Kaveri Hospital.
Also joining us on evolving hypoxia, Dr. Savita, Professor and Head of Department, MIMS. Dr. Sridhar MS, Consultant Neonatologist, Rainbow Hospital, who is going to be joining us through Google Meet. On fetal anemia, Dr. Rekha, Professor and Head of Department, Sridevi Medical College, Tumkur. Dr. Nirmal, Assistant Professor and Consultant Neonatologist from our very own institute, Vaidehi.
Now, along with that, we do have joining us for monitoring and cardiotography insights. We have Dr. Pratyusha, Consultant Obstetrician at Sahasra Hospitals, and as super moderators, we have Dr. Shashikala, Professor and HOD at SJMC, and Dr. Guru Prasad, Principal and Senior Neonatologist at JJMMC. Can we have a loud round of applause? Please put your hands together for this experienced panel of delegates we have.
Good afternoon, everyone. Thank you, Dr. Dinakar, for inviting me to moderate this session. And as we all know that this NST or a CTG is very important when the patient is going in labor, and we should know each and everything from NST to CTG and hypoxia to that fetal anemia and also that HIE. So I welcome all the moderators for thank you.
Thank you, ma'am. Thank you for the nice introduction, ma'am. And see, this is out of the crispy time. Over 1 hour, we will be discussing about the core concepts of the acute hypoxia. Because this is where we won't waste even a single minute, and we will be entering into this thing, and we will be discussing by the end of this session what we are going to acquire is acute hypoxia, which baby is in acute hypoxia, what is the meaning of subacute hypoxia, what is an evolving hypoxia, and then there is a fetal anemia. We will be getting the clarity throughout this session. As an introduction, just for a few minutes, I will be explaining these things. See, this is just an explanation for the initial few 5 to 10 minutes. We will be taking care of these things. See, if suppose a person is getting hanged himself, a person who is intentionally want to get suicide and then he is suiciding. He is able to suicide, and then what is happening here, and this is simple slides that we are showing, means the acute hypoxia. What happens in the acute hypoxia? See, by 2 minutes, the tightening of nose is tightening, and then followed by that, there is a pain, breathing difficulty, and there is an oxygen shortage. Then he will start wiggling, and then followed by that, there is an attempt to remove the nose. Though he decided, but still there is an attempt to remove the nose, and followed by there is a lividity, you can see. And followed by that, there is a rapid heartbeat rise. There is an increase in the heartbeat. Followed by there is a hypertension. And then followed by that, defecation. See, remember, this is not that happened here. Initially, that didn't happen. There is something, nose is tightening, and almost there is hypoxemia leading to hypoxia. Followed by that, there is a difficulty and the lividity, and then followed by that, the person is passing the motion. And followed by that, urination, ejaculation, mucus plug, and there is a slow heart. Initially, there is a rise in the heart rate. Sympathetic activation has happened. Blood pressure, followed by that, there is a decrease in the heart rate, slowing of the heart rate, and by the 3.5 or 4 minutes, the baby respiratory failure is happening, then the muscle relaxation is happening. Why this is most important, we will discuss by end of this acute hypoxic episode. And then there comes an agony, followed by that the arrest, and then followed by that the brain death, and then declared death. So these are the events that is happening, and then we are discussing. We will be little fast, nothing. If there is anywhere you need to stop, you just explain me to stop it. See, here the common catch is handling, but the way they handle is different. If the person hands like this and they don't have. See, if it is someone catch leg, someone catch there. So there is a thing that what we need to see, what we need to catch in these things are important. These are the definitions for these things. What is hypoxemia? The first, initially the person had a hypoxemia, means there is a decrease in the blood oxygen. Hypoxia, specific parts of the heart, that's a hypoxic injury, hypoxic failure, hypoxic nephro. Next, anoxia, followed by that the extensive low levels of the oxygen in the body. And there comes an asphyxia, complete absence and accumulation of the carbon dioxide. Why we are saying these all things? When there is a Doppler changes, what is happening? When there is a Doppler reversal, when there is an absent Doppler, what is that? The baby is in phase. When there is a reverse Doppler, when there is an accumulation of the carbon dioxide happening, we label that as an asphyxia and not hypoxia. And this way, and where the meconium is being passed, where the motion has passed there, where the meconium is passed in the baby. So acute hypoxia, chronic hypoxia, and our panelists will explain to us where the acute, what are the different stages, but just I am giving an initial introduction for that. What is the cardiac output? What is a reserve of a person? The reserve of a person, every body, every organ will have some reserves. And what is the reserve? Suppose the heart is there. If you run, the heart rate will rise. That is a reserve that the baby has, our has. In most of the times when there is a distress, or when the respiratory rises. So the reserves are the most important for all the organs. The reserve of the heart is heart rate. The reserve of the respiration is respiratory. If you see a same type of X-ray film for the 6 months baby, 6 years baby and a 60 years person, a small amount of the changes in the X-ray, here there will be retractions completely. And here there will be tachypnea, and there will be nothing. So that depends upon the reserve. So where there is a lack of the reserve, there will be retractions are happening. So reserve, what is the reserve? Cardiac output is something like a stroke volume into heart rate. What is reserve here? What we are assessing through the CTG is something like a heart rate. Heart rate we are seeing. As we go on the stroke volume, these things as a preload and the afterload, this will be explained. See, most of the slides now we will be explaining through this mechanism. This is considered as a baseline. Below that is a deceleration, this is an acceleration. Accelerations, baseline and change. Because when we are discussing about the CTGs and the things, acute hypoxia, we will be discussing only about the baseline, variation, and acceleration and decelerations. These are things our panelists will explain. Then just I will just explain about the contraction phase, and then we can go ahead with the what all the things with the real panel. See, if you see, this is how it appears. This is the umbilical cord. When the contraction is happening, when the contraction starts, what I explained, the cardiac output is nothing but is equal to stroke volume into heart rate. When the contraction started, understand, try to understand, when the contraction started, first thing that is got compressed is the umbilical vein. What carries in the umbilical vein is the oxygenated blood. But still the oxygen is there in the body. The baby is neither in hypoxia nor hypoxia. So circulatory wise, the volume get decreased. So when the volume is getting decreased, automatically the cardiac output is stroke volume into heart rate. Stroke volume is decreasing, so heart rate will rise. During the initial phases of the contraction, you can notice that there is, when there is a contraction begin, there is a rise in the heart rate. Slowly, if you can see, when I am getting compressed, automatically arteries are compressed. What does arteries carry? Deoxygenated blood to the baby. Deoxygenated blood to the placenta. When the deoxygenated blood is getting stopped, so obviously the baby is in hypoxia. Hypoxic phase, automatically there will be a decrease in the heart rate. Followed by that, see, whenever this is got compressed this way, and the contraction is released, first release is this, parallelly this thing. So this is how it happens. First, volume decrease, open, grossly open. And then again, when the opening, this is happening. So the parallelism that happens here is when this got open, relaxation phase, the deoxygenated blood is coming to the placenta, and the placenta is ready. From the uterus, you have received a fresh blood, and the blood will flow through the umbilicus. So again, the oxygenation is increasing, so that there is a rise in the heart rate. So now you understood There is a contraction phase, initial phase, when this got contracted, heart rate has increased, completely decreased. When it is releasing, it is increasing. Okay. To happen this, the uterus during the relaxation phase should receive the placenta should receive the fresh blood. Suppose the arteries are relaxed. During the relaxation phase, this has opened now. This opened. But the uterus didn't supply the fresh blood to the placenta. So what is happening? Though this has opened, the baby still is in hypoxia. Utero-placental insufficiency. From the uterus, the placenta is not sufficiently perfused. So when there is an utero-placental insufficiency, the baseline, again the normal heart rate we are not receiving, it is becoming late. Lately that is happening. This is a late deceleration. This late deceleration is a sign of the utero-placental insufficiency. And then we'll be discussing further what happens, why happens, and then complete discussion will be on these things only. So we will be discussing now about acute hypoxia, subacute hypoxia, evolving hypoxia, and sudden fetal anemia. So once you get clear picture about the contraction phases, relaxation phases, late deceleration, early acceleration, then we'll start these things. So acute hypoxia. Without wasting our time, we'll go ahead directly into the acute hypoxia. Dr. Hema, ma'am.
Hello, I would thank Dinakar sir to give me this opportunity to be one of the panelists. I am the alumni of Vaidehi Medical College. I've done my post-graduation here and going to whatever the case scenario is there. That case of...
This case scenario I haven't explained to you. The case scenario is this thing. Sorry ma'am, sorry to interrupt ma'am. The case scenario is this, that a 39 plus 4 week medical history, unremarkable pregnancy, spontaneous conception, admitted for the labor induction and the labor has started, and the Bishop score was 6. Intravenous oxytocin started and titrated every 30 minutes. Then they observed the tachysystole. More than 5 contractions in 10 minutes developed. Fetal heart rate tracing showed initially normal baseline, gradually loss of the variability, repetitive late decelerations after contractions, eventually bradycardia. Oxytocin was stopped, mother was repositioned and provided oxygen and supportive measures. Emergency LSAS performed and arterial pH of the baby got 7.0 and base deficit -14, lactate elevated, and postnasal course baby admitted in the NICU. And now we are going to discuss this baby. Till that point of the time this pregnancy was going very smoothly. Suddenly this baby landed in NICU. 2/3 of the babies are coming in that way. So why? This baby was completely at that point of the time till the pregnancy was carrying, and now this baby is in NICU. What could be the measures that we can do? What is the thing? What we are understanding this acute, subacute and evolving hypoxia. Madam, you can go ahead.
In this case, the patient had Bishop score of 6 and she was induced by oxytocin. And in the active phase of labor, the oxytocin was titrated and she went into labor. And there was tachysystole, which was ended in hyperstimulation. And finally, we had that is hypoxia. The causes of hypoxia being, that is the acute causes of hypoxia being card prolapse, card compression, abruption or hyperstimulation. Here the case was hyperstimulation. What happens as a compensatory mechanism during acute hypoxia is the blood, as the fetal blood pressure increases, there will be slowing of the heart rate as it is mediated by parasympathetic vagal nerve on the SA and AV node, and further decrease in the oxygen will further lower the heart rate, and this will continue till, if this continues when the oxygen is low, then the fetal arrest can occur. But this it is very different in chronic hypoxia, where first initial stages of chronic hypoxia, the fetal baseline will be high, and further chronic hypoxia means goes on, there will be loss of beat to beat variability.
Next case will discuss completely on chronic hypoxia, madam. And
so when there is in acute hypoxia, the causes may be, what are the sudden causes like card prolapse, card dehiscence, major placental abruption and uterine hyperstimulation, wherever we had this case. And in places where we have
uterine hypostimulation by oxytocin induction and hypotension due to maternal hypotension was there. If these scenarios are not there, if the scenarios are not there, 90% of the CTG, means 90% of prolonged bradycardia will improve after 6 minutes. If there is no card prolapse or no abruption or no scar dehiscence, it is expected to become normal. But we have to act within 3 to 6 minutes if there is prolonged bradycardia or decelerations. Next slide. So the same thing is explained here, but if the baseline is less than 80 beats per minute lasting for 3 minutes, then the fetal pH will drop by 0.01 per minute. So that is to be taken care. So whenever oxytocin is given to the mother, it is expected to sail through the intrapartum period. But what happens is during hyperstimulation, there is this and placental insufficiency, which is acute event which has happened in such scenarios, then there will be hypoxia.
Yeah, this is the expectation that we may be expecting, but something other than that is pushing inside.
So
now,
so
we entered in the NICU.
So there are studies telling that when a patient is induced with oxytocin, when they enter the active phase of labor, then oxytocin required should be tapered and stopped. If there is hyperstimulation, obviously stop. But in active phase of labor, oxytocin should be discontinued when there is hyperstimulation and hypoxia. So uterine hyperstimulation, by causing uterine hyperstimulation, oxytocin may lead to aggravate in the abnormal fetal heart rate, and which will contribute to neonatal acidosis and hypoxic ischemic
This
encephalopathy.
completely from the oxytocin induced hypoxia, there is again completely brief description will be there, but this is superficially. I will take this one slide. In acute hypoxia, if you could notice, okay, why we call it as an acute? What is an acute, what is an subacute? And why we are calling this an acute is, like this is like a Rajdhani Express. If you see, Rajdhani is a super express, normal one is a passenger. We are considering acute hypoxic evolution is like a Rajdhani Express, and then subacute hypoxia as a normal passenger. So this is why here in acute hypoxia, what is that is going to be fastly established is the acidosis. How this getting acidosis is 0.01 per minute. Per minute, 0.01. See the baby who is up to 7.35, which was baby completely fine pregnancy, and then we thought that the baby will come out safely. This baby after the starting, this baby within 1.5 hour, 0.1 lost, means 7.35 to 7.25. And within another 4.5 hours, 0.3 lost, 7.35 to 7.15. And then within 6 hours, 0.4 lost, means 6.9. Means the baby who is somewhere here itself is in NICU, will be coming into NICU. And here obviously the baby may be in a severe asphyxia state. So this is what that we are thinking, and this acute hypoxia is a very rapidly progressing, where there is a 0.01 per minute, very fastly establishing hypoxia, and this baby's pH is rapidly dropping, and this there is high chances this baby will land in NICU, or certainly the baby will have a hypoxic injury.
So according to the guidelines, whenever we come across such a scenario where there is hyperstimulation or continuous prolonged decelerations with absent baseline variability, what we have to do, we have to act very quickly. That is that is guidelines for 3, 6, 9, 12 and 15 minutes. First, initially, all we tend to do is stop the oxytocin, give that is tocolytics, positioning, left lateral position, hydration, and if this continues even after the resuscitation, then even after 6 minutes, to rush to the operation theatre, deliver the baby within 15 minutes of the acute incident.
Thank you, ma'am. Regarding this oxytocin-induced acute hypoxia, again one more panelist is there, completely on that oxytocin acute hypoxia only. So,
I would like to tell one of the conditions like card prolapse or occult cord prolapse or cord presentation. This may be one of the reasons, but it's very difficult to diagnose occult cord prolapse. We have a continuous persistent variable decelerations in the electronic CTG. Otherwise, we really don't know how to diagnose it. And next slide, sir. And cord prolapse, as you all know, that is intact membranes are there where the card is presenting with a presenting part. And in the cord prolapse, we have the membranes which are ruptured, and the management depends on whether the baby is alive or dead, maturity of the baby, and the degree of cervical dilatation. So the same thing with intact, and the cord prolapse is lying inside the vagina with the next slide. So the aim of management is you have to deliver as quickly as possible, never to meddle with the card more, and just to give the exaggerate Sims position or fill the bladder so that there's no compression on the card, and immediate vaginal delivery is possible. Then if it's 8 to 9 centimeters, apply forceps and deliver, or we can push the patient to emergency cesarean section. Next slide, sir. Okay, this is the thing while we are trying to take the patient to the OT, and this is one of the scenarios where cord prolapse or occult cord presentations are there. How to act on that, and where the acute hypoxia can be reduced. And some slides on deceleration is there, maybe.
Yeah, that will explain in that, Karan. Early and late, these things will be explaining in the further sessions, and late decelerations will be explained. Sir, regarding the Dr. Ramakrishnan, sir. See, there is acute hypoxia happening, sir. And then kindly explain that acute hypoxia, what is that happening in the brain? Now the baby is there. Madam has explained about the acute hypoxia happening in the baby. And kindly explain us what is that scenario that's happening in the brain.
Yeah, so we all know that acute hypoxia will lead to hypoxic ischemic injury in the baby. So it will lead to grey matter injuries. Similarly, in the white matter injury, it will lead to watershed, especially in the watershed areas. It will be causing if it is a preterm baby, periventricular leukomalacia are very common, and infarcts are very common. So we have to screen all such babies, especially born with severe HIEs, and going into encephalopathy with all this. So once we have that stage where the baby is already into encephalopathy and not coming out of, despite the therapeutic hypothermia, or it is into a state where no more interventions are required, or we are suspecting of any bad prognosis. So definitely to go with the MRI, and MRI we can definitely see, and other than MRI, to see early even the ultrasound or point of care ultrasound, which we will be going to teach all our students tomorrow in the workshop. That is also a very good way to know about the prognosis very early, because it is a logistic, very difficult task to shift all the babies in the MRI, especially when you have severe HI cases.
Yeah, this is what sir is trying to explain in detail about what are the MRI changes that is being identified. Now the baby is in acute hypoxia. The baby came out somewhere around 7.2, 7.3 or somewhere acidosis. And what are all the changes that can be observed at that point of the time in that baby, sir is trying to explain. And here these are the watershed zones. Means one artery and other artery are perfused in that here. And here these watershed zones are being affected. And the circulation of the preterm baby to term baby is a different. So there will be different changes that will be cortex to neocortex. A brain injury of the preterm infant. Term and preterm infants respond to asphyxia in a different way. Slower depletion of the high energy compounds during hypoxia in preterm fetus. Ability to use alternate energy like lactate and ketone will be very better in the preterm babies. Basal ganglia lesions are still the most common in the preterm babies in HI, but they are associated with widespread even white matter lesions. The preterm infant is more susceptible for the white matter because there is a difference between the term baby and preterm baby in the watershed zones. Madam, Dr. Rekha ma'am.
Yes.
Hi ma'am. Welcome ma'am. Here is a discussion. Now the madam has explained us about the acute hypoxia, how fast that is being established, and now we want to know what is subacute. Why they labeled as an acute? Now they come subacute.
So good afternoon to everyone. I am highly privileged to speak about a topic. Sir? You are sir? Okay, sir. So about a topic called as subacute hypoxia. We still have some space before slipping into evolving hypoxia. So it is a compensatory phase present, and we still can take some measures over here. This is the most important thing about this phase of hypoxia. Second important thing is connecting to this case scenario when oxytocin is causing or is the agent for the hyperstimulation. We have got too many things to reverse back. It is a beautiful drug which is directly under your control, which is not misoprostol or any other rapid and a strong inducing or an accelerating agent. So regarding subacute hypoxia, in this situation the most important physiology is it is spending more time with deceleration, that is to decrease the myocardial load on the fetus, and the thing it is spending in the baseline is less. So this tells us indirectly that it is still having some time to wash off the carbon dioxide that is getting accumulated, or which might help it to slip into evolving hypoxia or asphyxia.
Yes ma'am. That was madam is trying to explain in this scenario. If you start from baseline, if you try from approximately a baseline, 1/3 time of that the baby will be in the acceleration and 2/3 times the baby will in the deceleration. So when you rough a baseline, will show it as that the baby is predominant 1/3 the baby is oxygenating and 2/3 time the baby is accumulating the carbon dioxide. So here not like an acute hypoxia, in subacute hypoxia the baby is accumulating, but the pH is dropping not in the range of the acute hypoxia. At certain most of times this is the scenario where most of times we are come across.
So as the slide tells, it is 30:90 seconds. So it is 1:3 ratio it is spending. But subacute hypoxia as per the definition goes as more than 60 beats per minute of decelerations and lasting for more than 1 minute is indicative of subacute hypoxia. In these circumstances, the pH can drop by 0.01 per 3 minutes. Here one thing to be emphasized, sir has told that the first is decelerations. So we have got three things in a baby, in a fetus, what is happening when the blood is getting obstructed or there is a transient obstruction. So first stage will be to decrease the myocardial load of the fetus. That is reacted by the decelerations. The second is the fetus itself reduces the movements. That is caused by loss of accelerations. And the third important thing is that is decompensatory phases, loss of variability and your bradycardia.
Yeah, that's what madam is saying about the variability. And this is one single factor, the variability. And what we generally explain to the most of our people is, suppose if the baby is able to play it very nicely, this is how the baby can play as a volleyball. The effectiveness of the baby playing with the volleyball, vigorously I can play it up, the baby is good. When the baby is able to play very slowly only, that is a decreasing in the variability. When there is a good variability, the baby is fine. When there is a low variability, the baby is not having supporting document. This is how we generally explain. When the baby has a vigorosity, the baby can do variability very well. When the variability is decreasing, itself is a sign. So that's what Madam is trying to explain as the subacute hypoxia is establishing what are the changes that we are going to observe. And this is where these 30 seconds the baby is spending in the acceleration, 90 seconds the baby is spending in the deceleration. So there is an accumulation of acids. So the baby is in this phase, taking in the swimming like swimming, the baby is very short here and very long time in here. So this is where it is rapidly dropping per 1 minute is the 0.1, whereas there it's 0.0. Thank you, ma'am. Thank you for the wonderful explanation. And sir, Dr. Bhaskar sir, see here there is something happening with the cardiac status of this baby. The baby is evolving hypoxia, and the baby has certain difficulty in pumping the pump. So when this evolving hypoxia is establishing, what could be the cardiovascular changes that happens in this baby?
Hi everyone. So if you go the development of the heart develops in an hypoxic state. So that's a normal hypoxic state, the heart develops. And when we have an hypoxia, abnormal hypoxia, then they have an effect on structure and functional, even the gene expression of the fetal heart. We know about the Barker hypothesis, the fetal onset of adult disease. When a child is an IUGR, they are more prone for stroke, hypertension, and MI in an adulthood. So in that, in a child, when you have chronic hypoxia, placental uterine insufficiency, then there will be IUGR. Then you can say, okay, we can predict. Sometimes the hypoxia may not be so much, so the child may have a normal birth weight. Even then they can have an adult onset of disease. Certainly, when there is a remodeling happens in the conduction pathway of the heart development, then you have sudden infant death syndrome. SIDS can happen at one of time. So what happened in the prenatal period? What happened in the prenatal period? So initially when there is an hypoxia, carotid bodies get stimulated. There is an chemoreflex. There is afferent pathway going to the brainstem. From brainstem, it comes to the cholinergic vagal stimulation to the heart and decreases the heart rate. At the same time, there is an alpha adrenergic stimulation of the peripheral circulation, causes a peripheral vascular constriction. Why decreasing heart rate? Lesser the load, lesser the energy consumption. And why peripheral vascular constriction? We need to have more right to left shunt, so the aorta gets more blood, so the coronary and cerebral circulation are maintained. So initially, as we know, during the transition state, okay, there will be pulmonary vascular resistance will be more, followed by right ventricular pressures are more. During the transition, the pulmonary vascular resistance will go down, the left ventricle will take pressures will go above the right ventricular pressures. But when you have a hypoxia, the pulmonary vascular resistance will be still remain high. Okay, so that in turn causes poor oxygenation, which can lead to acidosis. Acidosis itself can again cause pulmonary vascular resistance, which lead to RV diastolic dysfunctions, followed by even increasing the pulmonary pulmonary vascular pressures. Okay, this is what happening. That is what Madam was telling. In the fetal period, they have bradycardia, decreased movement are seen. When they born, you may have cyanosis, shock, and respiratory distress may be seen. Now apnea is also mediated by adenosine. So there are many factors like hypoxic ischemic factor alpha and beta. There are adenosine, nitric oxide, angiotensin 2. There are some protective mechanism when you go into molecular type. So coming to the pressors we use, we have usually dopamine is the most common one, but here you need to be very cautious. Dopamine acts on both, mainly on beta 1 is a chronotropic action and inotropic action, and also on alpha 1, which causes vascular constriction. Okay, peripheral vascular constriction. Dobutamine is the one of the wonderful drug here, especially when you come to in an asphyxiated child, where only cardiac motility, want a cardiac contractility want to be improved. So use dobutamine, which has beta 1 and beta 2. Beta 1 acts on increasing inotrope on chronotropic action, and beta 2 on the peripheral vascular dilatation it happens. It can't be used in when you have hypotension scenario. Epinephrine. Epinephrine, the adrenaline, so it acts mainly on beta 1, beta 2 and also alpha 1. In a lower dose, 0.02 to 0.1 microgram per kg per minute, it mainly acts on beta 1 and also beta 2. If more than 0.1 microgram per kg per minute, it may have alpha 1 action which causes peripheral vasoconstriction. So beta 2 also causes pulmonary venous vascular resistance, decreases the pulmonary vascular resistance. That's the good part. When we have an asphyxia child, actually, when I was working with Dr. Dinakar sir, we used to have any child with little asphyxia, we used to start on dobutamine in minor dose. And if at all, if child has hypotension, we had adrenaline into it, so that we have both component are active. Vasopressin acts to vasopressin receptors, but it's a very peripheral, it's a very potent peripheral vasoconstricting agent, but little effect on cardiac. Milronin is a wonderful drug, which causes cardiac lucitrophic action. Okay, it lacks a cardiac relaxation, which will be used in PPHN-like conditions. If those things are not working, if catecholamines are not working, you need to go for steroid. If steroid is also not working, next step, theoretically ECMO, practically pray to God. Okay.
Excellent, sir. What sir trying is explaining is this thing, like initially our doctor explained about what is the neurological status, what is happening due to the hypoxia. When the hypoxia is being established, there is a drop in the pH. pH is dropping, automatically acidosis is building. Once the acidosis is building, the heart will be getting weakened. At what point of the time the heart is getting weakened and cardiac going to cardiac arrest, we will be completely discussing in the chronic hypoxia. It's completely in the chronic hypoxia, will be complete session is on that. But as the time goes on, when the acidosis is building, in the acute hypoxia, the cardiac compromise is very fast. And in subacute hypoxia, the cardiac status is slowly decreasing. The cardiac status, when the acidosis is building, the cardiac status of this is decreasing. That's why when the cardiac status is decreasing, there is both decreasing the preload and afterload. SAR is trying to increase that. Increasing by keeping the IV fluids boluses and then by giving the dobutamine. Dobutamine increase the contractility, maintaining the noradrenaline by the pressure. So at the end, what SAR is trying to support the heart and maintain the BP. What to maintain the BP? The mean arterial blood pressure should be maintained. To end organ perfusion to be properly, the mean arterial blood pressure should be maintained. That's why SAR is trying to increase the systolic also and tries to increase the diastolic blood pressure. See, noradrenaline will increase the diastolic blood pressure, and then the systolic blood pressure, if you want, the contractility is been increasing. So at the time of the acute or subacute hypoxia, where there is a compromised heart status, SAR is trying to give the fluids and this are increasing the afterload and increase the preload, and then by maintaining the mean arterial at the end. What all that is being maintained in the NICU is to maintain the mean arterial blood pressure, so that the end organs will be perfused. So, followed by that, we discussed about the acute hypoxia, subacute hypoxia, changes in the CNS, changes in the heart, and now we will be discussing about the evolving hypoxia. One of the beautiful things that we will discuss. Evolving hypoxia. Dr. Savita. Anyone? Who is? Okay. Then I will take over these things like evolving hypoxia. See, we have discussed about the chronic acute hypoxia, subacute hypoxia. There is a condition called as an evolving hypoxia, because if we can identify this evolving hypoxia, this is the beauty of these things, mean that why this is most important thing in the evolving hypoxia to identify is, if we can identify the evolving hypoxia once in a time, automatically we prevent the Meconium aspiration. This is how we are trying to prevent the baby to come into the NICU. What are the clues that's been evolved? Which is, we have observed nearly 14 cases, and then we have murdered to the literature, and then we are coming out with this. See, obviously, what we'll be saying is the stress, distress, death. What is we call is fetal distress, not stress. Why? The extended form of the stress is the distress. The baby is in fetal distress. Gradually evolving hypoxia means either there could be repeated episodes of the occlusion, or inadequate intervillous pool of the blood reserve, or inadequate placental function. and there is an evolving hypoxia. There is nothing evolved, that is the established acute or subacute is not there, that there is evolving hypoxia. What is the sensitivity and specificity has been explained in the form of abnormal decelerations has 95% sensitivity, and variability, if you see variability, 99 to 100%. This is the most important that we need to observe. That's why I said when the baby is able to play very properly, the baby has good strength. When the baby is unable to play weakly, that is already the baby is established. So there is 99 to 100% specificity. And abnormal baseline, see abnormal baseline. Now we are going to discuss about this abnormal baseline. How this abnormal baseline is giving us a clue, we'll be discussing. When there is a changes, slowly, what we will do in the NICU, somewhere in the NICU or Embryo, if there is a decreasing in the heartbeat, when we say the monitor is showing as a less than 90 or anything, what will we start? Obviously, we start some adrenal, something supporter will be starting. So obviously, when we start, we will try to increase the heartbeat. So in utero, baby has some adrenal reserves. See, you have the crash cart, adrenal is there. Baby in utero has an adrenal gland, adrenal is there. So when the baby is in the NICU, when the heart rate is decreasing, we are supporting with the adrenal thing to increase the heart rate. That means we are getting a clue there. And obviously in utero, when the baby is in evolving hypoxic state, this baby starts adrenal from the adrenals. So how we will be knowing? Obviously adrenal from the baby is extracting the adrenal from the adrenals, the baby heart rate will change. So what is that is increasing is the baseline. The baseline, if you notice, initially when there is a 130, 140 heartbeat is there, and then suddenly we are noticing 160, 180, baseline has been changed with one dip. This is what we are showing it as a push-push shouldering effect. See, there is a baseline, automatically some dip has happened, and again they rise the baseline. The ability to rise the baseline is an important thing. If you have the reserve only, because the baby has a reserve in the adrenal glands, able to rise. And the baby's heart is able to contract in a better way with that adrenal, the baby is able to rise. Why I am saying is, the ability to rise the baseline is very important. Inability to rise the baseline is a stress factor. Suppose an IUGR, severe IUGR baby has no cardiac contraction stresses and the baby is in decreased adrenal secretions, obviously the baby is in hypoxia, the baby is in compromise but unable to rise the baseline. That's why those babies will be passing the Meconium easily. They won't give a clue for us. The baby pass. Here this baby is giving a clue. See, I am suffering. And this baby, this is exactly the cry of a baby. This baby's heart rate, which was 130, 140, had suddenly raised. Exactly what we labeled this as a push-push shoulder effect. So the baby, when it is rising the baseline, defines that the baby is extracting the adrenal from the adrenal glands. Means the baby is taking the reserves. The reserves could be for what time and no one knows. So here we need to interact. We observed when there is a twice change in the baseline. Twice change in the baseline means the baby got a dip, raised it baseline. 130, 140 baseline heart rate, suddenly shifted to 160, 170, and there is a dip again, the baby rise to 180, 190. Twice baseline, this gives a clue that this baby is about to pass a Meconium. Remember, when the baby is able to pass Meconium, we can easily identify. This we have proved intentionally. Nearly 23 cases we have proved it up directly. ARM we did a prevalent post-op, we noticed those things. This is why we label the baby is in somewhere hypoxemia, you identify. Because when the distress is happening, hypoxia. When the fetal distress is happening, the baby is somewhere hypoxia and axia. When there is arrest is happening, the baby is in asphyxia. See, you can see most of the times, baseline change is there. So whenever there is a change in the baseline, remember this baby is under the stress. Baby is going to distress. Baby is utilizing the adrenal reserves. Because even this CTG will give a clue for the neonatologist. Once they see these things, the baby already utilizing these things. If you give this clue, they will start some other, either whatever the support that is required, they will be adding it up. See, already the baby is utilizing the adrenaline. They need to give some support. That is the reason, initially when you give the bolus, the baby may not be responding, the baby will have the blue periphery still. If you give this CTG report for them, they will be alert. See, almost all these things. The baseline is there, increasing, followed by that there will be decreasing in the variability. Once the baby changes its baseline, followed by slowly the baby starts losing the variability. See, this is how the baby is delivered. We try to prevent the meconiums. Almost nearly 23 cases we have identified. If not passed, sir, if not addressed at that point of the time, the baby may pass meconium and the baby will have the meconium aspiration syndromes. These are things that happens. That is a pneumothorax, chest tube, ventilation care, PPHN, everything follows. So when the baby is crying for the help, alert, get alert. See, there is a change in the baseline. I am reducing maternal, support me. If you continuously monitor, obviously the baby will be knowing a clue. Baby obviously saying that thing under distress. See, preventing the meconium itself, you can prevent all these things. Unnecessary. This baby was happily, the baby was growing and should come out. See, again, I am stressing these things. In the resuscitation, why we are saying heart rate, cry, tone. Why is because when the tone is lost, this baby is in asphyxia state. Hypoxia, hypoxemia, anoxia and asphyxia. This baby lost the tone. Tone loss is something like this person passed defecation, everything, and then they lost the tone. So losing the why in the NRP that there is a tone they are mentioning is this is the reason. When the baby has completely lost the tone, lost the reserves, and the baby has landed in asphyxia. See, when hypoxia develops, absence of axle, because when you have a new bike is there, when you are going in the bike at one speed, what is the first thing that when it comes to reserve, what is the first thing that we notice? Unable to accelerate. The unable to accelerate the bike is the first clue that the vehicle is going into the reserves. Followed by obviously there is a continuous rise in the baseline and there is a reduction in the baseline variability and the baby will be following the asphyxia state. Sir, Dr. Nirmal sir.
Yes. I think Dr. Sridhar sir is taking the Meconium part, sir. He is online. He will come in the Zoom, Google Meet.
Where is that Google Meet, sir?
Okay. Once.
See, once we are unable to identify this change in the baseline, perhaps because of the unable to continuously monitor the patient, this baby passed meconium. And what is the consequences of the meconium will be explained by the other.
Hello, can you hear me?
Yeah, you are audible, sir.
Thank you. Grateful for the opportunity and my apologies for not being there physically. So, briefly discussing about how meconium affects the fetus and the
Yeah, go ahead, sir.
aspiration and clinical implications because of that. So it is the gasping movements that lead to the passage of the aspiration of meconium into the lung. Now, what is the timing of this aspiration? It is peripartum. It happens before delivery, during delivery, and also after delivery. However, most of the meconium that is aspirated, it happens so inside the uterus or slightly, or just when the baby is getting delivered. So postpartum aspiration is relatively less. That is why our attempts to limit aspiration by intubating all these babies and suctioning has after they are delivered is not successful, and it is no longer recommended. Now, once the meconium is aspirated into the lungs, how does it affect? One important thing is the mechanical effect. So this meconium, which is a thick sludgy structure, it goes and blocks the airways. If a small airway is completely blocked, the alveoli distal to that completely get collapsed. But sometimes the blockage can be partial and it can cause the ball valve effect, wherein during inspiration there is opening and the alveoli receive air. During expiration there is closure of the airway. So these alveoli keep getting air during inspiration but they never deflate. So this causes hyperinflation and it also predisposes for air leak syndromes. This is the reason why meconium aspirated lungs are non-homogeneous, means we typically see some areas of collapse and some areas of hyperinflation. Another most important probably consequence of meconium that is aspirated into the lungs is the inflammation that it triggers. So this is from an animal study that I have taken. The pathogenesis is that meconium directly destroys the endothelial cells and the alveolar epithelial cells. This results in influx of inflammatory cells, including the neutrophils and macrophages, which start producing the inflammatory mediators, most predominantly the TNF alpha and also several of the interleukins. So what this inflammation does is it causes further cell damage, the alveolar epithelial cells, the bronchial lining cells, and also the endothelial cells of the pulmonary vasculature by necrosis and apoptosis. So this leads to exudation, this leads to poor compliance, this leads to impaired gas exchange, and also causes pulmonary vasospasm. So this process of inflammation continues, and the experimental studies show that the inflammatory levels, the markers of the inflammatory markers, they peak during day 3 or day 4 after the onset of illness. This also correlates clinically because most of these babies are relatively okay at birth, but they continue to deteriorate over the next 2 to 3 days. Another important thing that contributes to meconium aspiration syndrome is the inactivation of surfactant. Most of these babies are term babies wherein surfactant is already produced. However, they do behave like RDS lungs which are stiff and poorly compliant. This is because the surfactant is inactivated. See, what is the function of meconium? Meconium contains bile, right? So bile micelles primarily function in digestion of the lipids. And the most important component of surfactant is phospholipid. So this meconium directly goes and damages the phospholipid bilayer, thereby completely disrupts the process of surfactant metabolism and the way it decreases the and that's how it decreases the compliance. Also, the inflammatory response also leads to further surfactant damage. So that is why poorly compliant lungs are seen in meconium aspiration syndrome. So probably the most important clinical thing that we have to tackle in a baby with meconium aspiration syndrome is pulmonary hypertension. All the things that I have explained previously contribute to pulmonary hypertension, including airway obstruction, surfactant dysfunction, and most importantly, pulmonary inflammation. The PPHN in meconium aspiration syndrome is particularly severe, and also it does not respond so well to inhaled pulmonary vasodilators because the parenchyma is also abnormal. This is in contrast to the black PPHN where the parenchyma is normal and there is only functional vasoconstriction where vasodilators are very effective. But we often see that many of these babies with MAS who are ventilated, who are given INO, they don't respond dramatically to inhaled nitric oxide. So this is a disease that starts just before delivery and it progresses over the initial 3 to 5 days. You don't expect these babies to improve immediately because see, natural synthesis surfactant takes about 3 to 4 days. That is when surfactant replenishment happens. And as I said, inflammation that gets triggered at birth goes on worsening for the first 3 to 5 days. And PPHN is not that well responsive. And many of these babies have infection also. And these asphyxiated babies also have other organ dysfunction, for example, cardiac dysfunction. And this leads to pulmonary edema. Many of them have acute kidney injury with volume overload, which again causes pulmonary edema. Poor neurological status with poor respiratory efforts also complicate the process of ventilation. So all these things probably get reflected in the way we clinically manage these babies. For example, there is no routine tracheal suctioning needed. If the baby is vigorous, this is not necessary because as I said, most of the meconium is aspirated before the birth or just at the time of birth. Resuscitation, we follow the standard protocols. Respiratory support still should be non-invasive as much as possible. Only in the severest of cases, there is a need for intubation and invasive ventilation. Non-homogeneous lungs can be very difficult to manage, especially when the baby needs ventilation. High frequency ventilation is preferred if the required pressures are less to prevent air leaks. And air leaks, as it has already been stressed, is a very notorious complication can lead to deterioration, death, neurological morbidity, and we should always be preferred. Surfactant, yes or no, there is no strong evidence to say that surfactant replacement therapy helps. However, this has to be individualized, looking at the compliance, looking at the X-ray picture and all the other things. Standard management of PPHN, but as I said, these babies may not respond so vigorously to, I know at least a subclass of these babies don't respond. Another important thing we see is that many of these babies need prolonged respiratory support for several days, sometimes several weeks. And this is because of the ongoing inflammation, which not only causes parenchymal damage, but also persistent pulmonary vasoconstriction. Thank you.
Thank you, sir. Thank you very much. This is what that happened, all the consequences that he is explaining to us. When the baby, we are unable to identify what is the baseline heart rate changes or anything. If the baby accidentally passes even the meconium has gone inside because the hypoxia led to meconium passage, few episodes, not every time. The meconium passage again begetting the hypoxia because that has gone and obstructing the alveoli, and then ball mechanism is happening. Again, there is a hypoxia leading to the pneumothorax and then followed by PPHN and the cardiac compromise. See, this is all the vicious cycle that is happening. But if you are vigilant sometimes, we can prevent this. So we will be going ahead now with Dr. Pratyush. How this oxytocin is leading to acute hypoxia, and then what can we do on this? What this oxytocin-induced tachyphystolia, and how can I address it? In 5 minutes.
I extend my sincere gratitude to Dr. Dinakar sir for giving me this wonderful opportunity. Myself, Dr. Pratyusha, Managing Director and Consultant OBG, Sahasra Hospital, Vattur. So I'll be explaining about the oxytocin-induced tachysystole, how we can diagnose. So before we go to hyperstimulation, just a brief introduction about oxytocin. So 3 varieties of oxytocins which we can use in obstetrics or oxytocin, ergot derivatives and prostaglandins. So these all have the power to excite uterine muscle contraction. Therein the labor will progress. So now majorly I'm talking about oxytocin. Oxytocin is a non-peptide. It is released from the paraventricular nucleus and also supraoptic nucleus from the hypothalamus, and it will be transported to the posterior pituitary gland, wherein this oxytocin is actually helpful to excite the contractions of the uterine muscles. So next slide please. The T-half of this oxytocin is 3 to 4 minutes, and the duration of action will be 20 minutes. It is actually metabolized by oxytocinase enzyme. Mode of action is it will be causing mobilization of intracellular bound calcium from the sarcoplasmic reticulum to activate the contractile protein. So what are the preparations of oxytocin available in market? Synthetic oxytocin, very widely used preparation. So usually available as 5 international unit per ml ampules. It has only oxytocin effect, but there is no vasocompressor action. Then comes intometrin, combination of oxytocin 5 unit with ergometrin 0.5 mg. Then desamino oxytocin available in nasal preparation, 50 international units, and it is not deactivated by oxytocinase enzyme. Oxytocin nasal solution 40 units per ml. How effective oxytocin is if we see according to trimesters. Usually in first trimester uterus is refractory, so no much use of oxytocin since there are no receptors. In second trimester, yeah, it acts as a supplement to other abortifacients. And in third trimester, even though we are using small doses, it is very sensitive. And always we have to preserve it between 2 to 8 degrees Celsius, then only the power of oxytocin will be good. So what are the indications? If we divide it into therapeutic and diagnostic, contraction stress test and oxytocin sensitivity test comes under diagnostic indication. Whereas therapeutic indication, again, we can take into early pregnancy, late pregnancy, labor and puerperium. So what are the contraindications? In pregnancy, yes, in grand multipara, where there is a cephalopelvic disproportion or contracted pelvis, or if there is a previous cesarean section or hysterectomy or in malpresentations. In labor, what all pregnancy contraindications are there, we should not use it. And in obstructed labor, also when there is incoordinated uterine contraction and fetal distress. Anytime when there is a hypovolemic state or when there is a cardiac disease, oxytocin should be avoided. So what are the dangers? The most important thing which we all are discussing today is a uterine hyperstimulation. Yes, here oxytocin can cause hyperstimulation, wherein it can lead to rupture, water intoxication, hypotension, and also antidiuresis in doses above 40 to 50 milli international units per minute. Whereas in fetus, it can cause distress, hypoxia, placental insufficiency. How we can administer this? In controlled IV infusion, 1 to 2 milli units per minute for induction of labor or augmentation of labor, also in intramuscular route. So we have a oxytocin titration technique. So can you go back to the slide? Yeah, oxytocin titration technique, wherein we always start low dose of oxytocin and then we will escalate it in 20 to 30 minutes until we get the optimal response, that is at least 3 contractions in 10 minutes, each lasting for 45 seconds minimum. When we can stop infusion? When there is hyperstimulation, polysystole or tachysystole, or when there is uterine hypertonus, or if there is any evidence of fetal distress or other unexpected maternal symptoms. So the definition for oxytocin uterine tachysystole is more than 5 contractions occurring in 10 minutes, which is usually identified in continuous CTG tracing. This happens during labor augmentation with oxytocin. Each contraction, if it is lasting for more than 90 seconds with a relaxation of less than 30 seconds, the 1:3 ratio, with more frequent contractions happening with more than every 2 minutes and the peak pressure of more than 80 mmHg. So what we can look for in a CTG? First, we have to check how frequent is the contraction. Definitely more than 5 is a tachysystole. And how is the uterine activity? We have to check for the frequency, duration, intensity of the uterine contractions. Apart from that, fetal heart rate monitoring is also important. How is it going to cause an impact on fetal oxygenation? By reducing the placental blood flow, and also it reduces the fetal oxygenation, thereby fetal distress sets in. Why it is very important to diagnose this? Because it causes many fetal complications like hypoxia or oxygen deprivation is causing reduced blood supply to the brain, therein cerebral palsy or hypoxic ischemic encephalopathy can set in. So this can result in brain damage, seizures, cognitive delays, wherein baby can be left with the seizures or respiratory problems, deafness, irritability, and organ failure in the end. What are the maternal complications we can expect? Yes, it can cause uterine rupture. Can you go back to previous slide, sir? Uterine rupture, increased cesarean rate because of fetal intolerance, also sometimes cervical laceration, postpartum hemorrhage, and infections. So timely intervention is very much required, wherein we have to reduce or stop the oxytocin infusion. Thereby we have to improve the mother and baby safety. Next slide, sir. How this uterine tachysystole is operating? Yes, the placenta is called fetal lung in utero. This uteroplacental circulation usually allows the exchange of oxygen with carbon dioxide and waste products from the fetus. Initially, at rest phase, there will be increased spiral artery pressure compared to intramyometrial pressure. Thereby, there will be good flow into the intervillous space. So, there will be exit of waste products into the maternal circulation. Whereas, during a contraction, the myometrial pressure is exceeding the arterial pressure. So, there is an interruption in the uterine blood flow. And this causes oxygen delivery cessation to the placenta, thereby to the fetus. If contractions are very long or very strong, definitely hypoxemia will set in. So a mean contraction interval of fewer than 2 to 3 minutes reduces the oxygen saturation in the fetal brain. Still, baby is able to withstand the stress of labor during the recurring periods of transient hypoxemia. This is a physiological compensatory mechanism which is called as fetal oxygen reserve. Here, there will the oxygen, tissue oxygen levels are above the minimum oxygen level which are required for the normal cellular function. So, though there is a brief decrease in oxygen level, partial pressure, definitely the baby will be able to tolerate this. Next slide, sir. So as the duration and frequency of the contraction is increasing, again the mean placental flow will reduce. So that's how baby with less oxygenation will be resulting in the hypoxemia because of uterine systole. So there will be inadequate supply of oxygen and the contraction frequency is increasing. So it actually leads to late deceleration. Late deceleration usually occurs more than 15 seconds after the peak of contraction is done, usually seen in reduced placental blood flow like abruption, hyperstimulation, PIH, and in fetal conditions like IUGR, prematurity, and supine hypotension. Here, if we see, intrapartum uterine contractions are actually causing compression of the uteroplacental vessels, thereby PaC2 is reduced in fetus. And it is actually stimulating the chemoreceptor reflex. If we go to acidosis due to oxytocin, there is a multi-centered RCT done in France in at least 20 units. It is called Stopoxy trial. Here, less than 4 centimeter dilatation of cervix, they have actually given oxytocin, and they have observed that the neonatal outcome will be very good if we stop oxytocin in the active phase. Thereby, we have to reduce the neonatal acidosis, neonatal death, or HIE. If we go to legal complications, we as obstetrician, definitely we should be always monitoring, at least by checking the heart rate, or if we have a facility of CTG. If we are not able to titrate the dose or reduce the dose, by seeing the complications, definitely we are going to land up in legal battle. Thank you so much.
This one is done. Dr. Rekha ma'am's fetal particle, anemia.
Fetal anemia.
Fetal anemia, sir, Dr. Rekha's.
Hi, ma'am.
Good afternoon, everyone. So we'll start.
You can start up.
Next slide, sir. There is a case. So this is an uneventful baby which is delivered. It is 2.9 kgs, but the Apgar score of the baby is less at birth. And the hemoglobin is 4.1 and the hematocrit is 0.13. So this indicates massive fetal-maternal hemorrhage. So this baby was intubated, ventilated, and packed cells were transfused. So this post-transfusion baby was all right. So this session, the small session, what we are going to discuss is, we are going to talk about fetal anemia, which is not a very common condition. The earlier conditions were very common, but this is not very common. So the complex CTGs that we are now going to discuss in this slide is sinusoidal and pseudosinusoidal heart rate patterns, reduced baseline variability, saltatory, and pre-terminal. These are the three conditions, terminologies that we are going to be discussing in this session. Next slide. So fetal anemia, before that. By definition, all of you know what is anemia. Anemia is decreased oxygen carrying capacity. So reduce red blood cells than normal. So this is reducing the oxygen delivery to the tissues. There are three main causes of fetal anemia. One is either the baby is failing to produce the red blood cells, or there is accelerated red cell destruction, and the third one is there is fetal bleeding. There is loss of red blood cells through bleeding. So these are the main causes. We'll just look at quickly we'll look at what are the reasons for this. Increased red cell destruction, that is hemolysis, can be because of alloimmune causes like antibody mediated, like RH incompatibility. I think we have seen those cases, RH incompatibility. All of you know, we have all by hearted fetal anemia is a consequence of RH incompatibility. And then we can have minor blood group incompatibilities like anti-C, anti-Kel, etc. Infections, parvovirus B19, cytomegalovirus, syphilis, toxoplasmosis. These are the infections that can accelerate the red cell destruction. And then you have hereditary hemolytic disorders like hereditary spherocytosis and G6PD deficiency. Next slide, sir. So before that, sir. So red cell destruction is increased in aplastic, production is decreased. So in aplastic or hypoplastic anemia, again paro B19, congenital infection like CMV rubella, genetic disorders, alpha thalassemia major, diamond black fan anemia, and bone marrow failure syndromes, which is quite rare in vitro. And the last one is what we are supposed to be worried about, that is blood loss from the fetus. So the feto-maternal hemorrhage can be because of fetal blood leaking into the maternal circulation, TTTS, or placental or cord abnormalities like vasa previa cord accidents and massive placental abruption, or invasive procedures like fetal samplings and intrauterine interventions. So what we are worried of, I think the nightmare for us would be a vasa previa. So this is a sinusoidal pattern. So see, when we did our post-graduation, we did not have CTGs. We didn't have, it was only theoretical that we had. And I remember by-hearting this, you know, just looking at this and thinking and, you know, having the mental imprint that this is fetal anemia. So you see something like this, it is fetal anemia. So how is it different from the accelerations of beat-to-beat variability which sir was showing with the ball? Beat to beat variability is up and down. Beat to beat means every beat. The heart is beating at the rate of 160. Each beat has got a different rate. That is beat to beat variability. The normal is 5 to 25. I think all of us know that, right? So below 5 we call it as decreased beat to beat variability. Here there is no beat to beat variability. There is soft, smooth, undulating. So next slide, sir. So this is the thing that we had in mind. It is smooth, undulating pattern which is lasting at least for 10 minutes. The amplitude is anywhere between 5 beats to 15 beats, not rarely greater than 2 to 5 cycles per minute. There is no variability but smooth undulation of going up and down like this. This is the oscillation of the sinusoidal wave pattern, which is called the sine wave. There is no variability, there is no reactivity like we are talking about acceleration, deceleration, nothing is there. So if you see a pattern like this, you are supposed to think of fetal anemia. This is like, you know, pathognomonic of fetal anemia. Next slide. So the pathophysiology exactly of the true sinusoidal heart rate pattern is not clear, but fetal anemia equals tissue hypoxia. So there is elevated blood levels of arginine and vasopressin, which increases sensitivity of the autonomic nervous system, which is regulating the FHR, which is leading to this smooth pattern of fetal heart pattern. So the next, previously. So this slide, again we are seeing this serrated edges, but here we are also seeing decelerations. Next slide, sir. So this is called the pseudo-sinusoidal pattern. Here we are seeing this is called the pool shark tooth pattern. Okay, so this is the picture. So this is what it is equal to. So we see like the teeth of the shark, we see these variability. But when you observe it for more than 30 minutes, you see normal variability, and that is called pseudo-sinusoidal. So it's not a sinusoidal rhythm, it is a pseudo-sinusoidal rhythm. We should differentiate between the two. We are not, we don't have to be very much worried about pseudo-sinusoidal pattern. It is not having any much of clinical significance as long as this pattern converts to a normal FHR pattern. Next slide. So previous slide. Yeah. So this, usually we don't do anything for this. Some of them recommend VAST, that is vibroacoustic stimulation of the fetus. There is no need. You can just have some patience, wait out for 30 minutes. If it gets converted to normal, that is fine. But only thing we are worried is, are we having that time to wait for 30 minutes? So that is why probably we are going to do some intervention to know whether it is pseudo-sinusoidal or sinusoidal pattern. So now we are going to the other previous slides. So saltate. Saltatory is something that many a time can be missed by postgraduates thinking it is a beat-to-beat variability. So that is one thing. Saltatory, the increased, the variation is more than 25. When it is more than beat-to-beat variability is more than 25, then we are supposed to be worried about it. This is when the fetus is exposed to rapidly evolving hypoxia. Okay, so what is happening is, there is sympathetic and as well as parasympathetic activity. There is more activity because the heart is trying to obtain oxygen. Okay, so this exaggerated autonomic response can present as saltatory. So it's very important that we recognize saltatory pattern so that action can be taken. So another last one, Benckiser's hemorrhage is a serious obstetric hemorrhage where there is rupture of the velamentous insertion of the placenta. So here the exsanguination happens of the fetal blood, which is one of the most important reasons for fetal anemia and subsequently fetal death, because the fetus exsanguinates because of the bleeding that happens. Mortality is as high as 75 to 100%, and most often can happen because the hemorrhage happens when the membranes rupture either spontaneously or artificial rupture of membranes. So this is how a vessel which is seen, which is running through the membrane, and this can be injured leading to exsanguination of the fetus. Okay, there's another term, pre-terminal. This is one of the definitions that was used before 2017. Now it is all taken as pathological CTG. Okay, so absent variability, persistent late decelerations, atypical variable decelerations or prolonged decelerations, whatever we discussed till now are all clubbed under pre-terminal, no longer used in the present definition, but if somewhere it pops up, you should know to understand what it means. Okay, so this is fetal anemia, I think baby drowning in its own.
Because what we have seen, the baby is going upward, downward, but here there is completely loss of that variability. The baby is floating, define this baby is dead, already died baby. So this is what, the lack of variability or turning of the baseline. What madam is trying to say, sinusoidal wave is, the baseline has changed into the sine wave. This baseline changing into sine wave is called as a sinusoidal. There is no variation there. The baseline itself is in a sine wave. That's where this is called as continuous sine wave pattern, where there is a completely loss of variability and the heart has stopped long back.
I thank the organizers for this opportunity.
Thank you, ma'am. Nicely explained. And madam from the super moderator, ma'am.
So thank you panelists, and it was very elaborative and very interesting topic, and everyone has done very well. So only my take home message is only the few words, like depending on the acute hypoxia, as we know that mainly that cord prolapse and then the abruption and the scar rupture. So in this thing, abruption we cannot do anything, only that cord prolapse or a scar rupture. In case if we don't have, we have to follow the rule of that 3, 6, 9, 12, 5, rule of 3. Or in case if we have a OT next to the labor room, there is no problem, immediately we can do the cesarean section immediately. Otherwise, in case like even in St. John's also, we have to shift the patient in emergency from first floor to the third floor or the second floor, wherever they give. So in case we have a proper system, we can shift the patient within 15 minutes, no problem. If we don't have anything, then we can make a systems like a code blue type. Okay, if there is any cord rupture, cord prolapse, everyone knows that what they have to do, and then we can shift the patient immediately, that we can do. And at the same time, tachyphylaxis, tachysystole, we can give about 1 liter of fluid, that we have to, everyone should know that, and put the patient in the lateral position, even though they say that there is no improvement in this thing or we need not do, but still that it may help. And terbutaline 250 milligram, we have to, whenever we are giving the tocolytics, we should know that what is the contraindication for that. Again, we should not worsen the mother condition or the baby's conditions, and immediately have to stop the oxytocin. In subacute hypoxia, there is we think that it may be a normal, because everything it looks like a, even the new PGs comes or new ISR comes, they may think that it may be a normal, but we should educate them that to what is normal and what is abnormal. Evolving hypoxia, it is a variable deceleration. Everyone should know the shouldering effect. If they know the shouldering effect, they have to follow the NST, and if there is no improvement, you have to see is there any high risk factors, and then we have to, if there is no improvement, then there is no high risk factors. We have to make sure that if any one set of immediate the decelerations, we should take her for the cesarean sections. Fetal anemia, everyone knows that we have to follow the Doppler MCV, middle cerebral artery PSV. We will come to know that. Or if the patient has any problem or a fever, we can do the torch, and mainly the parvovirus, it causes this thing that we have to find out. And lastly, the take-home message is that because we are discussed NST and the CTG, so better we have a NST CTG classes. Periodically we have to take the class for the PGs, and then the SRs are in the department, so that everyone knows that what is normal and what is abnormal, and at the same time we can take a pictures of all abnormal CTGs and NSTs, and then we put up in the NST room and in the labor room, so that will help for to take care of the baby, so that they can identify the what is the abnormal CTG, then we can take immediate decision, and then we can prevent the HIE. Thank you, sir.
Thank you. Madam, sir.
I think we should congratulate the moderator for standing there for nearly 4 hours now. A big round of applause for him.
No, he will stand for in what is it, Andhra Pradesh conference, stood at 8 o'clock, till 8 o'clock gynecologist killed him. Pediatricians doesn't, ayo, bit buddy sir. You people never left him. I was, he's telling.
Excellent topics and
Please.
Excellent panel discussion. Because there is an august audience here, I like to share. This is whatever we are discussing since morning is something very burning issue, a problem of the country like ours. Knowing this, we had a great association with Dr. Robert Goldenberg, a senior obstetrician from Columbia University, who is an authority on stillbirth, and Dr. Elizabeth McClure. She's a senior epidemiologist from Research Triangle Institute, United States. Between 2018 and 2020, we studied 700 stillbirths and 700 preterm neonatal deaths. One our site in Davangere, I was the site investigator, and the other one was in Karachi. It is an Asian population. Interesting observations were made. So far, we have 27 international publications from that project, and both the primary papers are published in Lancet. 2022 July, neonatal deaths. 2022 October, the stillbirth paper got published. The take-home message was that we have done all the molecular investigations, multiplex PCR, autopsy, and if autopsy is not done, we have done minimal invasive tissue sampling. We have subjected the test samples for multiplex PCR, all that. The consistent take-home message is intrauterine hypoxia is an important fetal cause, both for fetal death and also for neonatal death, more than the respiratory distress syndrome. Second one is neonatal death. Infection is a burning problem. And as it is discussed since morning, in this multiplex PCR in all the specimens, we could recognize Klebsiella, E. coli, and Acinetobacter as a major threat. And the neglected, we are discussing so much about the fetus and the mother, no much discussion on the placenta. The future is understanding placenta and treating placenta, not the fetus. Now all the work is done on how to improve the circulation in placenta, how to make the fetus healthy. And I am happy to say just last week we received a confirmation of a last paper of this for publication in BJOG. The title of the paper is Shared Placental and Asphyxial Pathway as a Cause of Death for Stillbirth and Neonatal Deaths. This is accepted for publication. I am very sure it will elicit a lot of response from all the researchers in that. I once again thank Dr. Dinakar for this great opportunity. Thank you.
Thank you, sir. Sir, stay, sir. Please, please. Illeri, sir. Illeri. Madam, please come. Madam. Bama. Okay. Ba, bega ba. Andu. Dr. Hema, madam. Madam, please. Edkondi. Eradu neeve. One photo. Smile. Next. Rekha, madam. Bhaskara, Shashikala, madam. No, కూర్చోండి. Next, Sahana madam, come fast. Mamata madam. Mamata. JSS. Madam, sitting here. Oh, sorry.
Sir.
You give to madam and group person, sir. You come fast. Sahana madam, Randy. HOD JSS madam. See, old student to old student giving. JSS. Okay, sorry. Sahana madam, hey, Guru Prasad sir, kodu chinu. Sir. You are, madam, please come. But, hey, ba, Nirmal. Oh, Baba. Okay, thank you. One second. See, now we are going for the food. See, after that, chronic asphyxia is there. See, always we neonatologists fight against the gynecologist. We are like something everybody is telling Sasbahu, no? Always fight. It's like that we are, madam, 1 second. We are fighting because, see, Meconium is passed. You people will tell it is just now passed. We will tell, no, madam, it is timed. Then how many hours like that. Now chronic asphyxia, what happens? Why baby will die? Now that class is going to that one. We are cutting for 45 minutes. Next class we are cutting for 45 minutes. We are finishing. Okay.
Sorry. I don't know post lunch how many will sleep off, how many will go off. So this thing request. No, all HODs have come here from all medical colleges. Outside also they have come. So one announcement, we do conduct a luminous quiz every year in Saptagiri Medical College for the medical students, final year students. On 27 September it is there. Please send your students for that luminous quiz. Batches illa. I found out and I inquired and I have 27th August. So please do send your students. September, yeah. Thank you for you.
Okay. See, I am giving you only 15 minutes. Please take a plate, grab and come. I'll only be there. I'm telling. Because many HODs wants to go. They're really because their kids are not well. They have to catch their practice, and more than a practice, family people are waiting. Please, 15 minutes. I'm requesting. 15 minutes. 15 minutes. I am only coming. Please, madam. Everybody. 15 minutes. టాపిక్ అలాగుంది అది ఈడుస్తున్నావు అదేమైతే ఉంది ఇంకా 2 టాపిక్స్ ఉన్నాయి కదా we have told 5 o'clock it will end so what they are thinking see Davangere madam has to go from ESI hospital she has to go practice or family some function is there and many people madam I cannot blame anybody here the first talk it has went on 2 hours so I was not here I went somewhere that he knows he also cannot be blamed because he is a new person దానికి చెప్పింది నువ్వు కట్ I cannot see otherwise I will become dictator Parimala will have food okay but No, no, once snap something. Come, come. 15 minutes. Junaid, Bunny. Come. This time. Thanks. Come, we'll go for food. Please, everybody come for food. Please come. Please. Madam, please come on.
efficient and efficacious. Very limited attention has been paid through medical problems and complications associated with it. So what are ART? They basically include all fertility treatments in which gametes are handled, includes IVF, ICSI, frozen embryo transfer, etc. So these are steps in IVF cycle, which is ovarian stimulation. It involves ovarian induction. Gonadotropin drugs are administered over 10 to 12-day period to stimulate ovaries to produce follicles. And ideally, each should provide 5 to 10 follicles, giving up to 10 to 20 follicles. HCG trigger is given for further maturation of the ova. And ovum retrieval is done through transvaginal ultrasound-guided aspiration. So collected eggs are then taken into embryology lab or inseminated with prepared sample of semen, and embryos are cultured up to day 5 and are transferred into the uterus for hopes of further implantation. This is ICSI, which involves selecting single sperm with best motility and injecting directly into matured egg with a microneedle for assisted fertilization. Cryopreservation is a process that freezes and stores fertilized eggs or embryos for later use. It can help people to preserve fertility and have options for pregnancy later in life. Embryo biopsy techniques are helpful in finding out genetic disorders in couples and who have risks of genetic diseases in the past. So ART doesn't come without risk, and minimum attention has been paid to the complications and risks associated with assisted reproductive technology. It is important that we recognize them and timely intervene so that the ART cycles are efficiently used without any further risks. So these are some risks related to assisted reproductive technology. There is potential for complication at every stage of IVF procedure. That is why I wanted to brief on each procedure of IVF. I would like to majorly concentrate on the perinatal complications, which are multiple gestations, preterm birth, low birth weight, and congenital malformations. So these are multiple gestations. Incidence of multiple pregnancies via ART pregnancies is very high. And IVF directly influences the risk of twins or multiples. Naturally occurring twin rate is 6%. It is up to 25% by IVF pregnancies. And risks of higher rate of preterm birth, low birth weight, and neonatal morbidity is higher in multiple gestations. Also, there is increased risk of placental abruption, vasa previa, and placenta previa. ART is associated with twinning. It is not just dizygotic, also monozygotic. Studies suggest that there is increased incidence in monozygotic twinning, maybe due to techniques such as embryo handling techniques or manipulation techniques such as ICSI or assisted hatching or day 5 transfers, so that there is increased risk of twin-to-twin transition, which is the transfer of blood from one twin to another, which is 10% in any conception, whether it is through IVF or the natural pregnancies. This is a meta-analysis that shows that twins are increased risk. IVF twins are specifically increased risk of preterm birth and low birth weight compared to naturally occurring twins. This is a systematic review that shows that advanced pregnancy outcomes among singleton pregnancies conceived via IVF or ICSI and spontaneously suggests that there is increased risk of preterm birth, low birth weight, and perinatal mortality in singleton IVF pregnancies. So the risk of preterm birth is higher in ART pregnancies, almost 2-fold higher than in spontaneous conceptions. And also you can see the graph that the ART pregnancies show higher rate of preterm births as shown in the graph. So risk of low birth weight is higher in ART pregnancies, almost twice that of spontaneous conceptions. Contributing factors include placental dysfunction or the embryo handling techniques or embryo culture conditions, and many other IVF lab contributors. So this is an article which proposes potential etiologies for low birth weight in ART conceived children, the effect of ovarian stimulation protocol and egg quality and endometrial receptivity, the subfertility of parents that affect embryo quality, or the effect of culture media and lab conditions, and the developmental stage of in vitro that could affect the birth weight of the children born through ART. So this is the schematic representation of that shows possibly the factors that affect the embryo quality and endometrial quality. It could be culture medium or stage of development or even the induction protocols, which lead to implantation potential drawbacks and also developmental potential hindrance in embryo, which would in turn lead to suboptimal implantation or placental effects, which might lead to low birth weight and other adverse conditions affect in the perinatal period. So these are the determinants of embryo quality. What could possibly affect the quality of the what could possibly affect the embryo is the culture system or the manipulation techniques or even the parental demographies or the gamete quality. So abnormal placentation is higher in ART pregnancies, which is placenta previa or vasa previa, which is 1 in 2,500 without IVF, where it is 1 in 215 with IVF. So there's increased rate of birth defects from 8.3% with ART to 5.8% without ART, and other chromosomal abnormalities and birth defects are associated with babies born through ARTs. Okay, this is a meta-analysis which shows that ICSI was associated with higher risk of birth defects and also increased rate of NICU admissions in ART-born babies. There are long-term outcomes of children born through ART babies, which are enlisted in this slide. And also there are neurodevelopmental outcomes, which are increased rate of cerebral palsy in children born through ART. So each procedure of IVF is related to some or the other adverse effects in the ART children, as shown in the picture. So these are some of the causative factors in perinatal risks associated with ART. There are epigenetic and molecular changes or the ART procedural factors. These are some of the risk mitigation strategies, which is elective single embryo transfer or optimal maternal health, enhanced monitoring during pregnancy, or even the NICU preparedness. This is guidelines from ASRM in ISHRE, ACOG, and WHO, who suggest single embryo transfer and preconception evaluation and enhanced maternal fetal monitoring. This is a multidisciplinary approach from a reproductive medicine department or the embryology lab or the gynecologist or the maternal fetal medicine specialist or the neonatologist and pediatrician to ensure it is a holistic care from the lab to pregnancy to neonatal and long-term outcomes of the newborns. So in summary, the recognition and timely intervention for ART related adverse effects is important, so because the ART cycles are rapidly increasing globally. The recommendations include the data pertaining to risks associated with ART are limited, and continued tracking of outcomes of ART pregnancy is appropriate to include data beyond birth. So this is basically the summary of what I've been discussing. Thank you.
Over to Dr. Shivamurthy, sir, because the sir has been waiting. In order to utilize the SAR services, we are first moving with the SAR. Straight away, sir, we are going to display the.
This is a request and apologies for me, because I have to travel back to Davangere and I have brought my driver with me. It is rainy season, and with your blessings I want to leave early. That is why I have requested sir to take me, and I am sorry to make the lady from Kotureshwar Hospital to rush through, and she has accepted with great heart, and I apologize the organizers for taking me to this one. I would love to listen till 8 o'clock, but I am sorry, I have to leave. My son is leaving to UK at say 11 o'clock in the night. In that situation, I am made to rush through, and I was listening, enjoying everything since morning, the feast of perinatology, and lot of recommendations and arguments from our side, and really thankful to you, sir, and thankful to Dr. Dinakara and all over here. And we have brought a very nice 6 PGs from my college, and I hope you will all bear with me for this inconvenience. And Kottureshwara madam, sorry, I will come and talk to you in Shivamoga. I am in Shivamoga only, Subbaya College. We will meet sometime. We will conduct an IVF workshop in Shivamoga only, in collaboration with this Vaidehi and Kottureshwara Hospital. That madam is known to me. My apologies for you. Thank you.
So
Okay,
the panel
sir.
discussion will be on the chronic hypoxia, as we discussed about the acute hypoxia. Now we'll be going chronic hypoxia.
ಸರ್ ಮೇಲೆ ಕೇಳಿ ಪರವಾಗಿಲ್ಲ, ನಾನು ಸುಧಾರಿಸ್ಕೊಂತೀನಿ. ಮೇಲೆ ಕೇಳಿ, ಈಗ ನಡೀತೈತಿ
ಸರ್.
ಸಬ್ಮಿಷನ್ ಐ ಹ್ಯಾವ್ ಡನ್. ಈಗ ಒಂದು 2 ನಿಮಿಷ ಮಾತಾಡ್ತೀನಿ, ಪರವಾಗಿಲ್ಲ.
This is a chronic hypoxia. Sir, can I discuss the case first? Or directly I will go for, because
You tell the case, then I will go to my slide.
Okay. A 35-week pregnant woman with poorly controlled diabetes mellitus.
Sir, your slide.
That's okay, sir.
Okay,
I'll explain
that
it.
is good. That is good. Thank you.
And on diet and insulin and borderline high blood pressure presents with the decreased fetal movements, you are called to assess the fetal well-being. Fetal heart rate normal at the time of the initial evaluation. Doppler studies at 31 weeks, middle cerebral artery low resistance, umbilical artery high resistance. Current Doppler findings are MCA high resistance. Estimated fetal weight is 2 kgs. Amniotic fluid index is 8, and the mother is admitted for the close monitoring vitals, and fetal heart rate remains stable initially. However, the following day, intrauterine fetal demise is diagnosed with absent fetal cardiac activity. Now we are going to discuss about the chronic hypoxia and the intrauterine fetal death. And because as we are we want to utilize the SAR services before he leave, first I will be jumping to the SARs only. Sir, Dr. Shivamurthy sir will be explaining about the CTG in the chronic hypoxia, how to assess him, because IUJR baby CTG, how to assess and why they are passing suddenly Meconium. That will be.
Thank you, sir. Thank you. So kind of you. Sir, this case is very clear. High-risk pregnancy, number 1. Diabetes, uncontrolled, and hypertension, number 2. Number 3, all the parameters already show there is hypoxia inside. And close monitoring, the answer is everything is in the diagnosis only. Close monitoring also you are told. So this lady, I want to admit to our say high-risk unit, and the parameters for monitoring any high-risk pregnancy for that matter is starting from kick count, which may not be very much useful. Number 2, I will go for the NST, because she is not in labor. NST, as mentioned in the morning, Rajni madam has told very clearly. NST we are going to go with 4 parameters. Heart rate may not be useful. Heart rate changes. 1 nimisha, sir. Heart rate takes some time to manifest because baby has got lot of reserve inside. So first, the parameter the baby is going to lose or manifest is in biophysical profile, loss of tone. We mentioned already in the morning. And number 2, in NST is loss of the beat-to-beat variability. These are the highlighting points. These are red light areas. When things occur here, we are supposed to decide and we are supposed to take action here. No more waiting there when these 2 things occur. However, the hypoxia is an ongoing process, and these babies do really, in fact, they do well because they get accustomed to that. That doesn't mean that we should take, these babies for granted. 2 kg baby, diabetic, we want to know is it controlled or uncontrolled. Number 3, hypertension controlled or not. Anyway, baby is in a high risk center only. So these are some of the parameters which we have to monitor such baby. Go to next slide, sir. Next slide. This is the baby needs very much help from us. It has come to us, mother has come to us for us only. And remember, this baby is in a hostile situation inside condition. Number 2, it is premature also. These 2 points going to act. This activity shows on the earth, no uterus is quiescent. Uterus has got inherent contractions, so-called, we can make use of the Braxton contraction is because of oxytocin, because of imbalance between the estrogen, progesterone, that is there. But these minute subtle changes in the uterine activity, those good babies will still sustain, though there is a dip in the heart rate, but they pick up immediately. And they are not really deceleration, something like that. This is what the diagrammatic the representation of a car which has got good reserve, which can climb some hurdles like that and come out, and it doesn't need any petrol bunk immediately. Means it can sustain, it can manage. Whereas a strained IUGR baby, which needs immediate cover there, as it is shown in the petrol bunk, and wonderful illustrations given to me. I thank the person who has created this wonderful.
Sir.
Oh, hats off to you. So this IUGR baby has got less reserve. What all the reserve is already explained to you in the morning, chronic hypoxia and all. And these babies immediate attention. They have to be with us only, immediate attention. Next slide, please. This is what one more way of showing all this snake-like ladder there. It is self-monitoring, self-explanatory. Same thing. One more. Now, instead of going a straight way towards term and safe delivery, these babies will take a wrong turn there because they are not doing well. See there again, the uterine contraction is there. There is a decline, but it is unpredictable. The baby's heart rate is unpredictable. Keep in mind, heart rate alone is not going to help us. Heart rate is one of the parameters, whereas we can have a good heart rate 130, 140, but fixed heart rate without changes. With heart rate without changes is very ominous. It is very dangerous. We need to look into the beat-to-beat variation as it was already explained. One is heart rate agreed, but not too much. Heart rate can be misleading. 160, but loss of beat-to-beat variability very bad. Then you told in the beginning, the immediate response of the baby, which is asphyxiated, is tachycardia, as because of adrenals you told already. Then comes bradycardia, that is number one. Next is loss of beat-to-beat variability. It shows intact the brain and heart contact functioning. Okay. Third one is presence of acceleration is a good sign. However, in sleeping baby, it may not be there. However, it will not rule out a bad baby. Where occurrence of a deceleration of any type deceleration is bad for the baby. 5 to 15 beats sustained for 15 seconds. That is the definition. Just pick down and go up is not going to be useful. It tells definitely baby is bad, heart is bad, but it is picking up. Something like the madam is showing that day. Some say subacute say asphyxia, something like that. We want a baby to show good resistance, good pickup, good reserve and good pickup for anoxic challenge. It has to handle it and it has to come down. Now here it shows uterine condition. It is a CST, contraction test. Uterus is acting and baby showing some amount of acceleration, deceleration. Not really convincing, but still we could put as reactive. But we have to keep this baby in observation. Next, sir.
Sir, even without rising baseline, this baby can't rise the baby.
Even without, I told then, rising and less is adrenal function. But most important thing is fetal cardiac activity, loss of beat to beat variability. Sinusoidal pattern is rare, very rare. Sinusoidal pattern, heart rate could be normal, but loss of beat to beat variability, baby will not respond. It becomes snake-like. You do whatever you want to, I will sleep like this only. But heart rate could be normal. Sinusoidal pattern is the worst possible thing can happen. This baby is almost stage 4 shock, something like that only. That is the worst sign, ominous sign. We should never allow baby to go beyond type 1 dip. In the absence of timely intervention, ongoing hypoxia and acidosis continues with the fetus unable to rise a baseline, above the baseline. That is what you want to say, recovery of the heart rate. There is marked reduction in variability, I mentioned already. If the situation is ignored, their fetal heart rate is gone and we are likely to end up with fetal bradycardia, sinusoidal pattern and loss of baby. And best thing is in situation, what I would have done is, I would have gone for, if head is low, if possible, 2 kg, we can definitely solve this baby. Go for fetal scalp stimulation test and see the heart rate, whether it is moving or not. Earlier, abdominal root, madam was mentioning, the morning health, madam, we can go for the abdominal cyanoacoustic test because some of the babies sleep during day and get up in the night. If the sleep pattern is there, go for vibroacoustic stimulation test. Baby shows, okay, I'm okay. If that doesn't occur, you can go for still scalp stimulation test. There also you should tell, okay. But that also is not responsible. I am like this only, I can't do, sorry. Then you go for scalp, vein, scalp pH and lactic. If they are there, they are Supreme Court and there is no chance to leave the baby further, whether she is in labor or not. 2 kg baby and baby is in hostile condition and we have to look at that one, all those things. So that is the best way what I can do, sir. Thank you.
Sir,
again, if there is a in addition of this one, if there is a this lady 30 weeks, it is already premature baby. Plus, if it is present with the breach, and it again poses some more problem for the cord compression especially. And These are the indirect signs that baby, we are not going to have a good baby at all. Baby's prognosis is very bad with breech presentation because delivery, cord compression, everything occurs, sir.
Thank you very much, sir. And what I want to discuss even further beyond these things, after that we will be discussing 10 out of the 8 severe IVGR babies in the breech presentation.
Yes, sir.
Why? Why?
One is prematurity, number one, if it is there. Number two, these babies should have the energy, so-called the energy to move about. The breech babies, they become vortex because of their own movements and all. These movement is affected because stone is affected. They stay like that breech only. They stay like breech only. This baby is not vigorous enough to change itself. Usually 28 weeks, 30 weeks, the chance of baby being breech is less. 3% of the term babies will become, only 3% will become breech, because these babies do not have that energy, that vigorness to convert themselves. They stay like breech only. Premature babies and these babies which are bad, they are already strained inside the uterus. They present as the breech presentation, sir.
Exactly, thank you, sir. Because in the severe PM babies, they will be clumsy. They don't want to move. Severe PM babies, they
repeaters exam, repeaters, third time, fourth time examiners, no. You take special class, they won't come. You only bring them, pass them. They become repeaters, something like that. I'm sorry, don't mistake me if there are any repeaters here. They are the best students, they are the best as a practitioners. They are very good there because they have a lot of experience. Just for the sake of explanation time, they are repeaters only. No, I can't come for the examination. You only could come and take me and pass them. You have passed many students like that. So these babies are, somehow they are in a hostile condition. They can't cope up with that one, and they can't grow also in that condition because of high risk situations, and we have to take care of these babies. So 2 kg, definitely they should come out. They should live a very good life. Some of them should become pediatricians like you.
Thank you, sir.
Thank you very much.
Sir.
Thank you.
Sir.
Thank you, sir.
Hand over the...
ನಾನು ಪರ್ಮಿಷನ್ ಕೊಟ್ಟರೆ ನಾನು ಬಿಡಲಿಕ್ಕೆ ಇಷ್ಟಪಡ್ತೀನಿ, ಕ್ಷಮೆ ಇರಲಿ. ನಾನು ಭಾಳ ಕೇಳಿ ಇಷ್ಟಪಡ್ತಿದ್ದೆ. ನಮ್ಮ ಪಿ ಜಿಗಳು ಬರಲಿ ಬಂದೆ ಕೇಳಲಿಕ್ಕೆ ತುಂಬ ಇಷ್ಟ ಇತ್ತು. ಅವರು ಕೊಟ್ಟೂರೇಶ್ವರ ವೆರಿನೆಸ್ ಪ್ರೆಸೆಂಟೇಷನ್ ಅಲ್ಲಿ ನಮ್ಮ ಡ್ರೈವರ್ ಕಾಯ್ತದಾನೆ, ಬಿಟ್ಟರೆ ಅವನು 8 ಗಂಟೆ ಬಿಟ್ಟು ಹೋಗ್ಬಿಡ್ತಾನೆ ಕಾರ್ ನನಗೆ. ನಾನು ಡ್ರೈವ್ ಮಾಡೋಕ್ಕೆ ಮುಂದೆ ಕಲಿ.
Okay, sir. Thank you, sir. Thank you.
I shall leave you without apology. Thank you and with gratitudes. My PGs, please come here. I want to have a snap with them. Sir, I have brought 6 PGs with me. Hey, come here, quick. And with that, 1 PG is from your college only. We have adopted her there. ಎಲ್ಲ ಬನ್ನಿ ಜಲ್ದಿ ಬನ್ನಿ, ಲೇಟ್ ಮಾಡಬಾರ್ದು. ಬೇರೆ ಕಾಯ್ತಿದ್ರು, ಅವರು ಹೋಗ್ಬೇಕು. ನನ್ನ ಮೇಲೆ ಸಿಟ್ಟಕ್ಕಾರ ಅವ್ರು, ನೋಡಿ ಸರ್ ಇಷ್ಟು ಟೈಮ್ ತೊಗೊಂಡಿ ಅಂತ. ಒಂದು ಫೋಟೋ ತಗೊಡು, ಬರ್ರಿ ಸರ್, ಮೊಮೆಂಟೋ ಕೊಡಿ. Thank you. So highest number of PGs from a medical college is this. Okay, I am thankful. I am say very happy that they are here.
No, sir, we are very happy, sir, to have you.
Okay. Dinakar, sir, where are you? Dinakar? Sir. Thank you.
For all the interruption that is going on, but yet one more madam is in rush. I can move on the things, sir. Dr. Srilata ma'am, yes. You can take over yours, ma'am. Madam is in rush, so that madam I will finish it up, sir. Dr. Srilata madam will be explaining about what is the importance of the ductus venosus Doppler in the intrauterine fetal demise, or what is the role of the ductus venosus Doppler? And you can take
usually, yes, sir. Slide, sir. So everybody knows about that fetal circulation. Just before going for the importance of the ductus venous, before going for ductus venosus, just I wanted to tell about the touch of the fetal circulation. See, the blood will enter from the placenta to the umbilical vein. From there, it will enter to the ductus venosus via portal vein. From there, it will enter to the inferior vena cava. See, from there, it is entered into the right atrium. So there, it is divided into 2/3 it will enter into the right ventricle. It will mixes with the venous blood of the superior vena cava. Then it will enter into the right ventricle. 1/3 it will enter into the right atrium. So this is just brief about the fetal circulation because I don't want to go into the depth of that. Just I wanted to tell you what is ductus venous is a connection between the portal vein and the inferior vena cava. It is a low resistance bypass through the liver. The next, the functions of this is the placenta, umbilical and ductus venosus. And then it's a function of this is it bypasses the liver, carries an oxygenated blood. It enter the right foramina, right atrium through the foramina ovale to the left atrium. So ductus arteriosus, then it's placenta, that is a aorta, and then purpose is only to prioritize the oxygen carrying blood to the brain and heart. So usually, sir, skip the slides. Next. Just I wanted to go before that important of this. Usually whenever you ask for the Doppler studies, see this is a ductus venosus is a late stage. It will tell about the condition. It is one of the good predictors for the perinatal outcome, and it will tell you about the condition of the fetal heart. So because it is that is a 20 to 30% of the blood directly enter into the heart. It maintains the cardiac preload. It is a directly highly oxygenated blood to the coronary and cerebral circulation and act as a hemodynamic gatekeeper. See, it is usually when you are studying for these Doppler studies, so it has got an important, that is it has a biphasic pattern, and it has got a S wave, that is a ventricular systole. There is a filling. See, one thing you should know that it is a biphasic pattern. It is a continuous flow forward from systolic to diastolic. There is a continuous, that is an atrial contraction, that is known as an A wave. So because there was a study done by the trial of a randomized trial, that is an umbilical fetal blood flow in Europe, they have made it as 3 stages. So that's next slide, I'll tell you about that. So here we should know about the A wave. That is an S wave is tell about the ventricular systole. D wave is about whatever the blood flow, it is in the early diastolic. There is a continuous flow, it is known as an A wave. Wherever there is a change in the A wave, then only it will reflect whether it is a reverse or absent A wave, which will tell about the fetal acidemia and then IUD. So next slide, sir. So this is a normal flow where there is a systolic, that is an S is a systolic atrial filling, and diastolic is a ventricular filling. That is an A wave. So next slide, sir. Because whenever there is an absent A wave, it leads maybe because of the central venous, increasing the central venous pressure, decrease the myocardial compliance and fetal hypoxia and acidosis. It could be associated with IUGR, or even in case of hypertensive and even diabetic, it may be associated, and even aneuploidy. See, when you know that it's in a normal waveforms, so where there is an absent wave, that is an A wave is an absent, there is an abnormal late diastolic filling. Reverse is in a late diastolic filling. If it is an absent, there is something called a fetal acidemia, which is causing it may be causing the hypoxia and fetal IUD. And so next slide, sir. So this is why this is an alteration in the ductus venous flow, especially in an absent or reversed A wave, represent a late changes in the biophysical cascade with an alteration of the short-term variation and biophysical profile preceding to fetal acidemia and IUD. It is due to progressive dilatation of the isthmus in an attempt to increase the blood flow towards the heart and to compensate the hypoxia. So that the next thing is early changes in the ductus venosus. This is a study, the trial which is in the randomized trial in the umbilicus fetal blood flow in Europe. They have they have made it a 3 definition, that is an early changes in the ductus venous is defined as a pulsatile index is above 90th percentile. Late is defined as an absent or reverse A wave. There is one word they used, it's a reduced short-term variation, which is below 3.5 milliseconds between 26 to 28 weeks of gestation, or it is below 4 milliseconds between 29 to 31 weeks. So the ultimate, this is the, see what I wanted to tell you, see usually they won't, nobody will check for the fetal ductus venosus, as usually the changes has been taken place in already in the Doppler, uterines are umbilical, that will show about the reflect. So fetal circulation ensure preferentially perfusion of the vital organs. Ductus venous is vital shunt and diagnostic tool. Doppler abnormality is early prediction of the IUDs. Interrogation with an abnormal, uterine artery and MCA Doppler, optimal perinatal outcome. Thank you.
Thank you very much, ma'am. Can I add something?
Yeah, you can. Sure.
This is how ductus venosus is a direct representation of the atrial pressures. Suppose if you see in the JVP, what you will see? If there is an A wave, contraction of A wave is present and atria is getting contracted. Or atrial fibrillation is there, or atria is unable to contract, the A wave will not be there. So remembrance wise, I just kept that thing. This ductus venosus is a direct representation of the right atrium pressures. So in case if the atria is about to good contractility or good status of the right atrium, when the atria is able to contract, automatically the resistance is felt in the ductus venosus. The resistance of that is being felt. When the atria is good, means we are indirectly checking all the heart status in that thing. When the atria is good, automatically it is creating some resistance or pressure in the ductus venous. Suppose when the person is pushing from that side, you are pushing from this side, you can feel the resistance of both things. So the ductus venous is pushing in this way, atria is pushing in this way. So when the atria is pushing, we are seeing some wave in the waveforms. So automatically that is representing the directly status of the heart. When there is an absent, means the pressure I am applying, the ductus venous is applying, in the right atria is same, there is a loss of A wave. As I explained in the JVP, if there is a loss of A wave, the atrial contractile is coming down. So this way, when the A wave is coming down, means the atria is unable to push the resistance. Resistance is lacking. So the atria is under the failure. Atrial contractility is coming down. When the atrial contractility is coming down, automatically this pressure we are unable to feel as an A wave in the ductus venosus. So this is a clue where there is a decreasing, one side it is absent. So when there is an absent itself, there is a definition that the heart is under hypoxic status or the baby is in the going towards the fetal acidosis, where the acidosis is decreasing the cardiac contractility. So in case if the atria completely lost its contractility, so atria is unable to push. So what is happened? This has complete control. It will go, blood will come back. So obviously when the blood is coming back from the right atrium, means deoxygenated blood, going and coming back. The atria is unable to pump, completely lost its function, means complete cardiac failure or cardiac arrest. So this baby already died. This where it helps is when we have these ductus and everything, so that we have counsel much prior. Before delivery, if we have all these things, we can tell them this is absolutely almost the fetal day. This is a fetal day. Certain times this will help you in many cases in counseling. When there is a reversal of the A wave, and then you can easily say that this baby already compromised and the heart is in the failure, whatever the resuscitation that happens may not survive. Means this baby, when there is a reversal, the pH of the baby has landed less than 6.9 and the baby has completely lost its cardiac contractility. Sir Junai sir, you are the expert in these things.
I'll take it at the end, sir.
Because you are in the rush, we kept it all these things first. And we'll have the discussion, because we have the discussion where the baby, when the landing in the chronic hypoxia, what are all the changes that happens, we'll be discussing. So we'll enter into the original cause. You want to leave? That's your choice, because sir was in Russia. If you can stay, no, we can discuss. Madam? Maybe under 40 minutes. Okay, after completely learning about the acute hypoxia, now we have starting about the chronic hypoxia. This chronic hypoxia, so we are coming back to first thing. So here there is a person in utero, they were there, and now the baby died in utero. Okay, now we are seeing some babies may be coming to ICU and baby dying. That's a conversion of the fetal death into the neonatal death only. Obviously some babies are dying. In spite of the vigorous resuscitations, the babies are dying. The babies are dying because of the neonatal death. All the changes that has happened with the cardiac compromise and cardiac failure, we are taking the baby. That's the reason the baby is dying. This gives a clue. Where there is an absent or a complete reversal, we know that there is a completely acidotic baby. So here is that way. Sir, Dr. Srinivas K. Joyce. if SAR is absent, no, this is the first thing that already baby in utero fetal death happened because we have been monitoring in the hospital, and then there's a sudden intrauterine fetal death. This is just to address how we are going to address and face this. Someone is there. Madam? Madam, yours is one thing. You can explain this and add to this. In the added way, we have made it more emotional way, saying that yesterday itself the shower has happened, baby shower has happened. Everyone is waiting outside. Everyone is outside the door. They are waiting eagerly to hear the baby cry. Unfortunately, inside some other things are happening. Baby didn't cry. We have resuscitated a lot. We have done all the things, and then the baby died. The baby never regained the heartbeat. Now we are coming out. See, there is a different scenario running outside, and you are inside the different scenario. Now we are facing them by opening the hands, and then how we counsel them. That's the things, man.
Yeah, next slide, sir. Slideshow. Yeah, slideshow.
This is the mother radiant with anticipation has celebrated. This is more an emotional way I kept it up. Everything is joy and hope, but in the delivery newborn didn't cry, only gasped with agonal breath. Despite immediate and full resuscitation, heart never started beating outside, the father and family waiting eagerly to hear the baby's cry. Now the pediatrician must walk out and tell that their baby could not be saved.
Yeah, basically this is how to give the devastating news and how to give emotional support to the parents. Next slide, sir. So we all know this in this situation, intrauterine fetal death, we all know that it's an important cause of economic and social impact. So after the death, this is addressing mainly from the neonatologist point of view. Also there are some students, so I just want to give apart from that support, emotional support, some of the other things they're supposed to do, I'm going to say that now. So if I just take the history from the mother, or the detailed clinical history from the mother, and after the death of the baby, if the baby comes out, so when I do the detailed examination, so the cause of death is going to be there, only for 18% we'll get to know the cause of death. So along with the clinical history and the examination of the fetus and the fetus on examination, and if you send for fetal autopsy and then looking at the placenta, that is going to give 90% of the times it is going to give the cause of death. So that is why it is important not only to just examine the fetus and tell the parents, clinical history from the parents, fetal examination, fetal autopsy and placental examination will give me the cause of fetal death in 90% of the cases. So why it is important to know the fetal causes? Previous slide, there only, sir. Previous slide. So it is important to know the cause of fetal death because that will help me in the better management of the next pregnancies. So we need to have the maternal history of infections, whether she has any hereditary and genetic causes or gestational diabetes. And this baby has, this mother had uncontrolled diabetes. That is what you had put it in the thing. So that is also one of the cause of fetal death. So hypertension, eclampsia, cigarette smoke and torch infection, we need to get that history from the mother. And then the examination, so of the fetus, examination, anthropometric examination, complete examination of the fetus that we need to do after birth of the baby. And internal, we have to send that for autopsy, and placental examination, macroscopic and microscopic, that is very important. So when we do that autopsy, we need to send that blood biological fluids for toxicology and then virology and microbiological examination, because, and also the tissue for histopathological examination, we need to send it. Next slide, sir. So in placenta, so we've been discussing so much since morning. So placental examination is very important part. Many, most often that will be missed examination by most of us, and we should not be doing that. The weight of the placenta is very important, the membrane insertion and the umbilical cord length, and also the wrapping pattern, and also the anomalies of the placenta, like placental infarction, placental insufficiency, are there any thrombosis, all that is going to give a lot of information to us. And also abnormalities of the amniotic fluid, oligohydramnias, polyhydramnias, and that we need to send it for the tissue, we have to send it for karyotyping, chromosomal microarray, and whole exome sequencing. And the baby's neurosonogram and fetal brain MRI we need to do. So this is, whatever I put it on the right side, the table, is the investigations that we have to send whenever you have intrauterine fetal death. Next slide, sir. So this is coming to the next part of that. So mothers, so after the death of the fetus, mothers, they feel tremendous guilt upon suffering the intrauterine fetal death. So these mothers, they are at risk of having the psychological risk for the subsequent pregnancy. So what is well known that if we give that support, adequate support by us, by doctors, nurses, that is healthcare support, that is going to lower the depression, anxiety to the mother, and more so, she needs support from the parents, I mean the family members. And it is very important that the support of the parents is very important too, and we need to being a doctor, what is our main role? Main goal is to support them and through the grieving process and identify whether this grief is going to become pathological. When do we say that grief is going to become pathological? Means that she is going to suffer that anxiety, depression for more than 6 months, or it is going to affect the day-to-day activities. Then we say it is pathological, and we need to identify that soon. And when mother feels that there is, she has some, feeling. So we need to acknowledge mother's feeling that it is genuine because she has loss of, the fetus, and reassure the mother that, whatever, we could not do more than that to have this. So maybe we'll discuss about the prevention little later, but what we want to assure her is whatever we need to do, we have done that. Okay, and also we need to, what mothers feel is doctors telling them, in a simple language and acknowledging their feeling that it is, genuine reason, and supporting them and explain in the simple language and listen that we need to, being doctors and healthcare workers, we need to listen to whatever mother says. That is what mothers feel, and accept their distress. Next slide, sir. And then after the baby is born, we know that fetal death, it was diagnosed before, after the fetus is expelled. So we need to wrap the baby and show the baby to the mother and her immediate family members or to the parents, and allow her to hold as long as she wants to hold the baby. And it's important that we need to handle the baby with respect. Okay, so and also that is first thing. And then examination, I told already, weigh the baby, and allow the parents to take photographs of the baby if they need, and footprints, etc., because that is important for their memory collection. And also so it is and we need to help the family that they can hold the baby as long as possible, they can keep the baby as long as possible, then we can shift the baby to the mortuary. And also what we need to tell them is the counseling that has to be in a place, it is away from the resuscitation area. And the counseling has to happen with the nurse, with the obstetrician and neonatologist. This is very important to have a combined counseling to the parents. And also we need to tell about the autopsy, that I'll come to that in the last slide. And also we need to tell about the subsequent pregnancies. So when we should start and the antepartum fetal surveillance, at what gestation we need to do, what is the importance of doing serial ultrasound. It starts at 28 weeks to assess the growth of the baby. And also the most experts say that at 39 weeks, the next pregnancy, that is the time for for the medical termination at 39 weeks. Go to the next slide, sir. Okay, what are the important things that we need to consider when we are counseling them? Please. First of all, we need to know in detail about the history of the mother and the fetus information, ultrasound and examination, and then prepare yourself to meet the family. So gather all the information, risk factors, delivery details, examination, everything what is needed, and then you speak to the family. As I told you, it is a combined counseling. And it should not be there on the place where she delivers, maybe a little away from them, the delivery area, and in the right place. That is important. Right time, allow them to express whatever they feel, the emotional reaction. So and we need to handle them and respond. We need to tell directly. We need to what is the cause of death, and directly, but compassionately, and we should be have patience and smoothly. And acknowledge their feelings, that is very important. And we need to offer, after that, what else they can do for the baby. They want to hold the baby. This after any religious process, any, Catholics, they may have the religious process. We need to allow them to do that, complete it there. And more than that for us, What is important is the documentation. The documentation of the conversation, most of the time it is done in the video based, recording will be there. And we need to document that what we discussed, what they responded, and the family response. That is very, very important for us. And also the whatever is the legal and hospital requirement is there, for example, death certificate and autopsy, this test need to be done, that we need to tell the parents. So this is what I just wanted to say. Okay, so
and added to that very because it's really because here where it is very easy to intubate or ventilate or anything, but it is the scenario where you are facing this scenario. The first time if you are facing, you'll get the tremors. That's why the madam has been selected for this thing, because the madam as an expert, we asked how to face this situation. And here something like key phrases that we did everything possible to help the baby. And second thing is your baby heart never started beating again because of the full efforts. All the efforts we will explain. And then these efforts, we are unable to get back the baby. And I'm truly sorry. I know that it is shock, especially after the celebrations yesterday. And it's not your fault. They should never be under the guilty. And as madam said, there should be never like a medical journal. Unwell, we no need to tell like the baby is unwell. The baby is unwell means there is a hope for them again. So don't use those medical jargons or anything like unwell or anything. Straight away come to the point, the baby didn't beat heart rate. Okay, very well, thank you madam, because this is where the real expertise happens, because you are the right person to explain these things, because the first person who is facing this thing will be having the tremors. Thank you ma'am. Someone who want to add, you can add it up. Yes, yes sir, cultural and these things we can.
Junior people most likely the postgraduates who are there, if they go and declare it casually, they may start shouting, yelling at you. Even they may start physically try to assault you. That time what happens is it may ignite their emotions much more. So and that's how the reactions come, and that's the reason why some senior person should be available there. Even if they shout at you, you should keep quiet. So let the emotional reaction pass away. After that, slowly you explain to them, and nothing, best we have done, and we could not save. That is the reason why that phrase, I liked it very much, madam.
You are very good point, sir. So it's important that we should not allow the junior most people or the postgraduates or the interns to go and declare. So what you said is very relevant, that even if they're angry and even with their emotional problem, that they want to express it. They may fight also, they may scold you, whatever, but I think we need to take that calmly, because we need to understand their emotional problems at that point. Thank you, sir. Very,
I
very
just
good.
want to add one more thing. In most of the centers, when this resuscitation is going to happen, the parents are with the baby at the time of delivery. So usually the father is the one who is next to the baby. The father would know, exactly what is happening. It is in front of his eyes how the baby has come out. When we do the resuscitation, generally we do for 20 minutes to 30 minutes. The recommendation is 20 minutes before we declare. You have ample time to just brief him. If you have another person who is a consultant, probably go through the process, what's been happening for the baby at the time of resuscitation. So that gives a kind of a preparation, that he knows that what all has been done. And you can again, debrief him about what has all been done to the child, so that he will have understanding. He has seen the baby, what we have tried to do. And also at the same time, he knows that, okay, everything is being given to their child, a benefit of survival. Okay. So if you have two people, that's great. If not, you will be probably stuck with one person. You probably will be resuscitating.
Thank you, sir.
Put some phrases which should not be told. I think you had put it, somewhere?
Somewhere, because again, reaching
no, okay. No, what he had put that I really liked was, okay, better try next time. So those things and all, we should avoid it. So that's what you should be careful when they are addressing the parents.
Very, very delicate issue, ma'am. Because see, when we are sailing the ship, a big ship will be there. But while we are sailing, we will take very, very, very carefully. We have to sail it up. This news should be like that. This is not such a simple news that the baby is lost. Okay, so it's like just sailing a big ship into the ocean. We take very cautious, otherwise it will topple. Once it's toppled, everything returns to us. Unnecessarily troublesome.
To my daughter's friend who was in Texas 3 years back.
Okay.
Same baby shower. The parents had gone, in-laws have gone from here And 15 days back, it had happened. Her close friend, she was also pregnant, and she was also pregnant, you know. And my daughter went into post-traumatic like depression for her friend. And that girl, the well child, I mean, there were no risk factors at all, like diabetes, hypertension. In Texas, Houston, that's a big center. It can happen in India.
Anywhere it can happen.
Yeah,
because
anywhere it
this
can
is
happen.
exactly all these seminars started in this
And it was
ma'am.
38, 39. You know jolly well that no cesareans there. They will wait for the normal. So this happened, and 2 days prior she had gone, everything was good, but I don't know, IUDs her, and she went into post-traumatic depression like anything. Now she got a baby again. So you said baby shower, you're saying, no? This is real scenario which has happened. Yeah.
Thank you, ma'am. Thank you very much, ma'am.
Yeah.
This is scenario which is a traumatic to everyone there.
Yes.
And this is where actually the group will be playing. Where
And
the
they had got
fetal deaths
usually
are
in
happening.
US, they get everything to the child, no? Before. That's the norm, not like kusutak munche kulavi, like that doesn't happen here. But there, the cradle, the dresses, everybody pin them up like that, you know. So it was really traumatic for her.
Thank you, ma'am. Because treating is very easy, but this counseling is something unforgettable memory for everyone, even for the doctor, because see, you have remembered for since ages. And here is the discussion from the next one. We will be going into the concept of IUD and one things. And actually, Dr. Jayanti ma'am, how to interpret and understand the pathophysiology leading to the intrauterine fetal death? Was this preventable based on the previous Dopplers and fetal surveillance? This is what the exact question that is then. Means we are just trying to understand what are all the changes that has happened and that led to the intrauterine fetal death. One means what all that is happening in the chronic hypoxia. Jayanti ma'am is not there, it seems. Then I will start. I will start up now. As I said, okay, since morning we will be for every case, everything we are saying the same thing. What is the adaptation? For the first case, GDM low, the adaptation has happened. And what is the competition that has happened, and then what is the chaos that is expected? Here also the same thing. Every case, every scenario, acute hypoxia, chronic hypoxia, we are discussing the first thing as what is the adaptation process that has happened, because for the survival, adaptation is the first thing that has to happen. So what is the adaptation complete? This seminar will be what is the adaptation that is happening in the intrauterine baby with the chronic hypoxia. So for, this is the repeated slides we are showing because there is an importance in this thing. This we have made a journey, a single baby journey. Okay, the intrauterine fetal death, neonatal death. As I told, there will be some reversal or something, and then we have tried resuscitation. Obviously, the baby with very bad pH will be entering into these things, and the pH is 6.74. I am just impressing at what pH and what is the chronic hypoxia that is leading to the death. Neonate, who stayed for few days in the NICU, and neonate 7.32 who didn't stay in the NICU. Maybe we for only observation the baby was there and the baby got it. Because all these babies are of single age group. Maybe in and around 32, 33 weeks. See, I am taking a journey. If that is in delivered there, here, here, here. So the hypoxia which is stage at that stage, the baby pH is 7.32, or this stage 7.1 and this stage. So we are taking a journey of chronic hypoxia. We are this. See why again the same thing. What is stress? Followed by distress, followed by death. See what is the extended form of distress is nothing but, that's why we take fetal distress. And the fetal distress is nothing but extended form of distress. And then collapse. Again, I have just compared this with another form. Here there is some stress. And there is a distress. And it has collapsed. And again death has happened. So obviously I am showing in this way, slow, gradual increasing the acidosis, the death is approaching. Just comparison sake. And in morning we have explained about the mean arterial blood pressure is something about 1/3 systole plus 2/3 of the diastole. And now in the during the when the baby is unable to maintain this mean arterial blood pressure, what is happening? And how we are getting through the Dopplers. Okay, the Doppler flow showing what is this diastole, what is that absent, lost, what is reversal, and these things will be explained. Because once we are discussing mean arterial blood pressure is 2/3 of the 2/3 is diastolic blood pressure. When the diastolic blood pressure is not there, the systems are submitted with only systolic. Okay. And so the mean arterial blood pressure is coming down. When the mean arterial blood pressure is coming down, obviously the kidneys are not perfused and there is an oligohydramnios. So this is how the things are happening. So these things, when there is only systole and diastole, how this diastole is getting compromised, we are saying. These are all the things that is there. See, at this point of the time, very good diastole. When there is an absent diastole, the end organs are being perfused only in the systole. When there is a reversal of the diastole, this is when there is a reversal of the diastole, obviously, what is this showing? The umbilical arteries should happily take away the deoxygenated blood to the placenta. When there is a reversal is happening, the deoxygenated blood is re-entering into the system. That is what? The reversal defines reflow of the deoxygenated blood from the placenta into the baby. Where the deoxygenated blood from the baby has to enter into the placenta, here that is re-entering. That is called reversal. Reversal is happening. So obviously the pooling of the diastolic blood, pooling of the blood is happening, anaerobic blood is happening. So obviously when there is an blood continuously accumulating, the hypoxic blood is accumulating, though the baby is landing rapidly in the acidosis. So accumulation of the deoxygenated blood leads to acidosis. So here to here, slowly acidosis is building up. So after this reversal, we are checking about the severity of acidosis. So acidosis is building. Here there is an absent diastole. So obviously the kidneys and everything are perfused in systole. And here there is a reversal of the diastole happening, that there is a deoxygenated blood is entering, but we want to know the cardiac status. That is what we are discussing. So we came to know that there is a reversal and there is a pooling and the acidosis is building up. But what amount of the acidosis is there? Acidosis to the extent that the cardiac compromise is happening or not, we will be assessing. So there comes the ductus venosus blood flow. So ductus venosus blood flow, if there is some A wave, see this is where, if there is an A wave here, means there is a reversal. There is an deoxygenated blood is getting accumulated and acidosis started. Acidosis started, but to the extent that the cardiac is not under the compromise, there is an A wave. So heart is able to beat. So when the acidosis is slowly building up, deoxygenated blood is coming and pulling up, and the acidosis is getting worsening, slowly this heart is unable to contract. When the heart is unable to contract, obviously the ductus venosus A wave is slowly getting decreased. When there is completely pulling up of the acidosis, automatically this heart is under the failure, this blood will be going and coming back. Means this is a flaccid now. Automatically when it is coming down, define this baby died. So with the journey of these things, that's what this is a wave and everything. See, and there is a pulling up of the acidosis. We are trying to understand what is the cardiac status. This cardiac status, if you can see, these two babies only. Here the cardiac status is too good. These two babies' cardiac status is good because there is a good wave. Heart is able to contract. We are able to see in the ductus Doppler very good, very good wave. And there is a absent diastolic blood flow here, not a reversal. Here there is a diastolic blood flow has been reversed. Accumulation of the diastolic blood flow, the deoxygenated blood is pulled up, and there is a acidosis to the extent that the baby has landed up to 6.9 I think. Here to the extent that the complete loss of the heart contractile, in utero fetal death happened. This is a single journey of a baby. If you can concentrate here where there is completely, or here, how to understand these things, and then we are taking up a journey, because these are 4 different babies actually, in which we have treated. See, again I have said, what amount of the stress will lead to this? Suppose a absent is there, when it converts into reversal, no one knows. When this distress will lead into collapse also, no one knows. That's what. That's where our guidelines comes. This BPP and all will give only up to 24 hours. Now we are going to know from the Junai sir how we have to monitor these babies. This baby died. Where we should have intervened. What is the status? How can understand these things? There is a deoxygenated blood getting accumulated here, and we have certain things. And certain times we may be unknowingly, we may be discharging the baby, sending the baby, saying that BPP may be here somewhere normal, and we send. But we don't know when to call back. When to call back, we don't know. There is an absent and reversal, absent diastolic blood, when to call back. When that have reversed. When that have reversed. Reverse may be done next hour itself. And there is a pooling of the deoxygenated blood might be that next hour itself. So this is how, when there is a reversal, when you are understanding that there is an acidosis building, and acidosis is the extent to the cardiac compromise will be given by the doctors. So accumulate everything. Added to this, you take the CTG. Will give abundant information. Take each and everything. This is first thing. Sir, doctor, Rajanish sir. Sir, you can tell about this baby. When the baby got delivered with the pH of 6.9 somewhere, the third baby, what I am saying is this baby has delivered. Now you are going to resuscitate. What are all the things that we can resuscitate, or what is the status of the compromised thing that here is there we can tell us?
Yeah, this baby indeed after surviving may undergo a lot of hematological and biochemical as well as hemodynamic changes because of the chronic hypoxia. As the mammalian reflex, diving reflex is acting throughout the intrauterine life, just a few words about the mammalian diving reflex. If we go, this particular diving reflex came into existence when the vertebrates moved from the sea to the land around 400 million years ago. If we see the evolutionary biology, like they evolved from sea to the land animals, like you can say from Matsyavatara to Kurmavatara, if you can imagine. So this particular to escape the predators or to find more food, they evolved. So once again there is a need for them to go back into the sea to get the food. So when they go into the sea, this particular mammalian reflex, what it does is preferentially tries to maintain the cerebral, coronary as well as the adrenal circulation, even at the cost of decreasing the splanchnic circulation, skin circulation, as well as to some extent to the skeletal muscles also. So this particular reflex is intact even today in the humans. When the baby is exposed to a chronic hypoxia or undernourishment or any adverse intrauterine environment, because of by the virtue of this reflex, what happens? The same, the principle is to maintain the cerebral perfusion. So there is a shunting of the blood from this splanchnic circulation. So this GI system, the gut actually suffers the hypoxia. So in the postnatal period, we can expect a certain amount of gut problems. And also the cardiovascular system, like there is a suboptimal kind of cardiovascular performance in such children. And if we see the long-term aspects of this particular adaptation, like as you have told, like in a Pune maternal study, it's a landmark study which has amply demonstrated this developmental origins of health and disease, long-term changes. Because of this changes in the abdominal circulation, and also they have studied that the intra-abdominal fat is relatively maintained. Even the organ systems like liver, spleen, as well as the pancreas, the size of the tissue is less, but relatively the intra-abdominal fat is preserved. And also there is a kind of insulin resistance which gets programmed during the fetal time itself. The reason for this particular insulin resistance is even despite the lower insulin levels in the fetally growth restricted fetus, the skeletal muscles tries to not utilize the oxygen. There is some signaling pathways which gets altered and it will not utilize the oxygen, so that the cerebral tissues can get the more this one. This particular programming, unfortunately what happens, this continued even in the childhood and later stages in the life, which sets the stage for later cardiometabolic risks.
Yes, sir. Thank you, sir. Thank you very much, sir. In detail explain this brain sparing effect. Whenever you see the word of saying that there is something like a brain sparing effect, it has been written. This is what Dhar is trying to explain. This is a mammalian reflex, where exactly the arisal from the ocean and then they gone back into the thing. That's a mammalian as birth. We got that mammalian reflex where we came from the water. So when the baby, again they are going into the water, they used to preserve some energies and maintain that thing for the hunting. So when you hear this brain sparing effect, when all the organs are being supplied with the systole, the mean arterial blood pressure to maintain systole and diastole, once we hear that there is a decreased diastolic blood pressure or decreased absent diastolic blood flow, suppose what they mention is, there is the real meaning of that thing is brain sparing effect. When all the organs are being mean arterial blood pressure is 1/3 of systole plus 2/3 of diastole. Now the all other organs, diastolic blood flow came down. So mean arterial blood pressure came down. But the brain, when in the compromise of all other organs absent or diastolic blood flow, this started to increase their diastolic blood flow. Means in the brain, if you are seeing when all the other organs are compromised in diastole, The brain is increasing its diastolic blood flow. Why? Because when there is a hypoxia is happening or increasing the PCO2, automatically there will be dilatation. Automatically there will be dilatation. So there comes a diastole. So what is happening first? When all other organs are utilizing predominantly diastolic blood flow, the brain is utilizing in another way. See, this is actually the brain. The brain waves are different. You see the medial cerebral artery flow compared to other blood flows. Other blood flows will be different, having a diastole. But why the brain is having this type of blood flow? The medial cerebral blood flow is completely different from other blood flows. If you can see all the ductus or winter, you can see the umbilical Dopplers. Umbilical Dopplers will be having systole, good amount of diastole. Good amount of diastole. But here you see, there is a peak wave. So how this got adapted? Why this brain is utilizing in these waveforms? Followed by that, when there is a brain sparing effect, actually the diastolic blood flow is increasing. Why this is utilizing systolic blood flow? Anyone can add it. Why this waveform is there in the medial cerebral like this, and all other waveforms are different?
So if we have a high resistance flow in the brain, say for example middle cerebral artery, that gives the brain a chance to actually increase its diastolic flow when there is a compromise. If there is an already compromised state wherein there is a high diastolic flow, say low resistance, and if you are going for a deep dive, there is no further chance for the body to adapt and increase the diastolic flow further. So that's how the body has probably adapted to have a high resistance flow within the brain. That's what I can think of.
Any other explanation do you have? I accept this, sir, but any other explanations do you have? Any other persons who can explain why this waveform is like this? Because all other waveforms are different, and why this waveform is different? Say, let's go into the deeper issues. See, what is this? You can see these things. What is the saturations of all these things? You can see in the saturations in the ductus is around 7. Here it will be somewhere around 75 to 80. Highest. The descending is around 55. What the liver has been, it is a bypassing most of the 30% of the blood flow to the liver has been bypassed into the ductus venous. Now, the most vital and important organ is the brain. This brain has made in the physiologically, our body has made in such a way in the in utero, why the brain is going very fastly. Rather than other organs, if you see, the brain will be growing very fastly. Why? Why is because the brain is utilizing the highest oxygen blood. To provide the highest oxygen blood, this body has made in such a way, this ductus venosus blood flow 80% is coming, and directly the brain is utilizing the systole completely. This is how our body has been made up. This is how the fetus has been made up. So the systole has a rich amount of the blood of 80-85% saturation. This has to be supplied to the predominantly the head, because the head is the most vital organ that has to grow in utero. So this is pumping directly. Systolic blood flow. Now when the all other organs are under the suffering, lost their diastolic blood flow, because this is not receiving adequate amount of the blood flow brain, this started to pull the diastolic blood flow. So there is an increasing diastolic blood flow. So when you are seeing the word of a brain sparing effect, this is a master switch of the life has been activated. This is master switch of the life, because this might having some battery. Some battery may be power off some other time if there is no backup. Here also the master switch of life has been activated. This brain is utilizing that thing. That means there is something going wrong. Sir has explained very well about the dual terrorism, because a 1 kg or 1.2 kg baby, like other cages, if you this is a 3.5 kgs baby, grown into 70 or 80 kgs. This baby who is born with 1.2 kg baby, obviously landing in the diabetes. That is why there is a diabetic surge in India. This was explained by sir excellently about the dual teratogen. That is what the dual teratogen. This is excellent study in India, Pune maternal study. 3 generations of the mothers has been observed.
From 93 to 2008, it's a very
93
long
to
term,
2008. This is nearly 3 generations of the mothers. But the baby has been observed.
From pre-pregnancy stages, they have been studied. Some 2,500 mothers have been enrolled, and some 760 odd mothers followed up even after delivery till 6-7 years.
One of the beautiful studies, sir. You can go through. Sir, due to the lack of the time, we are unable to go into all the depths of these things. And then, sir, followed by that, Dr. Prakash, sir. You can add your notes, sir.
Yeah, it's there in the slides.
Sir. See, we observed almost all the things like cardiac compromise. Now the sir will be explaining that what is exactly the cardiac, because we have trying to resuscitate in utero there in the delivery room, ventilation, pressing, these things, the things, and that what exactly is the cardiopulmonary, because the last stage of the death is the cardiopulmonary. Everything, every case we will be writing cardiopulmonary, cause of the death is what is exactly the cardiopulmonary arrest?
So, if you definitely face this scenario in your practice, and what exactly is important is how you initially kind of get a full history about what you're attending to. So the preparedness is the most important thing. So get a proper history, whether it is a normal delivery or it is a high-risk delivery. Make sure that the antenatal history is taken properly. You have adequate team, the nursing staff, and probably another person to attend the delivery, especially when it is a high-risk delivery. So next slide, please. If you look at this chart, it's basically the same explanation what the other speakers have spoken earlier. So when we do pediatric training, we are told by our professors that child is not an adult. And when you start doing neonatal training, then you say, okay, when you learn yourself, a neonate is not a child. Then when you go extensively into aggressive neonatology training, like intensive, then we probably say that, okay, a neonate is not a extreme preterm baby. So what it basically means that at different age groups, the physiology changes, the cardiopulmonary interventions are different, and unfortunately in neonatology we don't have much of data to support each management part of it. But whatever has been extrapolated or with the animal study is what the NRP guidelines say. And if you see that we have 3 stages of, this is on the extreme left of yours is the fetal period, and then the baby is born, and then subsequently. So when you do training, you probably jump around and say that, okay, the baby is desaturating, we need to increase the oxygen, we probably have to ventilate this baby, or probably before ventilating, we probably have to give a bag and mask ventilation. So you see that the child definitely takes at least 5 to 10 minutes to have good oxygen saturations. So there is a logarithm. We have different time points for different gestation, less than 32 weeks and more than 32 weeks, and especially to look at what the saturation you have to target. So as soon as the baby is born, you probably don't get 85 or 90 saturation. So it starts with somewhere around 80, then gradually. So term babies, we know that we don't start free flow oxygen. We resuscitate with 21% and wait for 5 to 10 minutes. And if the baby has a good heart rate, you probably know that this baby is breathing well, and that is an indicator. So if you see the baby's heart rate is quite good, you know that the baby is breathing well. Can you go to the next slide, please? So this is more of an animal study, which has been extrapolated to neonates. We generally don't see all these phases. What we see is at the time of the baby is born, who is asphyxiated, you see initially a change in the heart rate. So there's increased heart rate, the blood pressure goes up. And if the baby in utero probably will be breathing very rapidly, so that's what all the CTG is all about. And then as soon as the baby is born, you will land up in a situation where you have a primary apnea. So that is the time where you need to intervene. And when you intervene at that stage, it depends on what is the heart rate, what is the color, what is the tone, and other parameters. And you probably have to start positive pressure ventilation at that stage when there is irregular breathing, and then go sequentially. What is interesting is, as the irregular respiration happens, sometimes you land up with secondary apnea. That's the stage where the heart rate falls less than 60. Probably baby is not breathing. That's the time where you have to probably think of intubating the child. But the subsequent effect of all this, primary apnea followed by secondary apnea in utero and subsequently, is when do we establish the spontaneous circulation, recirculation of the cardiac output. So whatever the secondary effect is the one which will determine the long-term mortality and morbidity of this child. So can you go to the next slide, please? So the definition is what is being mentioned here. So it's basically a sudden cessation of effective cardiac mechanical activity and a spontaneous breathing leading to absence of systemic circulation and oxygen delivery to the tissue. So the most important crux here is the oxygen delivery to the tissue. So this, can you go to the next slide? So in most of the babies who are born with birth asphyxia, if you kind of stimulate them, dry them up, and give them positive pressure ventilation, if the ventilation is quite good, then you would see the heart rate improving. So if the heart rate is not improving, you probably have to think that, okay, you're not doing proper respiratory support for these babies. So the primary respiratory failure is the first event, followed by the cardiac arrest, and subsequently the cardiac arrest is secondary to all this electrical and mechanical function of the heart. Next slide, please. So the net effect of the whole sequence is the immediate effect, the oxygen not delivering to the tissues, brain hypoxia, loss of consciousness, there's no perfusion, there's ATP, the energy store of the baby is depleted, cellular hypoxia, energy failure, anaerobic metabolism, lactic acidosis building up, and the sodium potassium pump failure leading to cellular swelling. So this happens to all the organs, and the most important organ, what we are talking right now, is more of the heart as well as the brain, which needs to be supported. So eventually these babies succumb to death because of some of these arrhythmias or myocardial depression. Next slide, please. So this is organ specific, which I told you. So the brain, the heart, the lungs, kidney, and liver. So you land up in a child, in the NICU in case if the baby is viable at the time of birth with multi-organ dysfunction. So if you know that if your child has a multi-organ dysfunction, has higher mortality and morbidity, and of course we know that again it is extrapolated from the pediatric study. If there is more than 3 organ involvement, then you have almost 70 to 80% mortality. So obviously the reperfusion injury part of it, as soon as the spontaneous circulation established, we know that when the recirculation happens, again it kind of get into a cascade of oxygen free radical, inflammatory mediators, and mitochondrial dysfunction. And that's why you see some of these babies, okay, they get stabilized for some hours, and then you say, okay, this probably is getting better, the acidosis is getting better, but in the next 12 to 24 hours you see again a deterioration happening. So this is all the secondary effect of the reperfusion injury. And in total, this is what cardiac output is most important to prevent the tissue hypoxia, cellular failure, and organ dysfunction. And always keep in your mind that these babies will have secondary injury as reperfusion injury.
Excellent, sir. Thank you very much. Because every time we write the death is because of the cardiopulmonary arrest, but what exactly is the cardiopulmonary arrest is the sir that has explained. It's that is the way the beauty the senior persons can explain to us. And this is what that is cardiopulmonary arrest. This is what that happens when the baby is in severe failure, and then even if the resuscitation has happened, the baby will die. That's fair. Sir, Dr. Junaid, sir, this floor is yours, because right now we want to know. Once you give some of the criteria or what reports, at the end what we want to know as obstetrician and the NICU person, sir, is the baby safe in utero for hours, days, or weeks?
Absolutely.
How we can come to know?
Absolutely, very pertinent question. As we come to the last topic of this panel, I have only 2 slides, but I will take some time and I'll be a little slow to show what exactly is to be done when we have Doppler abnormalities. So the practice is varied. There are different obstetricians practicing differently as to one particular Doppler finding. So if you have a Doppler finding, the 2 most important questions that arise are, when do I deliver? Should I deliver now, or should I follow up? And if I follow up, how frequently do I follow up? Is there any particular guideline or anything that will help me in like mathematics? So and so Doppler findings, you follow up at this time and deliver at this time. The answer to this is yes. We have something called as Gratico staging of fetal growth restriction based on Doppler findings. You see this slide. This slide is self-explanatory. This article actually came out in 2014. It has been largely practiced by most of the fetal medicine specialists across the globe. In fact, it is endorsed by the Fetal Medicine Foundation UK as well. So you see, we have an interesting case scenario at hand. So we have a lady who came at 31 weeks with Doppler findings. And then She came at 35 weeks with an IUD. So there was a gap of 1 month. And was that right is what we want to understand in this particular scenario. So before I go into this particular slide, I'll try to introduce some terminologies of Doppler. So we have so many Doppler parameters like RI, S by D, PI. What we need to understand is it's only the PI that is pertinent based on the guidelines. We need to take RI and S by D and all other parameters out of the window and just keep them aside, just concentrate on PI because the guideline takes into account only the PI of these particular arteries as we are speaking. And also, we need to be very objective in terms of our findings. If you say high resistance, low resistance, it doesn't mean anything because even an 80th centile of PI of some artery can be a high resistant, isn't it? So we need the cutoffs for centiles is less than 5 centile or more than 95 centile. That's what we take into account. So that ways Doppler findings is classified into 4 stages. So when we look at the stage 1, here it is denoted as severe smallness or mild placental insufficiency. So this is the stage 1. What case we had in hand at 31 weeks had these findings. It was in stage 1, in which the findings are umbilical artery PI more than 95th centile, which meant high resistance. Also MCA PI less than 5th centile, which meant low resistance. Of course, the CPR will be less than 5th centile based on the ratio, and also uterine artery PI, if it is more than 95th centile, is abnormal. Also, because it is an FGR, we also have to consider less than 3rd centile of the estimated fetal weight as stage 1 FGR. So we have these findings, and when we have these findings, what is the protocol that says monitoring is weekly? You need to follow up this patient with a stage 1 FGR after 1 week and see. If it is in the same stage, then repeat it after another week. So on and so forth, you can continue up to 37 weeks. That's what it says. GA or mode of delivery is at 37 weeks, and you can induce labor. You can use a normal delivery for stage 1. Whereas in stage 2, stage 3, and stage 4, they would not prefer normal delivery. We saw one picture in which a stage 4 case was being delivered vaginally. So that is not what is recommended. It is cesarean section from stage 2, stage 3, and stage 4. And there was one image which Sir showed in which it was just increased umbilical artery, reduced umbilical artery diastolic flow, and then which moved on to absent and then reversed, and then the ductus venosus. So these stages are exactly the same. In stage 1, you see umbilical artery PA is more than 95th centile. Stage 2, which is severe placental insufficiency, is actually absent end diastolic flow in the umbilical artery. These are short forms. We just have to understand this. And stage 3 onwards, there is suspicion of acidosis. So what a pediatrician wants is we need to give the baby at stage 1 and stage 2. We don't want to give the baby to the pediatricians when it is in stage 3 or stage 4, when there is actual acidosis setting in, or at least an initial stage of stage 3 that we need to hand it over. So when you look at stage 2, the follow-up is bi-weekly. When you look at absent end diastolic flow and you see the patient at say 30 weeks, our end target is 34 weeks delivery for a stage 2, but with a bi-weekly follow-up. Follow-up after 3 to 4 days, up to 34 weeks. If it deteriorates, then it goes into stage 3. And then we'll have to deliver maximum by 30 weeks. That's in the third column. So when it comes to stage 3, that is reverse end diastolic flow in the umbilical artery. And in such a case, we'll have to follow up every 1 or 2 days. How long? Till 30 weeks. Suppose we have a baby who's come at 31 weeks and in stage 3, what do? We don't have to wait till 34 weeks. So it is already crossed the stage. Stage 3, if it's crossed 30 weeks, deliver immediately. And similarly, when there is high suspicion of fetal acidosis, ductus venosus reversal, and all those things, 12 hours is just mentioned just to make things ready for the cesarean section, and you'll have to deliver maximum by 26 weeks. So that was the whole protocol. This is Gratago's staging protocol. This is readily available online, and it is followed by most of the fetal medicine specialists. I think all of us should follow it. It gives a clear mathematical picture how to follow up Doppler abnormalities. Coming to the second slide, one of the things that I have come across during my initial practice is we get requests saying BPP scan for a third trimester scan. BPP, problem with BPP is if you're not seeing any breathing movements of the fetus, you'll have to look for it for 30 minutes. I have never looked a fetus for 30 minutes. So you're always wrong. You just, if the Dopplers are normal, you tend to give BPP as 8/8. So that is actually taken out of the window. We don't use BPP now. It's never BPP. Just to explain you why is that, the same Doppler parameters, this is a chronology, left to right. How do these Doppler parameters change? You see the uterine artery becomes abnormal, then the CPR changes, and then the umbilical artery PI becomes abnormal, which reflects onto the MCA as the brain sparing effect, and then again moves on to absent and diastolic flow in the umbilical artery, and then the aortic isthmus PI raises, and then it increases from stage 2, stage 3, stage 3, and then comes to stage 4 where there is reversal in ductus venosus, reversal of A wave in ductus venosus. That's when we see that the BPP score is less than 4. So when we are actually seeing that the tone is less and there is no frequent breathing movements, we have already lost the baby. This baby cannot be revived. So BPP is out of the question. We need to get this baby out before we see abnormality in the BPP score. So that's when the Doppler chronology as well as the staging comes into effect. So this is what I just wanted to highlight. Just to give an overall picture, BPP, no, it's only Doppler, and Doppler has to be staged. One important caveat here is, which is also pertinent to our case, this staging is applicable only when there is no uncontrolled hypertension. When there is uncontrolled hypertension, it's an emergency. It can deteriorate from stage 1 to stage 4 directly. How long, we don't know. So the moment we see uncontrolled hypertension and Doppler parameters deranged, we need to monitor, admit the patient with a frequent NST, and probably give an option of delivery immediately, and mostly with cesarean section.
Thank you, sir. Thank you very much, sir. And one slide I have added to this, sir. This is a finding that we have noticed in one of the baby, a 29-weeker here.
Yeah.
There is an appearance of the early fetal appearance of the lower femoral one. And see the circumference. And these are the Dopplers.
Yeah.
You can see the Dopplers.
Yeah.
Dopplers, other umbilical artery, everything was being displayed.
This is
there.
MCA. MCA is good. Yeah. This is MCA. MCA is high resistance. It is more than.
Yes, sir.
Yeah. So
high resistance flow, and then there sometimes we notice that there is reversal even in the MCA.
Yeah, correct. That is of no consequence, because even when we press the head of the fetus and take this value, it's going to come like this. What you have to do is just repeat after 2 hours, and then it normalizes. So this is of no concern.
So early appearance of the fetal lower pole, lower end of the femur with the ossification center.
Yes.
And there is a biparent BPD is rising, and we are seeing that the middle cerebral artery flow is always reversed in this baby.
Yeah. Okay.
And then what we have went for, and then we searched about the literature. It is being shown as intracranial hemorrhage, growth restriction, and other things. There can be a persistent middle cerebral artery reversal flow. Others are normal. This baby had that.
Yeah.
3 babies we have shown these things, and 3 babies had an intracranial hemorrhage.
Okay.
And as a closing note, this case, particularly this case which we discussed, that exact case was if you can see, in this I have displayed all these things, but this case was formulated based upon this single slide, sir. I will show the slide. Because once the middle cerebral artery flow you can see these things, sir. You see this slide. This is directly from the Radiopedia.
Correct.
You can go through. See, once that's why I have mentioned in the question, at 31 weeks there is high resistance, followed by 34 weeks there is a low resistance. Again there is a high resistance flow at 34 weeks has been noticed, and the baby was diagnosed, and next day the baby was intrauterine fetal. If you can read the scenario, the scenario has been based on this thing. Actually, when there is when the middle cerebral artery from the low resistance to high resistance is from the high resistance to low resistance is been obtained, after that reappearance of the high resistance flow again is a sign of intracranial hypertension, because due to the PCO2 there is dilatation. That means when the intracranial pressure is rising, automatically again the vessels are getting compressed and this vessel is going into high resistance. This is a sign that there is an imminent death. This is why that directly I took this slide from the radiopedia. You can see this thing. Paradoxically, in such situations, such as severe cerebral edema, the flow can revert back to the high resistance pattern when the pathology has not yet resolved. This is a very poor prognostic sign. If we miss this baby is going to die imminently. This baby actually had a cerebral edema, and that was left. Sir, reason no.
So I would like to take this. I would like to beg slightly on your point. Definitely, cerebral edema. This paradoxically increased PI is definitely seen in MCA. But what happens is almost every patient has this finding. You see now. Every day it happens. You see that the MCA PI is less. It's less than 5th centile. You make the patient sit. See, after half an hour, it will increase. So that is always there. That is very common. But yes, this fact is also true that there can be paradoxical increase when there is cerebral edema. And cerebral edema will have other findings also. The ecotexture of the brain differs in cerebral edema. So there will be other co-factors which can contribute to cerebral edema, and that we can identify in utero. Yeah. Yes.
Slide I gone through.
Yeah, one more thing,
and that paradoxical reversal I just want to show in this thing that I framed the question in such a way that the baby
absolutely, sir. Absolutely true. One more thing. The same radiopedia shows 1.1 more than 1.1 less than 1.1. This is a very old article from radiopedia. Now it's changed to cerebroplacental ratio less than 5th centile is abnormal. So 1.1 is gone out of the picture. Sir,
you have to change because the BPP is normal and will be sending. That is where that we are seeing. That's where the fetal medicine people exactly should be involved. Because we don't know when to follow up unless we are being discharging. Exactly, the BPP won't work for the severe IUGR babies or severe IDM babies. That won't work. Same BPP profile, how can that work for all the babies? That's why there is a time that we need to change from the BPP to another profile. Now that's what the SAR has explained. Kindly take up this message.
Thanks.
Everyone.
Hello. Sir, I want to add one more thing. Hello. Sir, I want to add one more thing. Sometimes we find in our practice intense itching of the mother at around the 8th month and sudden loss of fetal movement and sudden death of the baby. There is no Doppler evaluation done. Many times we get like how we will evaluate.
Most of the times, I am not an expert in that thing, but I am saying there is a cholestasis has been found. And obviously there is something like a PFIC also will be representing in the same way. PFIC in the newborn, in the mother side there will be reflexes in this way. Mother will be having itching.
Alkaline phosphatase increased in the mother.
Babies will have some other liver problem also. They will be representing in this way, madam. PFIC is
how to
PFIC.
Evaluate in the neonatal period?
Madam, in the neonatal period, obviously we will be evaluating from the direct bilirubin, indirect bilirubin, everything will go through. And if there is a prolonged things, and then madam will be checking about the PFICs. PFIC is one genetic condition. They will be ruling to the genetic test.
So then we cannot go through the Doppler and the BPP. Sudden death will occur because of the only alkaline phosphatase raising.
That I will search, madam, because I am not an expert as I know. I will go through.
Even I have to see that. I haven't heard of it.
Unknown IUDs.
Yes, ma'am. No. These are all the many causes are there for IUDs, ma'am. That's why we are making these panels.
Okay, thank you.
I think so. Here, how many OBG people are there? At least 5 are there. 1, 2, 3, 4, 5, 6, 7, 8. Okay. See, you know why we have done this today program? Okay, fast. Begama, Harsha, no time. Fast. Okay, okay, second. Okay, Harsha, come up. Fast, make it fast. Okay, see, the reason is because I am from Lakkur. How many you people know Chikka Tirupati? Chikka Tirupati, at least local people, Chikka Tirupati. Okay, it's they are very remote places, Lakkur, where my brother, myself and everybody we have delivered there out. The reason is, it's a very, still now nothing is there in that. We have to go to Malur. Malur is also nothing is there. See, now we are having in the Bangalore luxury called Cloud9, Motherhood, something, XYZ and all. How many people we know that, like small things, middle cerebral artery, then previously it is now low, now it is started increasing, it will develop this thing. You know how many people will come to me? No, why I am telling is, see, Dr. Aparna is sending, sir, counseling kardo. I will tell, Are bhaiya, Baba Nirmal aajo. Are, yes sir, no. And baby will die, they are coming. Sir, sudden baby death, what is the problem? And after that baby die, they will come to us. Sir, you have counseled us. Sir, can I put a case? I told nothing. I am telling. Because why baby died? Nennevargu baby channagittu, why baby died today? No, it is, practicing is very difficult because I am also opened one hospital, even scanning. How many we people are having luxury to have a fetal radiologist, interventional radiologist? Come this side, brother. Yes, how many people we are having? No, I am telling, okay, take our Vaidehi only. No, I am just, you understood, no. That is the reason. We simply talk. I am telling, Jagdish, you are also practicing neonatology. There are, your gynecologist might send to you also counseling. Yes or no? If it dies, how many people? We are also losing the babies. And IUGR one baby, when it came only reversal of diastolic flow, and I have seen the other parameters, it was missing. I thought I'll tell them, go and get it outside. I cannot tell them because I don't have authority in my hospital to go and get it done outside. And somebody has delivered, you people only, baby died. And I told this baby will die. After 4th day, 5th day, baby developed IVH, baby developed NEC, baby died. Some babies, I told you, whatever we do, some babies will develop this. So that is the reason I am telling you, what is that baby? I don't know, you people knows. Nirmal, kaunsi baby?
39 weeks, reversal of flow was
reversal flow, not only reversal flow, there is other, so many other parameters, abnormality was there. They went 4 gynecologists. Aapka kaisi hoga? No, I am telling, see that you are not the problem. They have already shopped 4 gynecologists. 4, then they came to you last. For paisa only, nothing. They came because, what is it, government, some newborn baby. What is it? ABARK. That is there, that only they came here, nothing like, okay, that is the reason. I am telling you, even now I am afraid. See, how many we people can have, Arvind Shanai sir was telling me when we discussed, Dinkar, bada headache ide, aur band tale tintara, madam also, Praveen Shanai, one small Doppler study, they will do the Google, they will ask the other fetal medicine, then they will catch and they will give the money, the other fetal medicine will tell, interventional radiologist will give all these things, go and fight. And somewhere we will be in the mistake. Whatever you do somewhere, that class sir will going to take now. Okay, please, I know that everybody wants to leave now, jump if you leave. Abba, bit put up on a toilet go, please don't go. I'm telling you, see, I'm afraid now. Because see, you people are still, because father, mother is giving the money, you people are studying final year PGs. When you sit on the stage, then when you will do the mistake, that time they will put that how manelu support madalla. It kada husband kada you in taleno manel kutkolama saku. You understood, no? I think so. You understood. Anybody doesn't know Kannada, I'll translate in English. Okay, please. That is the reason I am telling you. Read, understand. That is the reason I started developing in How many you people have known neonatology? First fellowship is started in 2004. It has name is turned to Perinatology. Then some influential institution went and changed it to neonatology. You know that? In 2004, neonatology started in, I think so, sir only knows. In 2006, Vaidehi Hospital people have changed it from Rajiv Gandhi University. It is perinatology. It is not neonatology. Then some influential one people have changed it because they were not having gynecology. Namatra gynecology illa, namatra newborn jasti ide, perinatology madakagala, neonatology change maadu. 2007, because we took that time perinatology, this thing. That time only, I think so. No, apply chesindi. You understood, no? No, why I am telling is really, please, gynecologists, pediatricians, solpa talagogi, because those people will send, go and get the counseling. Okay, reversal flow, why I to see? How many you people know? All the ionic exchange or the CO2 exchange will take in diastolic time. If it comes down diastolic reversal, alage illa. Nothing is gone to the baby. Not only diastolic reversal flow in umbilical. Where about DV? Where about MCA? Yes or no? And beautifully slides, I think so, he has showed in the liver. I don't know whether he showed or not. Liver one and that beautiful. How many? I am asking how many gynecologists. Sorry, it's not your subject. And I asked one XYZ department, please can you teach tomorrow for my OBG doctors ultrasound? They told, sir, if we will teach, they will learn. They won't send us cases. They won't. There was, why? Sir, they will remove us from our organization. Bas. And I asked some gynecologist, can you teach? I'll not young month. Stop. And gynecologist. And how many you people are doing the scanning? I'm not commenting. Please learn. See, when 2007, when I started teaching here in capital, this thing, 2007, ultrasound, lung and all, hey, you never know hucha. You know, now he is an IAP, he was an IAP president. Hey, Sundir Marayan in A line or B line. He was IAP president. Okay, I am telling you. So that was the scenario. Scenario will change. Thank you very much. Now just I'll take 1 minute. Everybody relax. I'll give to the company person. Harsha, go to you. 30 seconds.
We are a medical device manufacturing company which is made in India. So we have our manufacturing plant in Bangalore, HSR layout. We just want to introduce our products to you so that we get the opportunity to serve as a medical device manufacturing company. We basically are a group of engineers who are graduating from VTU, NIT, IIT, Vellore Institute of Technology. Our CEO is also a graduate biomedical engineer who has worked on most of the intellectual property products where it is focusing on both maternal and newborn care division. So one of our major products are the CTG devices, complete range of wireless CTG devices at a very affordable price, which is manufactured in Bangalore plant itself. Recently in the month of January in Hyderabad, the Pedicon which happened, we have also introduced some 2 products in neonatal segment as well, which is non-invasive transcutaneous bilirubin meter. Of course, the product is already existing in the market, but not with any Indian players. It's mostly the players those come outside who are already in high brand and high value, which is not affordable for all our practicing pediatricians because the product not only comes with a higher value, but also comes with higher service and maintenance costs. So to bring something which is affordable, but at the same time giving you the best service possible by being manufactured in India and giving the benefit directly to the customer, we are here to present you both the products. We also have the products here handy, so anybody who's interested to have a look at the product or looking for it for a demonstration purpose or any kind of clinical trials in the hospitals, please do let us know and kindly give us the opportunity. We're looking forward for it. Thank you so much.
Okay, at the same time, okay, first. Show them like this.
Basically a wireless CTG device where we are the only manufacturers who are giving it combined with not just intrapartum but postpartum as well. So it has also during intrapartum the obstetrician gynec that OSI model where you have the PPH theorem which has been implemented here to make sure you have the proper OSI value calculation, which no other company is providing as of now. In this we also have included the maternal heart rate as well as the wireless BP apparatus, which is helping in keeping a complete record of the entire journey of labor from intrapartum to postpartum and also after discharge. Apart from that, we also have non-invasive bilirubin meter which comes with inbuilt nomogram facility. So that particular product again also comes with the additional feature of continuous not only monitoring but also record maintenance. So both the devices are manufactured in Bangalore only.
You people have seen the Dragger. Dragger is they are quoting around 3 lakhs something, I don't know. Okay, you bargain with this Okay, and because accuracy is 0.5 to 0.8 compared to that test. But when you see the blood test, it's almost giving 0.5 to 0.8. It's not so much. Okay, difference. You can bargain it is because very less. Not like they are concerned for our program or anything. Because in India, encourage the youngsters. Then anything else is there other than and SPO2?
Only central monitoring along with this. So if you just want to have a look, all the devices have each PF just 5 minutes. Take a look at the devices.
Tomorrow, whoever it is there, first we will show the survey. Okay, any gynecologist, we will be sharing your numbers to them. They will be calling you. In case if you are interested, you can talk with them. ಅದು ನಿಮ್ದು OBG. I don't know what is that. Okay. Tomorrow we will teach you all the who are interested to ultrasound drive. If you'll put the vacuum, you'll put the forceps, where the problem is, where the hemorrhage, why it will develop, everything we will teach you. Okay, next. Anything? Happy?
Thank you so very much.
Okay, now we are going to come for the last session, medico-legal aspects, and really it is interesting subject. I am going to learn from the great stalwarts and many people who are sitting here. Please, everybody, I don't want momentous. Sorry. Senior person.
Now for our final academic session of the day. Yes.
Hello, good evening. My name is Mohammed Saifa. I am from MAP Industry. Our company is based in Ahmedabad, and I am taking care of complete South India. We are manufacturing for autoclaves, ETOs, and all complete CSSD products. If anything is there, my cards are there in the basement, in the counter. Just you can collect and get back to me.
given CSST items and laundry items, and not only CSST, laundry, and even
the complete range of laundry and CSSD.
He will marine grade steel, he won't cheat. And big company and very nice people. Thank you, sir.
Yeah, thank you.
And one more thing, may I request Harsha Ninige, that CSST everybody knows, and even wireless CSST everybody knows. It is there since years. Anybody is having AI in this, set that like TRICOG. How many people are using TRICOG ECG? I think so everybody will use. Okay, just it needs a mobile, put the ECG, in 1 minute it will only give complete report. In 30 seconds it will give the report. In 1 minute they will call you and they will tell you, please put this medicine inside their mouth. Put IV line and give this injection. Like that. You understood? Chandrakala artha aitala. One 2 ನಿಮಿಷ ಇರು. 2 ನಿಮಿಷ. ಆಮೇಲೆ ಅಬ್ಬಾ ಹುಡುಗಿರು ಮಾತಾಡ್ತಾರೆ. 1 ನಿಮಿಷ ಇರು. Okay, number 1 is finished. Number 2, like that, Harsha and your young people, please, because CTG machine I do have, BPL company and other companies, I am also. But in that, see, I don't know how to read. Example, complex CTGs, I don't know, because acceptance is better instead of simply gottu. Okay, CTG, I don't know. At least my sister might not know that. So something, at least whenever it is coming, something like, you paid 250 rupees when we drink coffee, 25 rupees coffee when we pay. That chatterbox is come Paytm, GTM. Like that, that machine, artificial AI, it is going for variable deceleration. It is going for, what is that, late deceleration. It is going for something. That AI you should include and print out, it should come. It is there with you? In this machine it is there? Okay, naale torsde iru. Madam, what is it, Aparna, whether you have in like this AI? Okay, so see whether it is there or not first. Kaadu unda AI report vastunda. If it comes, see sisters, it will be useful for my sisters. Report. Okay, thank you very much. Thank you, Bhaiya. Okay. Next sessions, over to Madam.
Coming to our final session for the day, we have the following dilemmas.
Dilemma 1, use of magnesium sulfate in preterm birth.
We have the following doctors presenting the same. Dr. Aparna Nair, Professor and HOD at our very own Vaidehi Institute of Medical Sciences. Dr. Parimala Thirumalch, Consultant Neonatologist at Aster CMI Hospital, Bangalore.
Dilemma 2, extreme prematurity and counseling in the gray zone.
For this, we have the doctors, Dr. Deepika, Professor and Head of Department at Bowring Hospital, and Dr. Jagdish S., Professor and Consultant Neonatologist at MVJ Medical College.
Dilemma 3, medico-legal challenges in perinatal care.
And lastly, for this, we have Dr. Lakshmi Kanta Ji, Professor and Head of Department at MMC Mysore, Dr. Venkatesh Murthy, Associate Professor and Neonatologist at Rajrajeshwari Medical College, Bangalore. Last but not least, we also have Dr. Jagdish, our Vice Principal and Professor of Forensic Medicine, WIMS NRC.
The final remarks and summary are by the super moderator for this session, Dr. Mamta, Professor and Head of Department, JSS Medical College, Mysore, and with Dr. Prashant Gowda, Head of Department and Lead Consultant, Sparsh Hospital, and Dr. S. Ramakrishnan, Consultant Neonatologist at SKS Hospital.
The stage is all of yours.
How many you people knows Dr. Prashant? No. How many you people? See, he is Neo Gurukul, myself and Dr. Prashant, we started. Okay, he is very nice person, very down to earth person. What is it? Ego? It is not there in his body. Okay, that is the reason Neo Gurukul is standing from 2000. I don't know whether it is 12 or 14 or something. It is then every year we are conducting every 2-3 months one without any lava ildange nam kayinda doddodu kuda. Now Nirmal, we are only spending, Nirmal knows, we are only spending for this conference money 1,500 rupees really good, you know that. Okay, we are doing it. One big round of applause for Dr. Prashant. Okay, thank you.
Shall we take over, madam? Because it's almost last session. But very, very essential session that is to be. In this session, we will be discussing about the dilemmas. Okay, what are the dilemmas? Where to start, what to start, and what followed by that there will be medico-legal issues. And the grey zones. And all the experts here, because after acquiring the knowledge, it is make sure that you should not go to jail. This is the most important thing. So we acquired knowledge, now the SARS will protect us. So, madam, the first panel. First dilemma, use of the magnesium sulfate in the preterm. When is the magnesium sulfate indicated for the neuroprotection in preterm delivery, and when should we avoid it? Avoid in the maternal and the fetal contraindications.
I'll complete my portion. As like you told, it's the last session. So magnesium sulfate came into play with MACPI regime. MACPI regime was MACPI trial. MACPI trial was done for preeclampsia to see if we give it prophylactically in severe eclampsia mothers, preeclamptic mothers, will it be safe for the mothers or not? As a sub-analysis of the study, they found out that those mothers who were given prophylactically magnesium sulfate, babies did better at 18 months with lesser neurological disability. So it came into the thought process that maybe it has some protective effect. Following which multiple studies have been done, large scale studies, more than I think 20,000 neonates have been observed. Premac trial, Magenta trial, so many trials have been done. They were all categorically proven there is significant reduction in neurological disability at the time of discharge, at 18 months and at 5 years. It is beneficial if it is given up to 32 weeks. But there was a study called Premac which told it can be taken up to 34 weeks. It is safe. There is no problem. The dosage used were 8 grams loading followed by 2 grams continuous dosage, 6 grams loading followed by 2 grams or 4 grams. In our center, Vaidehi, we are giving 4 grams loading dose followed by 1 gram hourly for 24 hours prior to delivery. We are following the protocol of giving up to 32 weeks.
And where it is contraindicated, ma'am?
It's given there. So anybody who has any muscular problems, myasthenia gravis, muscular dystrophy, myocardial compromise, it is contraindicated. But that is because it acts on the muscle. It acts on NDMA receptor. It causes muscle relaxation. So only thing we should be careful is PPH is a strong possibility if you are giving immediately. So probably you can titrate if you are taking up a section, or if your delivery is imminent, you can probably stop it for 2 hours prior to the delivery.
Then,
yeah, this is something which I learned after I listened to Shubhashekar's pre-conference this thing. I didn't know magnesium is just above calcium. I should have known. We also did chemistry sometime. But yeah, so that is why probably it has a similar biochemical profile as calcium. So how the neurological deficit occurs in extreme preterm babies is because of severe preterm, these glutamate channels get into the open up and they cause hypoxemic damage. This stabilizes magnesium. When it is given, magnesium gets absorbed very fast into the circulation. It is easy to close the placenta, and it stabilizes these receptors, blocks these receptors, and prevents the calcium-induced, free radical-induced damage to the fetal blood vessels, which are in and around the lateral ventricle.
Can I take over now for another 2 minutes? These things, like see, the discussion like this. See, when the magnesium sulfate, if you see the magnesium sulfate, we'll say that when there is a neuroprotection, we'll give the magnesium sulfate. And then for the cardiac, we'll be using. And then for the muscle relaxation, we'll be using. And then when uterus relaxation, we'll be using. And then there is a respiratory. In the respiratory wise, when there is a status asthmaticus, we'll be using. See, that has a varied action from the top to bottom. Everywhere we are saying the magnesium sulfate. How this got that effect? And there was a discussion happening. Why this got such a beautiful effect? Is it inherently this magnesium capability or some other things? This is where the calcium is nearly 1.5% of the body weight. And most common mineral that is there in the body. Whereas magnesium compounds of 0.05%. of the body. It plays a role in skeletal muscles. And while we are searching these things, we have asked for the most of the professors, and then we came to know this is exactly sitting in the periodic table in the second place, same place. And this is the only one that has a capability. You can see many literatures are there that what is the mechanism of action in this way. You can see that it can block the calcium. The only one that can control the calcium is this. So when because the calcium is something, and the calcium causes unpleasant things, because everywhere the calcium is there, the calcium can do many number of things. So someone should be there in the body to stop that thing, to control that thing. It is the thing. This is where the scenario came. So this is how the magnesium, so that is the reason where we should be contracting, and because wherever there is these things like myasthenia gravis, muscular dystrophy, myocardial cardiac conduction defects, there it should be contraindicated. So here the calcium is right now below the thing. So much body of calcium is doing many things. Someone should be there to control these things. So there is the magnesium. So predominantly the function of this is happening in such a way that magnesium, the magnesium can control the calcium entry. So there is a the unpleasant sensations or the damage that is being caused or apoptosis that is being induced by the calcium influx will be decreased. So here in the second, madam will be anyhow explaining about these things. But here if you key in the secondary failure, the most important thing is the calcium will be influxing. One, the sodium potassium ATP is, obviously madam you will be explaining next thing. But here, when there is a secondary phase is activated, where there is a sodium pump failure, there is a free flow of the calcium inside, and the calcium is causing the mitochondrial apoptosis. So this phenomenon, this can bring down. So this is like this. This person is so powerful. Equally this person also powerful. This person is like calcium. And someone controlling the calcium only at that point, till the calcium is being regulated or controlled only, there will be pleasantness. Otherwise, he is an unpleasant cell. The calcium is quite unpleasant. He can do a number of the things, so powerful, but very unpleasant things. See, he is so powerful that he can kill anyone. He is so powerful. Maybe this movie everyone has seen, that's why I quoted this thing. But that person is being regulated by this person. If you can see in the movie, completely in the movie, whenever this person is controlling that person, he is safe. The point of the time where he lost the control over him, he is going to get killed. That means this is an very unpleasant. Magnesium is the one. This is like magnesium. Magnesium can control the calcium. If you are unable to control, they lost control. Automatically the calcium influx happens. And then there will be very mitochondrial damage and there is a trigger for the apoptosis of the cells. Once the apoptosis happens, completely neuronal death and death happens. This just I have mentioned. Followed by this, madam, Dr. Parmala mentioned, ma'am, when there is, what are the neonatal effects? What are the neonatal effects of the antenatal magnesium sulfate, short-term impact in the adaptation, long-term neurodevelopmental outcomes, and monitoring and the management of the NICU? Ma'am, here we will be explaining these things. Your slides. Yes.
Good evening, everyone. And just to reassure you, I have only 4 slides. So have some patience with me, out of which 1 slide has been explained already by Dr. Prakash sir. So I don't think I would go into that detail, because he explained how hypoxia happens, what exactly happens during hypoxia. Next slide, sir. Yeah, this is just a picture of which areas of brain is actually affected during hypoxia. So that specifically, these are the areas which are affected. So each area, when particularly they are affected, long term, what complications can happen. So if it is predominantly a frontal area, then it would be a thought and cognition. So behavioral abnormality, that is what you are going to see. So if it is very close to the white matter, then cerebral palsy, that is what you're going to see. And watershed area can give a very wide range of kind of involvement, which means like, you can see from just dyskinesia to gross motor dysfunction to cerebral palsy, in which again it can be anything, dyskinetic, spastic, all types of cerebral palsy can happen. So it all depends on which area is affected. Okay, so ATP is all highlighted in very big capitals because ATP is our powerhouse, we all know that. And in hypoxia, what happens? ATP is depleted. So once ATP is depleted, what happens? Next slide, sir. Yeah, so when there is lack of ATP, so normally what happens, there is a pump called sodium potassium ATPase, and that needs ATP to function. So which pushes sodium in and potassium out. So this is what normally happens. If ATP is not there, what happens? Sodium is very high. So that causes excitability, and potassium is not being pumped out actually, so it cannot relax. So this causes excess excitability inside the cell. And on top of it, even there is NMDA receptors which get stimulated. And NMDA is dependent on the glutamate actually. So glutamate is, we all know, it's an excitatory neurotransmitter. So there is too much of excitation now happening in the brain. So if that much of excitation is happening and without any relaxation, the brain just dies. It fries basically. So you can't be always on the active mode, you have to switch off as well. So this is the pathophysiology. And the other thing you also see is once this excess ions get inside, you also see other things activated. One is your nitric oxide. So that is high now. So, and apart from nitric oxide, you also see cytokine release, so which causes inflammation. That also is going to affect the brain. So excess vasodilation happens, that also is actually going to affect the brain. And apart from this, cytokine injury and all this, direct cell death itself can happen because you have excess of ions inside. The cell itself kind of eats itself, called apoptosis. So that way, direct necrosis also can happen. So damage doesn't happen just because of little bit of less oxygen, no. It is a series of events post-hypoxia which actually fries the brain of the preterm baby or even a term baby actually. So all these events are happening. So initially excitability is high, so glutamate is high, and then the NO is involved. After that, the ATP is not there, so energy depletion is happening. And because mitochondria is a powerhouse, without ATP it cannot function. That destroys itself, self-destruction, apoptosis is happening. And on top of it, the calcium is more inside. So calcium, because sodium is not entering, the alternate one is calcium. So that starts entering. So because of calcium, there's a lot of contraction happening, and there is no relaxation. That also causes direct cell death. Apart from mediating, all the inflammatory mediators like interleukins, cytokines, everything, which is also going to kill. So all this process is in place. Now our question is, how is magnesium sulfate going to help in all this? And why are we talking so much about antenatal magnesium sulfate? As ma'am rightly mentioned, the MACPI trial did not happen to see how it is going to protect the baby. No, MACPI trial happened to see how it is going to help in eclampsia, how it's going to help the mother. So this was a after study actually, because they also saw what happens to the baby when you gave the magnesium sulfate, and they saw that these babies did better compared to the other babies who also had hypoxia. These babies who received MAC-SULF, they did better. Then they started correlating and seeing whether it really helped. So then other trials came. So my professor once said, actually, if you have a lot of theories about something, that means we don't know the actual cause and actual effect. So this magnesium sulfate is like one of that. We have a lot of theories how magnesium sulfate acts. That means you really do not know how the magnesium sulfate acts. So that I have to accept, because whatever I'm saying is all theory. The real way how magnesium sulfate is acting as a neuroprotector is not known. So that is the fact. So the theories are how it is going to protect us. One of the things is the magnesium and calcium, as we showed in the periodic table, they are all in the second table. They all have the similar valency and all that. That means one can substitute for the other. So if the magnesium starts entering the cell when they give antenatally to the mother, instead of calcium, before the baby is just becoming hypoxic. So you know the next step is calcium is going to enter inside. So before that magnesium goes there, this competes. So as he said, rightly said, if the hero is kind of more active, then the anti-hero naturally has to die. But if the anti-hero is going up, then the hero has to die. So one of them only can stay, not both. So that way, this magnesium is going inside and it is taking over. Now it is not allowing the calcium to enter. So that way, it stops all the process which happens when calcium enters inside the cell. So that is one way of acting, this magnesium sulfate. The other way it protects the thing is, there is no blood supply. That is why they are getting hypoxic. So magnesium sulfate is a direct vasodilator. So it dilates the endothelium. As I said, nitric oxide is kind of stimulated. Once nitric oxide, we all know it's a good vasodilator. So there is vasodilation happening. More blood is flowing, not only to the baby, more blood is flowing to the placenta also. So if more blood goes to placenta, automatically baby's health is going to be good. So both ways, it's going to be a vasodilator, so that way it helps. And the other way it helps is, it also is a competitive blocker for the NMDA receptors. So now I said glutamate is going and causing excitation. So this one actually competitively blocks the NMDA receptors as well. So doesn't allow the glutamate to go inside. So the excitability is also not happening. So when all this is not happening, there is some damage because of the hypoxia, but then it is not prolonging. So sometimes what happens is, there is hypoxia. If you immediately intervene, like what they showed for CPR and all that to resuscitate a baby, the baby had primary apnea, so immediately resuscitated. So the secondary apnea doesn't happen. Baby took a breath, you supported it, baby became all right. But if the baby came out in secondary apnea, no matter how much resuscitation effort you do, may or may not be successful. So when you give antenatally the magnesium sulfate, the fetus is compromised. They know that it's going to be a preterm delivery. Baby is going to come out compromised. But if they protected it already, and there is a criteria which ma'am also mentioned, they have to finish it 4 hours before the delivery. So they have to plan the delivery 4 hours later only, after finishing the max self. They cannot do it immediately. You give one dose and immediately you cannot deliver, because it has to reach the fetus. And if it has reached, then it has already started doing all these effects, in which case, even if the baby comes out hypoxic, max self is already there with the sword to protect the baby. So that is how the neuroprotection happens for the baby. And long-term thing, again, anything, studies, everything which comes, in my own career I've seen something comes in, and 10 years later, that is a wrong way of treatment. And 10 years later, it comes in back again and says that is the best treatment again. So we just start using it again. So anything we say, enough studies, whatever, has to be taken with a pinch of salt. So there are other studies apart from MACPI. There is a BEAM study from US, which also supported very well. That is why RCOG made it like, universal guideline that any mother as a, protection, they all have to receive. If their imminent preterm delivery is there, they have to receive MaxSelf. But you also need to know there is a French study, pre-max study, what ma'am mentioned. It showed that, it didn't have that much of effect. So what 2 things they mainly analyzed were death and cerebral palsy, and then came moderate to severe cerebral palsy. The last thing is just gross motor disability. These are the things they look for in the baby at 18 months and 2 years. So French study said, no, it may or may not help. And there is an Australian study as well. I think it's Actomax Self. So that study said, no, it's actually not at all helping. No, it is also causing adverse effect. So if you gave, there are some preterm babies who actually die because of this. Deaths have been reported. And also baby once born, NEC incidence is very high. So they die because of that NEC. So these things you should keep in mind just in case actually, because tomorrow if they reverse and say Maxwell should not be given, then these are the reasons actually why. Because enough studies have been done, but each study had its own regimen. There was no uniformity. Each one gave Maxwell as a different doses. Each one followed a different protocol. Each one checked different set of babies. Some checked extreme preterms, some checked borderline preterms also. So I want you, one take-home message what I want to give is, if the baby is, what are we trying to protect the baby from? We don't want the baby to become cerebral palsy. So what is the risk of cerebral palsy in a preterm baby? That we have to know. Between 24 weeks to 28 weeks or 29 weeks, the risk is around 14% to 17%. That is a risk. Means just being born as a preterm, they have that much risk of becoming a cerebral palsy children. The same baby, if it becomes like 30 to 32 weeks, the risk falls by half. It's only 7% risk. And after 32 weeks, between 32 and 34, it goes to 4%. And 34 to 36, it's 1%. And for a term baby, it's only 0.1%. So there are some gynecologists who are over-enthusiastic and say, all preterm babies, I will just give Maxself. So what are we going to see if the baby, mother received Maxself? We are going to get a flat baby who's hypotonic, because it's a muscle relaxant. Baby is not going to breathe. It causes respiratory depression. So baby is going to come out like a hypoxic baby only. So how do we know if it's a birth asphyxia or if it is a Maxself effect? We do not know. So we just treat it like how we will resuscitate a birth asphyxia baby. But then one thing we know for sure is, if it is because of magnesium sulfate, within 24 hours, baby will be all right, because the effect is gone, stays for 24 hours. But after 24 hours, your baby continues to be that way, then it was a perinatal asphyxia, which is going to have its consequences.
This is exactly the expert review, ma'am. You have given really like an expert, ma'am.
postgraduates, please don't take home the message that calcium is the villain. Calcium is a very good mineral. Okay, that is the reason why we are giving antenatally 2 doses, 500 mg twice we give antenatally. So the past 15 minutes what sir discussed and what we are discussing, they may take it wrongly as calcium is a villain. Calcium is actually a hero. Okay, not eclampsia is not result of increased calcium. It's not due to excess calcium. It is due to the deficiency of calcium. Understood? So it's only when there is excitability and convulsions are happening, that time magnesium will counteract and it will prevent convulsions. So please don't go home thinking that calcium is a villain.
Thank you, sir. But madam, your explanation was too good.
Thank you. Calcium is a villain only if there is hypoxia.
Yes, yes.
Thanks for clearing that. Without calcium, your heart won't contract. So.
Thank you, sir. Thanks for the contribution. Coming to, that's what, whenever there is a magnesium sulfate, be ready with intubation set. That's what, keep it ready. And further going now to the second scenario. Here the baby is going to get delivered. Like there is a 23-weeker, long-standing 10 years on the pregnancy, and that's an IVF. Now the mother is leaking, and now we are going to counsel them. How exactly the 23-weeker will appear is like this. It's exactly 23-weeker. These small lungs, those are small lungs, heart. And the small intestine, small things. And then now we are going to, because this comes under the gray zone of neonatal, 22 to 24 weeks. If they are getting delivered, this is a highly precious. 10 years onwards they didn't have a baby and IVF. Now the baby is leaking. Now the leaking, and there is a situation arised where we need to go for delivery. And how are you going to counsel and how you are getting ready for the baby retrieval? Sir? Dr. Deepika. Dr. Jagadish, sir, you can take over. 23-weeker.
So I'll take over regarding the neonatal management. So whenever we have a preterm like this, how many of you have faced such a scenario in your duties sometimes? You have some babies who have just come, mothers leaked. Yeah, all of you have faced the situation? Yeah. So that's one reason we all need to know about this session. It's a very important session. And second thing is, as students, I think you'll be at a counseling station in your OSCE. So there's 2 reasons why you should know about this session. So as far as counseling is concerned, now let's first look at how do we assess the risk. So we are going to look at the risk assessment. So we're going to look at place this baby, is it at a high risk or is it at moderate risk or an extreme high risk? So there are some factors which are going to help us to decide whether based on the gestation, based on some modifiable factors and non-modifiable factors. We're going to look at whether there's any growth restriction, is it a singleton pregnancy, or what is the gestation, what's the weight of the baby. Based on this, we are going to classify this baby as, is it an extremely high risk, or is it high, or is it moderate risk? So as this baby is given, it's a 23-weeker and mother is having leaking and is a diabetes as a morbidity. So we're going to put this baby somewhere around high risk, okay? So based on this, we have 3 levels of care. So we're going to look at whether are we going to just give a comfort care, or we are going to just counsel them and tell them, okay, we are going to be with your side and just allow the baby to pass away with your side. That's called comfort care. Or that we're going to go like highly expectant management you're going to do, or we're going to do an active management. If this baby is somewhere around 23 weeks and say 24 and 25 and above, we try to go towards the moderate risk, where we just do an active management. We try to do actively many things, thinking of a better outcome. Whereas this one somewhere falls under the moderate risk. So where we have to explain to the parents, and counseling becomes very important, and it should be a shared decision with the parents what we are going to do, and you have to balance both the outcome, the risks you take, the long-term outcome. So as far any counseling is concerned, we have various formats you do for counseling. So like you would be taught, like we have a gather format, etc. We have different, like you first greet, you introduce yourself, establish rapport. So I'm going to talk to the parents. Preferably both the parents are going to be there. I'm going to note down the details. I'm going to verify the details. That's the first step. So once I introduce myself, I'm going to tell them this one statement which is there. You're not alone. We are both are going to go towards this journey. And then you're going to tell them, do you have any prior knowledge? So have you any previous experience? It could be of a previous preterm birth, or you're going to tell them that is any of your family members have had it. So then it becomes much easier for us to explain to them. And then you're going to also look into the family background. You're going to look at the social, cultural factors, religious beliefs. Based on that, you're going to take a call and tell them that here we are dealing with a baby who's going to come preterm, and both of us are going to go towards this journey. So you start off with that, establishing the rapport, getting a background, and you ask them what is their pre-knowledge, whatever they have, a baseline knowledge. And next you try to help them to understand what is the problem. To help them to understand what is the problem, you need to start off and give them first a big picture. You just tell them that, yes, this is a baby where we both of us are going to go for the next 2 to 3 months together. These are some of the problems which the babies can have. So you're going to tell them about survival and outcome risks you're going to discuss. So that you're going to preferably ask them, what kind do you want? Do you want percentages or do you want in number? You're going to tell them about that. So if you say you have some, you can plot graphs. I think that slide has not been added. So you can tell, okay, there's a 1 in 10 chance. We said like in a 23-weeker, I'm going to say maybe there is a 4 in 10 chances of survival. So that's what I'm going to tell. And as Madam said, we will have outcome risks, long-term outcome risks. Yes, maybe 1 in 4 of this child may have a serious neurological outcome. So that's how I'm going to give them a big picture of what's going to happen to the outcome or the risk is going to happen. And then I'm going to come and tell them about problems of prematurity. I'm not going to straight away tell them there is no hope, these are the problems, these are the problems. If you start with a negative effect and give them no hope, then I think we are not going to reach anywhere. So you're going to start off with introduction, background knowledge, and then you're going to tell them about the outcome, the risks involved, and then you describe them about the prematurity problems. You can tell them start from head, these are the problems. You can tell them they're going to have immature lungs, they're going to have breathing problems. Then you're going to tell about the intestine, and then you're going to tell them each problem. And then finally, it's very important that both of you reach an agreement on a key decision making, because at the end of your counseling, you should have a plan, and it should be a shared decision between both of them. So you come to tell them, you describe them about what happens in the delivery room. You tell them the baby may have difficulty in breathing, we may have to put a tube, he needs to be on a respiratory support. And then if the baby does not make, what would be the parallel planning? And finally, it ends up with a written plan. You can give them outcome risks, you can give them experiences of your previous children in your NICU, your local data, whatever you have done, whatever happens in your unit. If you're possible to take, you're going to tell them this is what has happened. And you always tell them that babies in just like y'all would have, your babies, there were many other experiences we have had, and this is what has been their outcome. So that's why we always first introduce, take a background knowledge, help them to understand what's the problem, tell them the actual scenario, the outcome, the risks, tell them about the problems of prematurity, tell them about key decision making, and finally you end up saying that this is what's going to be our plan. And then you're going to tell them that empathy, and also hear, always reassure, and have a patient hearing till towards the end. And if there's a lot of time for you all to actually come back, you're going to say, yes, we're going to meet multiple times. We're going to talk about the same thing. This is how we are going to tell them. And finally, you also talk about mom, that is early initiation of breastfeeding, encourage breastfeeding also in that few minutes. And finally, you summarize and recap and give them a chance to ask any questions if they have any doubts. So this is how you're going to try to, you can use the gather approach, you greet them, you introduce, take a background data, help them to understand the problem, tell them the scenario, then finally help them understand the problem, and then reassure them, recap the whole situation, and finally come to an agreed equipment. So that's how I would like to go for this 23-weeker. And you can use some captions like it's a miracle, so your baby's heart beating is important. So this is how you could go for the counseling. So with regards to management, so very important that all of us know about the golden hour management. So as we know, we go to the preparation, it's very important. As in NRP, we teach PPE. So you need to have personnel trained, you need about equipment, and you need about the place. So always remember, your outcome is going to be based on whether your center is equipped with the treatment. So if you're equipped, yes, you can say, we are not going to do heroics here. So you're going to say that, yes, if there is, then there is a role for in utero transfer in these babies. So you discuss with the attenders and then take a call. See who is the senior most person who can accompany and form a team. You discuss your roles prior to your entering the delivery room. There are certain few things you do initially prior to your thing in terms of take about temperature. In temperature, if I'm looking at a 23-weeker, yes, I'm going to skip the drying. I'm going to receive in a plastic wrap. And I'm going to think about, make sure that the transport is warm. Then I'm going to make sure I'm going to be gentle from the word go. So the way I handle the baby is important right from the beginning. So I'm going to use gentle ventilation by using a T-piece. Use of a blender is very important. Use the appropriate size ET, appropriate size scope. And then we make sure that the baby is transported gently to your labor room. And very important is start early. Start early for what? So once the baby reaches your delivery room, from the delivery room to your NICU, you have an entire golden hour preparation of your NICU. What does it start? From the baby, if the baby is spontaneously breathing, you may start CPAP from the time when he's come, or if he has not had a spontaneous breathing, you would have intubated the child. Again, be gentle. With gentle ventilation with your Neopuff, you're going to carry him to the NICU. Once he reaches NICU, it's all timed now. So 0 to 5 minutes, you have finished, started your delivery room, you have confirmed your CPAP is delivering well. Then the next, from within 30 minutes, for the next 30 minutes, you try to put a pulse ox, you put an umbilical line, and then make sure your surfactant is ready. Check your GRBS. And the next 30 minutes, you're going to make sure that your lines have already been put. Now you're going to start parental nutrition. It should be proteins, about at least 2 grams in this baby I'm going to start off. Lipids, I'm going to start right from aggressive nutrition should be started. That's in the second half an hour. And within 50 minutes, most of your stabilization is over. And the last 10 minutes time, you have a buffering time. By end of first one, everybody should have an oral swab of mom. So this is very important. So this is your early first 1 hour golden hour management in an extreme preterm. So then onwards, you know that we are going to important bundles important. So you need to have, very important is your neuroprotection bundle. So you're going to take care of all bundles to prevent IVH, because your whole outcome depends upon that, especially in the first 3-4 days. Very important to follow your IVH bundle, your neuroprotection bundles. Don't try to give too much boluses. Make sure you're going to be your light, sound, developmentally supportive care starts from the time you enter the NICU. It's very, very important. Apart from the respiratory support, so what kind of respiratory support you're going to do? You're going to make sure you have continued your CPAP. We have lung ultrasound makes a lot of difference. So based on your scores, you decide, or your requirement, you're thinking of your surfactant, and whether you're using a CPAP or an NIB mode, or the baby goes in for ventilation. If at all you're going to use ventilation, it should be what kind of ventilation? Yeah, it's usually with ventilation with your volume guarantee. So that's what you're going to try to use. You make sure you stabilize the baby. Always targeted oxygen. Use oxygen as a drug. It's very, very important in your extreme preterm. Your entire staff, your unit, and your alarm limits should be set well in advance. And that's your respiratory support. So respiratory support, neuroprotection bundle. The third most important is your cardiovascular support. Make sure, even delayed cord clamping, if the baby is spontaneously breathing, it has a role. There's no role of cord milking. So once you start off there, you make sure that the baby, your follow-up with your mean arterial pressures, you are discussing about that, blood pressures, you make sure requirement of inotropes, watch for your PDA opening, and then we are going to look at adequate inotropic support as per requirement. So that's very important. And once you finish your cardiovascular support, the next important is, very important one is prevention of infection. That plays a very important role. So all your CLAPSI bundle, VAB bundle, all your infection control makes a very lot of difference, because you would have done very well in the 24 to 48 hours. By the end of first week, we are down again. And that's the stormy course begins from there onwards. So infection control bundle is very, very important. And the next most important is your fluid and electrolyte management. Very important to have a restricted fluid policy. Each unit has a different policy. You start off with 80, then you start increasing based on the weight, urine output, and the other lab parameters. Add your sodium, potassium after day 3. And very important to start aggressive nutrition. And after the fluid, it's most important to have a standard feeding regimen. That's very important. Initially, you're going to have trophic feeds, minimal enteral nutrition, and then start off and go on increasing. As per now, we are going to start 15 to 20 ml per kg and then start increasing as the baby tolerates. So by starting early, aggressive nutrition by TPN in the first week, and then following it up with rapid advancement of feeds, I think takes away most of our infection risk lines and other procedures. So I think with this targeted approach, and the last part of it is monitoring. Always monitor, anticipate complications, and act quickly. So I think with this, I think we would try to manage this preterm baby and most important and the center to all of this is developmentally supportive care. Take care of light, take care of sound, take care of noise, take care of the small things which you can do like nesting. You try to train your staff on developmentally supportive care, the skin care. All of this makes a lot of difference in the outcome. And then finally, we have to end up this with follow-up. So screening is very important. So screening right from head, eyes, heart, abdomen, the screening becomes very, very important in your preterm. So I think if this approach is there, the outcome of an extreme preterm would be much different. And we could try to, from 25 to 26, maybe we may go on, but at least I think we start off at 25, 26 as of now, and then maybe you can be brave on 23 week up. Thank you, sir. Thank you very much.
I think I just have to make a comment here with the permission of the moderator. Yeah, I think what we have left over is he has very well given a very, a nice picture of managing. Sir, listening to you, we all obstetricians will definitely feel, oh, we can handle any 23-weeker because how you explained, it is, I don't think we always have this kind of picture or scenario in with all cases. Maybe 1 or 2 babies out of 10 may go through this. But even after 1 month or 2 months or 3 months, what I've gone through is they'll keep them for 2 months, 3 months, and then ultimately the parents go with an empty hand. That is really disheartening because we would have been giving them hopes throughout. So the dilemma, since the topic is dilemma, I think I want the obstetricians to answer the mode of deliveries. Because that is the main challenge what we face when they come, because we also know it's a precious baby, they also want the baby, and we also want to help them. But they can't take the stress of inducing and delivering, and even cesarean at that point is, we can't call it a cesarean literally. Ideally going through the textbooks, it will be like an hysterotomy, delivering, because recently I got to know that while delivering an extreme preterm, there was a fracture femur when they are trying to pull out, because definitely it is fragile and small, and it was definitely not intentional. And even though by an experienced person, it can happen. So a lot of comorbid things and morbidities do happen. So decision making for youngsters, any take-home message you would just like to give them, any tips?
Ma'am, as always, it's case-based scenario,
Yes.
but extreme preterm, cesarean is the way forward, unless she's coming 7 centimeters. Even then I would be, because second stage, anything goes wrong, it will be difficult, but better to do with a senior consultant in a daytime, if possible, because what sir told, he has told the best case scenario. We don't get that kind of pediatricians in here. We have a good NICU support, but many medical colleges, peripheral centers, you don't get highly trained pediatricians at night time. So intubation, cord cannulation, all these things become difficult. And like it was told, golden hour is way more important for the preterm than for anybody else. So daytime cesarean section with a senior gynecologist. Pre-warmed rooms is must, because that temperature change affects very adversely for the fetuses.
And the sepsis, of course, with PROM already. The
Yeah.
baby is at the risk of developing chorioamnitis or infection.
Yes.
Even intrauterine infection, sepsis also may be there, which we don't know. Morning when we listen to him. So we
Yeah,
need to be
we
extremely
had
careful with that. And you should handle or deliver the baby with extreme care so that no trauma should be happening. Even a slight pressure on the soft head can definitely lead to flexibilities.
Yes,
So
and liberal incision.
Liberal incisions, yes.
There is
that
no
what-
cosmetic surgery
because
here.
as such, the lower segment will not be formed and it won't stretch. So you can't give push or pull, nothing works there. And presentation also can be compound presentation. You won't know exactly, you may not have that.
Correct.
So it's definitely a challenging thing for the obstetrician also.
Yes.
So decision making and giving them a detailed counseling from the obstetrician's point, not just about the fetus. I think we should involve and inform them all these things.
But it's just that we have been counseling mostly for 9 months, 6 months, 7 months, they would be in contact. How early can we know that this baby is going to go in for CP? Any cutoff is there like that, ma'am?
There is no cutoff, ma'am. We have to monitor them minimum for 18 months to see which babies. But there are some early markers for cerebral palsy and all that. If they show that, then it is fine. We can say much earlier. Even as a newborn, like say 1 month old, 2 month old, if they have that constant scissoring, quite a bit of hypertonia and all that, arching, all that, Those are all early markers of CP, fisting, all that. If you can see that in the baby, then yes, we can say this baby. But baby is already born. There's nothing we can do about it. So only way forward is antenatally you, so kind of when you give magnesium sulfate, inform the intensivist, neonatologist, everybody. So you're already ready to just kind of get the baby. Because again, it's not my specialty, so I cannot comment, but still I want to say, because there was this baby, not in the center where I'm working, but previously I've seen, she came in labor because she was too far into the labor. They could not do a cesarean section, though they want the baby. And they kept waiting, nothing happened actually, because she was not in pain. It's just that she went into labor and they could see the head, so they couldn't wait also. So they didn't put any oxytocin, nothing, so they were only waiting. Because they waited for 2-3 hours, they just stepped out for a minute, baby came out. So vaginal delivery, that risk is there. So if it is a cesarean, it's a controlled environment, we're all there. The moment baby comes, you can do your delayed cord clamping, we can do the intubation immediately, even delivery room surfactant immediately. Everything is ready. So naturally, if everything is ready, we are doing everything within the golden hour, within the first few minutes. We know 3 minutes only brain can sustain hypoxia. Within the 3 minutes we resuscitate the baby, I think it'll make a lot of difference.
The other point we need to add is like follow-up. Follow-up is very important. So that's why we have some neuromotor, neurosensory follow-up. So where we try to do a Hammersmith neurological examination, neonatal and then infant follow-up, try to measure angles. We have a screening of ultrasound which gives a clue that this child may be going, like grades of periventricular leukomalacia. These are the things. And most important for postgraduates is early stimulation. So very important, because by 2nd to 3rd trimester, your neurons are formed. So what is there within our hands is the synapses and the dendrites. So if you don't make use of them, then they're going to get pruned off. So early stimulation and early monitoring, as ma'am said, picking up as early as possible and giving them the best possible outcome is what we have to go for.
Madam, if, thank you, sir. Thank you, ma'am. If this is a DCDA twin and one twin is leaking, how will you approach me?
If there is infection and there is signs that this mother is going for amniotitis, we have to deliver. The indication is maternal indication more than the fetal indication, because we will not be able to salvage either of the twins if mother goes in for sepsis.
Thank you. And now we enter into the medico-legal risks. Dr. Lakshmikant, how can we protect ourselves from what is the legal framework, ethical practice and practicing guidelines?
Yeah, sir, I'll just quickly go through. Please skip this slide, sir. Yeah. So the legal framework in India, want to concentrate, the consent must be free and lawful. There should not be any coercion. And the age of valid consent, major management, either medical management or the surgery, should be 18 years. So whenever a girl or a boy walks to us less than 18 years, I always ask the mother or the father, whoever is accompanied, to come inside. Because less than 18 years, we still feel that they don't understand. 17, 15 years, they won't understand whatever the treatment we give, the dosage schedule, they may take it little extra and cause problems. So whether it is a medical treatment or a surgical treatment, 18 years is taken as a cutoff for consent. And informed consent is we should explain the nature of the management, what we are addressing, and the risks and benefit both should be addressed, and even the alternative therapies, either it is a surgery or any medical management is available, or non-medical management, any other non-medical management is available also, we can address, like physiotherapy or something like that. Okay. Then about the documentation standards, so the date, time and name, signature of consenting patient witness should be mentioned. And of late, I'm seeing when I attend medical legal cases to courts, the witnesses are telling this is not my signature. Okay, so I have addressed and I have advised all my postgraduates to take thumb impression also with that. Okay, that's an extra addition thing. And whenever you take the consent, informed consent, we generally come across our inpatient cases, one page will be filled with consent, already documented one. That is not valid in court of law. We should take a procedure-specific consent in major things. Next slide, sir. Yeah, why it matters in medical legal protection. First thing is, it is a very good evidence in court in obstetric disputes, and it supports continuity of care. Continuity of care means you can hand over the cases easily. Whatever you have documented, and there is a shift, a change in the shift, night shift like that. So if everything is documented in time, dosage, everything what you have given, it is easy to hand over. Continuum of care will be there. That is one thing. And it also demonstrates standard of care. So at that particular time, because the date and time if you put, at that particular time, what standard of care you have given, that will be dealt in court of law. Because after 10 years or after 5 years, if court of law takes this hearing, and if you are not documented the date and time, it becomes a problem, because a lot of medical legal advancement would have happened. So the date and time also should be mentioned properly. And whenever this court of law addresses this, they usually, if you have not mentioned date and time properly, they will view the thing in retrospective basis. Suppose you have taken the same instance, around 27, 28 weeks, you have delivered vaginally and the baby died. They would have asked if you have delivered by cesarean section, baby would have been alive. Okay. So depending on the care, the time and the period of care what you have given. So based on that, retrospective judgment should not be given. So this will help us with the proper management, proper time, proper date if you have put and documented. This will help in prospective management and prospective case view in court of law. And this MTP consent and requirements. Only women consent required, guardian if minor or mentally ill. This is what commonly we address. But the thing is, the spousal consent also is desirable. Okay, because to avoid medical legal problems, even the court told mandatory is the woman consent. The client consent is mandatory, but spousal consent should not be taken, it is not told. It is desirable. Even in sterilizations, in one case, husband had filed to Supreme Court, asking that I want to get one more child. You please give the divorce. I'll get married to somebody else. Then Supreme Court thought that we have to change it, and it is included in sterilization that the spousal consent is desirable. It is not made it mandatory, desirable. So whatever the amendments happening, we should learn those amendments and follow in our day-to-day practice. And this wonderful thing is shared decision making. For the past 2 years, I am following this shared decision making, especially in controversial aspects. Like Madam was asking, 23, 24 weeks, what shall we do? Less than 28 weeks. So in our hospital, if less than 28 weeks or 1 kg baby, effective fetal weight comes. So I follow shared decision making. I call them and I speak to them. So the poor prognosis is there because our setup is not like it's not a very good neonatal backup. Less than 1 kg baby, 800, 900, very rarely we could save in our setup because I work in a government. So we take shared decision making, and if they say, if they insist for cesarean, yes, we do cesarean because it avoids a lot of medical legal problems. And they also will be happy if something goes wrong. Otherwise, everything will be cast on us. Okay. And confidentiality and sensitive cases. In cases of MTP Act, PCPNDT Act, and POXO laws, we should follow the confidentiality. In the recent amendments of 2021, if we don't follow the confidentiality, 1 year of imprisonment can be done with fine. So confidentiality should be maintained. So that law we should practice. Yeah. Here emergency C-section, oral consent documented with witness. So usually if it is real emergency and no other person is there, we can just proceed because it looks like an implied consent, but otherwise generally we try to written consent and we have to follow that. And the second point is refusal of abortion to unwed women despite legal right. Here I want to tell abortion is not a legal right. There are specific conditions where abortion should be done, and for unwed women, refusal of abortion is problematic. We are not supposed to refuse abortion for unwed women because that comes to prevention of mental or physical trauma for her. Unwed woman, she may commit suicide. So that is there as a criteria. So we have to accept that and we have to oblige to the abortion. And failure to explain risk leading to litigation. We should always explain all the risks leading to the particular procedure. And we should tell them that all these risks will be there in very minor percentage. Maybe I generally tell them 1 to 2% you'll have this adverse risk, major problems. 98 to 99%, usually all these risks won't happen. So generally they accept that. Yeah, in emergencies where mother is unconscious, implied consent can be applied. Only thing is, in our practice, when nobody is there and some auto driver brings the patient and leaves and goes, so we just inform the higher authorities like medical superintendent or resident medical officer or the unit chiefs, and we'll proceed with the case. Whatever the best knowledge we have, or the best indication, so we just proceed on humanitarian grounds. Even the law will support us in such situations. And for procedures affecting fertility, I told you already. So the best practices is, the first thing is we should develop a rapport. Some doctor was clearly telling we should develop a proper rapport before managing any case, whether it is a medical management or surgical management. So we have to speak to them for 5 minutes extra to know about their place or their occupation or what other problems they are facing. This will develop some mutual bonding, and the trust, mutual trust will develop. The present scenarios, the lack of trust is a very, very important reason for medical litigation. Lack of trust. And the other important reason is lack of quality care. So lack of trust to obtain, we have to speak to them for at least 5 minutes. Apart from the routine things, we have to talk to them about their personal, and they should start putting evidence, confidence on you that this doctor is good doctor, he'll help me. So that rapport is very, very important. That is one thing. The second is, the properly communication is very important, and also you document it in written form. Written informed consent should be taken and should be properly communicated. And as far as possible, not as far as possible, always you follow established management protocols. Okay, only in controversial aspects I told you about shared decision making, but otherwise always follow established medical protocols, and this also should be documented. And whatever the language used should be clear language, understandable language in their local language, and even the consent should be taken in the local language. Okay. So then after that we should discuss that audit should be done to see what's gone wrong, and we should also train the staff about the medical legal litigations and how to deal with the breaking of death. Like afternoon session we were discussing maternal mortality or stillborn baby or neonatal death, how to break the news. All these things should be addressed to the particular staff, and adequate training should be given. Yes, sir. Thank you, sir.
Thank you, sir. Thank you very much, sir. Sir, anything you want to add, sir? Because something like you have given informed consent, sir was stressing on the understood consent. Suppose a mother came in labor, after some other person will say, suppose the labor was not progressing, and then they applied a forceps, and there was some damage that has happened, or the baby was in hypoxia. They were now suing us, saying that you could have done cesarean section. Or before applying the forceps also, whether with this, how can the mother will give an understood consent? That's where when the sir is explaining the understood consent concept.
See, as doctors, we always look consent many a time as just a signature. But today, the litigation has forced us in understanding particularly the Supreme Court judgment in Samira Kohli's case, which is a landmark judgment on consent, wherein we are now putting it out, mere giving information, though you brought out as shared decision, but the information what we are giving to the person in front of us, and here when you put out so many issues in front, and the morbidity and mortality also involved, it should be that they should have understood it. If they fail to understand, it is as a doctor I have given the information, but it has not reached. You quoted the contract law. The contract law, Indian contract law very clearly says it would be valid when what this person who has communicated is communicated in the same way that what that person has understood. So if that understanding does not happen, then each one may be looking in a different way. So that is something which in the current context, every doctor has to be very clear how to practice that. So maybe you can, after you have explained or in your sessions of counseling, whatever, you can ask them what did they what was the end result, what did they understand out of it. They will in a nutshell try to summarize what they have understood. So that way it will be a document saying that, okay, these are the things And you can again further explain, if something is not clear, that these issues are not what you have understood. This is what I meant, and these complications, you can come back. One point I wanted to make, because here it's a mixed crowd of both obstetricians and pediatricians, this litigation is not going to happen immediate. If that baby is going to sue you back, it's after they become major, that is 18. If it's a consumer case, that is add 2 years, that is 20 years. If it's a civil case, add 1 more year, that is 3 years, that becomes 21 years. So that means after 21 years is when they are going to catch you. And the documentation is the only thing which is going to be there that day. And by that time, whether you are in that place or not, or all, so the litigation is 21 years later is a possibility. You are talking about cerebral palsy, all sorts of complications. And if that person, and today it's not only them, so the legal heir of that person can also sue. And in that situation, how best should be our documentation is what you have very clearly brought out in a slide. So we would request everybody to follow that. Only one more point which I wanted to add, because all these years we were looking at as an unmarried person, if they come saying that, okay, they did not have some rights. But the MTP Act of 2021 has very clearly brought out saying that today married and unmarried doesn't make any difference. Though it was explained in the context of the contraception, the contraceptive failure, but where one way it has expanded so that it has allowed today all women we are recognizing. And post that 2021 judgment law, we also had a Supreme Court judgment, ex versus State of NCT, Delhi, where the court went on explaining it's not a cis woman, it is all women. So that means even the trans and other things, all other variants also. So that means when we are inclusive of those many variants, this married unmarried issue is not going to come in. And as doctors, we have to be very, we have to move out from what we were in a defensive practice, trying to put out the prejudices of ours. So today it's a legal right. So any woman who walks in, if the MTP law allows, so as Rule 3B points out in the MTP rules of 2021, all those provisions up to 24 weeks, you have to do it. And our point of discussion is fetal abnormalities. So for a fetal abnormality, definitely beyond 24 weeks also, if a medical board approves, so you are bound to give that right for MTP. Otherwise, reverse, there would be coming back a litigation against the doctor that you didn't follow the law of the land today. And because of you, whatever the consequences. So there are litigations, civil litigations which are coming out, recovering for the costs, whatever for the baby care and other things which are coming in. So that's what I wanted to add. Thank you.
Sir, this is called an expert opinion, sir. Because you are trying to protect us. The last session right now, sir has explained about the medical legal issues that are risk that has been involved in the obstetric practice. And in the NICU also we are facing the same thing. And what are those things and how we can be protecting ourselves? What are those issues?
Sir, thank you, Dinakar sir, for inviting and the speaker. So initially, after doing NICU neonatology course, super specialty, I realized doing so many things, saving babies, unless the only thing which saves us is pen and paper. Most of obstetric colleagues in my hospital also tell, like your case sheet is like a textbook. You are writing so much, you are putting lot of details in the case sheet. And how now I realized to make it a point to purchase always a good pen. Always I keep a good pen and keep on whatever we do, we document. See, the documentation is the only thing, and pen and paper is the only thing which can save in long run. And how beautifully we write, our handwriting matters, and how much documentation we do. It may start from antenatal period. See, the baby, before the delivery, how we counsel, how much consents we take, and during the delivery, Apgar scores, resuscitation details, and birth weight, and the intensive treatment what we give, unless it is put on paper, like if the baby is ventilated, the blood gases, and the course in NICU, if the baby system-wise, respiratory, cardiac, nutrition, CNS part, if the baby develops any medical complications like IVH, PVL, major sepsis, needs to be documented. If the baby is a very peri-viable, have a very stormy NICU course, needs to be documented. And if the same baby, initially, if the baby's plan were to be either comfort care or active care, if the baby is in comfort care also, there are chances we have seen, they revert back to active care. Initially, they would have decided for a comfort care. Later on, they'll if the baby requires only a minimal respiratory care, then the baby starts signs of improvement. Then they reverse back their decisions and they want active treatment for the baby. That time, we need to document those events and the everyday, day-to-day progress of the baby, course of the baby. And once suppose we decide the baby for a comfort care, initially they have decided the baby were to have a bad course, then we have to plan an end-of-life care for this baby, giving comfort care, nutrition, warm care, fluid management, and glucose, so that even the parent should be aware the comfort care is given for the baby, and the same details has to be documented in the case sheet. And suppose the baby gets better, the baby discharge planning, how the baby's growth has to be monitored, has to be followed up, growth charts, screening tests. Suppose the baby requires ROP examinations. See, ROP is one part, there is always, we explain to the parents, but they may not come back. We need to sensitize them about ROP screenings, hearing assessment, neurodevelopmental follow-up, developmental screening, and growth monitoring. So we need to have a good written document with a discharge summary, and the parents have to be counseled the importance of each screening test. It may be like a metabolic screening. Sometimes we do thyroid screening, advanced metabolic screening. The parents have to be sensitized about the importance of the screening tests, and they also should be aware about the developmental follow-up. See, as my colleague was telling, the need for early stimulation, early intervention plays an important role in high-risk babies. And in our NICUs also, we do risk stratification. We divide the babies into mild risk, moderate risk, severe risk. Most of the babies which are under less than 26 weeker, 28 weeker comes under high risk. So if they are less than 1,000 grams, less than 28 weeks, if they have a major sepsis, ventilation, inotropic support, IVH, those babies has to be risk stratified, and they need to be followed up closely. And written discharge document has to be provided them, emphasizing the need for discharge plan. And this baby's case sheets also we need to keep as a legal document. As sir was telling, we may do active treatment as of now, but with the documentation kept for a longer period, it may save us in long term. But I honestly feel maintaining a transparent communication with the parents, building up trust in communication will save a lot of things in our care, what I feel.
Suppose the same thing, ROP. Okay. It has been very clearly written in the discharge summary that this baby has to come this point of the time, and the call also done. And still the patients didn't turn out. And once they came back, there is a clear-cut ROP stage 3. And there is a AP-ROP stage. Okay, and then how can we protect ourselves? Because still they are going to sue.
See, today, as sir was pointing it out, I work in a government setup or a private setup, but care cannot be compromised. We have to follow standard protocol. If you are expecting that a follow-up examination is required, and you have already written in the discharge summary, but people, as I pointed out earlier, like the understood concept here also, if they fail to keep up with that, if the complication which is coming out as a result of non-follow-up of that is going to be grave or going to be risky, as like in you are looking at the retinal damage, in such situation, if you don't do a follow-up, in the sense if they miss out, whether there is an effort of calling back with the address what you have or a phone number what you have, if these are failed, there are enough number of case examples wherein there is a huge compensation put back on the doctor, saying that you have not done what was the standard of care. Even the government hospital is not shared. We have a case from Tamil Nadu wherein the case was against a government hospital doctor itself that you failed to prevent ROP, and as a result of that the child has got a damage. So it's irrespective whether it's a government or a private, every effort has to be done so that after that also if they don't come in, then the balance shifts on to the patient side. But if no effort is done, and a mere, I had asked them at the previous visit that they should come back periodically or after this duration, and if they, there is an end damage, then definitely there is some amount of civil litigation. See, criminal litigation and civil litigation are two different things. Criminally, you may not be imprisoned for it, but for the compensation, and today with the consumer court, for the deficiency of service. See, consumer cases understand the mistake of the doctor as deficiency of service. So this will definitely qualify as deficiency of service. And that's the reason why there are so many consumer cases against us. As a government doctor, you may argue, okay, there is no consumer case against me because I am treating free of charge. So there comes the litigation that health is a fundamental right, and if any party who is aggrieved of that can sue that my fundamental right is infringed in the High Court and Supreme Court, and that's where the government doctor also has to come paying the compensation. Initially the government pays and it recovers from the salary of the government doctor. So that's the situation where we are, and we need to follow the standard of care.
So just one doubt. We are doing a section for a 25-year-old weaker. They are keen on keeping the baby. How long is the documentation to be preserved to protect us from any litigation?
I already told, saying that any pediatric issue or any newborn issue, it is till they become major, that is 18 plus 2 for consumer case, 3 for civil case.
So 21 years?
Yeah, all obstetricians have to understand 21 years is your documentation period. See, that is for a routine case. That is for a routine case. For a newborn, it is an accepted principle because the newborn cannot litigate on the day one. Newborn will litigate when they become a legal status, that is when they attain majority at 18 years. And then it starts, then the Limitation Act starts. So the consumer case is 2 years and civil case is 3 years. And criminal case, there is no limitation at all. Yeah. See, this question I also receive regularly from my obstetricians also, but we have made it a point saying that mere unmarried doesn't automatically qualify as a medico-legal case. What qualifies is whether there is a forced sexual act. So you clearly document when they come for the MTP saying that this is not a forced sexual act, it's a consensual sexual act as a result of which there is pregnancy. And based on that, if the person is above 18 years, obviously the issue would not come because legally they can consent for sexual act after 18. The issue comes if they are less than 18, and that's where the situation comes. It's an married wife. I think somebody else on the previous panel also was talking, the wife happened to be less than 18. See, there the law is very clear. Any sexual activity less than 18 becomes criminal. POXO Act automatically comes. And again, don't get carried away that 18 years. So you also have to look, you are delivering at 18 years, 4 months, a full-term baby. So that means the sex or the implantation happened, conception happened during the minorhood of that. So still it's a POXO case. And we have to be very clear. We always wanted all the obstetricians and pediatricians to fight on this issue, saying that what are the dilemmas. One end we have a national program wherein you are insisting on an antenatal care, you are insisting that there should be a compulsory care for all the pregnant women. And the other end you are driving away with the teenage pregnancy being a high-risk pregnancy. And the moment I say that there is a mandatory reporting, they will move away from the therapeutic care or the hospital care. So that means we are risking. So we wanted the medical sector to represent, but though Foxy as well as IAP, we are doing it, but it's not to the extent wherein we could open the eyes of the government. All that what we wanted is there should be a protection to the doctors. The mandatory reporting, if you don't do it immediately, there is an imprisonment clause. Even the Karnataka High Court didn't spare the obstetrician who was caught from one of the neighborhood district who was caught for not reporting a mandatory reporting case. The court was of the opinion you were having a duty to report and you failed to do it. So any amount of explanation by the obstetrician failed to even give her any claim in the court. So let's be clear, let's follow the law, and within the law framework what we can practice. Yes, we all are there to help the person. So you inform the police and then you do the therapeutic care. See, currently India... Currently, India doesn't follow what the Chinese followed some time back, but China is also reverting back, and now we are finding the politicians also saying 3, 4 is something as a norm. So India, I don't think in the near future it will come of any sort, because no politician wants to dare that, though we are already occupied the #1 position in the population. So I don't think it will come. In terms of the care, we all should remember the Max Hospital case. At that time, 23-weeker, so people all felt saying that, okay, it's anyhow not going to die. But the Supreme Court very clearly pointed out, till the baby you have survived, so you had a responsibility to care. So it doesn't, if that is the analogy, then definitely the 3rd pregnancy or 4th pregnancy doesn't give any sort of a leverage to the doctor that you will not be litigated.
Sir?
Yeah.
Obstetrician, when the patient came, out of the seeing the poverty or anything, had some samples of iron or anything, and gave the free sample. And there came suddenly the reaction happened. And there are certain times there is this, pregnancy complicated. See, in case if the free sample has been given and there is something wrong going on with that free sample also, whether this comes into a law.
See, there are few companies who are sponsoring here also. See, product liability is a recognized entity in our country, but the onus of saying that it is, because you took the example from the obstetrician point of view, here they are there. We have several case laws, particularly when the free camps were going on for cataract surgery. They had given the free eye drops also, and the eye drop was the root cause for the infection, but the litigation happened on the ophthalmologist. Here also the litigation would be on the obstetrician. Obstetrician has to prove that yes, my care was correct, it is the product which was used is defective. So for which till such time, so there is a joint liability between the manufacturer of that product and the obstetrician. But product liability is an established entity, so the obstetrician will have a responsibility to prove that.
We do a counseling, but they should understand. So after 20 years, what do I have on paper which tells that patient may not remember, I may not remember, which substantiates that yes, patient has understood.
See, 21 years, it's not the mother, we are talking of the newborn today who would be, because it is the end result. As an obstetrician, you are the person who is delivering the child. The child who is being delivered has a right to litigate after 21 years, even though the mother has kept silent.
I understood, sir. Like you were telling, whatever I counsel the mother, the mother should understand. So how should I put on paper that she has understood? Maybe her signature may not signify that she has understood the things which I have told
That's
her.
what one line extra you have to add, saying that all this information was explained, and after that the patient party whom you have explained has, in a nutshell, agreed and
reciprocated back.
Reciprocated or told back the same thing, that, and that is the reason she has understood that.
So if at all language is a barrier, maybe sometimes we see some other languages, does the signature of a translator is sufficient for that?
No, both should be there. Translator
As
for
well as
as a onus for translating it, but the person also has to. Otherwise, it would be ending as translator's consent. It is not the person.
So both will suffice.
Both should do it.
Thank
Translator as a mediator for both of you and the person. So both has to be done.
Thank you.
Thank you.
Thank you, sir. Thank you very much, because this is one that is required.
Thank you.
It's you are really experts, sir, in this. Thanks, sir, guiding. And sir, Dinkar sir, can you close the session?
Okay. Rajneesh sir, can you come, sir, please? Sir, Randy, please come, sir. Sir, ready, sir? Andy, please go, sir. Everything you bring. I'll give, sir, hand over to big people, sir. Sir, Biru Randy, Nilchukondi. Hospital. Who are you? See, just everybody come. Ram, bus, you are a young boy, man. Come. Come. Prashant, the barbecue. Ram, come. Okay, how many people knows Ram? Yes, 1, 2, 3. Kindly just okay. How many people know, sir? He has come for our new hemodynamics. Okay, one, sir, me
Yeah.
Say.
It's a great evening. We had a long session on perinatology, very detailed and very useful session to every one of us, both gynecologists and neonatologists. Dr. Dinakar is making all such efforts to make academically refresh our knowledge and to improve the knowledge to the extent that is needed for every neonatologist and gynecologist. Neeraj is working very hard on this, and Nirmal is working very hard on this with Dr. Dinakar, and Hashita, she's doing her best to conduct these meetings very promptly and very nicely. We thank Neonatal, Dr. Dinakar, Dr. Neeraj, and everyone who has attended this and all the lectures for giving us such a beautiful feast to every one of us. I am Dr. KSPN Verma, practicing neonatologist and pediatrician from Palakol, Andhra Pradesh. I am managing director of New Life Hospital. We have all the branches: pediatrics, neonatology, then gynec, obstetrics. No, not like that. Yeah, academically, you are all excellent. Every one of you are very good, and otherwise you would not have stayed till this time. That itself says that you are all very nice, and academically you want to give best service to the patient, and you want India to develop to the highest technical expertise, which is very much needed now in India to be the leading power of the world. I am thankful to each and every one of you, especially Dinakar sir, Neeraj, and Hashita, all the panel members, lecturers, students, and all the practitioners. Thank you very much for giving me such a beautiful opportunity. Have a nice time, sir.
Okay, and now, sir, in the last word in the head.
Feedback is 5 stars.
Thank you, sir. Now, may I request Mamata madam, please come in the center. Okay, madam, you are sitting almost from 12 o'clock, I think
so. This is always what obstetricians wanted, because we always want pediatricians or the neonatologists to be a part of our practice, especially in decision making, because when we combine and together we counsel the patients, I think they understand more
and decision making becomes more easier, and our management and half of our work becomes less, because prior to delivery what we take care, and after delivery when we hand over the baby, they still come back to us asking about the baby, what did he say. So I think it is always better. We also know what happens after birth and what care the baby needs, everything. So it was a wonderful session. I think now I have got a new idea that I can go back and ask our neonatology team to start a perinatology conference so that we can invite Dinakar sir and his team to come and guide us. Thank you, sir. It was an excellent session and a good conference. Great.
First of all, Neo Gurukul, we created a platform because we wanted academics to be neutral, not to be branded only to any specific hospital or things like that. That's why we have come up with Neo Gurukul, so that everybody can freely participate, because we have been doing neonatal teaching with a free mind and free heart, with an intention of spreading the knowledge. So Neo Gurukul, from last almost more than a decade, every year we are doing international conference and lot of CMEs, lot of workshops and CMEs, and we were the first one in India to start point of care ultrasound training course. After that, many people have followed in Pune, in Gujarat, everywhere.